Is Good morning. I am Matt Fruman, Ward 3 Council Member and Chairperson of the Committee on Human Services. Today is Thursday, November 6th, 2025. We are meeting in room 412 of the John A. Wilson Building and on the Zoom virtual platform. The time is now 11 a.m. I am joined by my colleagues, Chairperson of the Committee on Health, Christina Henderson, and Ward 7 Council Member Wendell Felder. Today we are together with the Committee on Health conducting a joint public oversight roundtable on behavioral health supports in local housing voucher programs. I deeply appreciate the work of Councilmember Henderson and her excellent team in preparing for today's roundtable, and I am grateful for their partnership. The Department of Human Services, or DHS, administers the Permanent Supportive Housing, or PSH, program. PSH provides a housing voucher and intensive case management to residents who are chronically homeless, have limited potential to earn income, and suffer from chronic disabling conditions. PSH clients work with case managers to develop personalized treatment plans, and they are supposed to have at least 2 monthly contacts with caseworkers, including a home visit. The district has invested significantly in supporting PSH households, and the services available to them should be robust. DHS and its case management providers partner closely with the Department of Behavioral Health, or DBH, to support PSH clients who often rely on DBH-regulated or DBH-contracted services. Case managers refer clients to DBH-certified community-based substance use and mental health providers. They also rely on DBH-certified multidisciplinary assertive community treatment, or ACT, teams. ACT teams comprise of psychiatrists, nurses, vocational specialists, and other supportive professionals provide person-centered treatment to residents with severe mental illness who have disengaged from treatment. Despite these investments, PSH clients and their neighbors across the district find that PSH households are not always adequately supported. PSH clients report going months without hearing from their caseworkers. Case managers report struggling to focus on each of their clients when they have such high caseloads, and property managers report having nowhere to turn when clients have mental health crises in the middle of the night. When voucher households are inadequately supported, it's not just beneficiaries who pay the price, but their neighbors. My office has been supporting one longtime resident whose chronic health conditions have been aggravated by a neighbor's public use of illegal drugs. When she reached out to her neighbor's caseworker to see how they could be better supported, the caseworker dismissed her concerns and declined to intervene. Other residents report being kept awake by their neighbors' screams, having to call the police to respond to repeated instances of domestic violence, and being unable to use common areas that have become sites of criminal activity. The executive has not intervened in any of those cases that have been referred to us. That is not normal, and it is not acceptable. Neighbors of residents in PSH have told me that they want to support their neighbors, and I know they are trying. They are reaching out to caseworkers, helping with diapers and food, and advocating for their communities across the district government. Supporting PSH clients, however, is the responsibility of the district, and we need to do better. We must acknowledge that the focus on making concrete changes to a system that is not working in the way it should for all of our beneficiaries and their neighbors. When it comes to public safety and their mental health in PSH, DHS's position has been that their hands are tied. that only housing providers and MPD are accountable for the safety and well-being of voucher clients and their neighbors. That position must change. Everyone involved must accept accountability. In the past 2 years, 6 children in DHS PSH households have passed away. MPD data shows that violent crime and child welfare reports have increased several times over in police service areas with high concentrations of voucher holders. We cannot ignore the reality of what our residents are experiencing. This is not to say that I'm not deeply grateful to DHS and to our housing providers and to our caseworkers for all you do to help PSH families. I am. And I recognize how hard this work is. Today gives us a chance to hear from each other without judgment and to work together to find solutions. That conversation must start by acknowledging that solutions are needed. Today we brought together PSH participants, their neighbors, housing providers, service providers, subject matter experts, and the district government leaders, including the leaders of DHS and DBH, to discuss the changes we need to see. Today, I'm looking for new ideas that take us beyond the status quo. I look forward to hearing how we can make permanent housing truly supportive housing so we are able to provide housing that is safe and sustainable for all district residents. I will now turn to Councilmember Henderson, Chair of the Committee on Health, for opening remarks.
Thank you, Chairman Fruman, and good morning, everyone. Today's discussion is not just about whether behavioral health supports exist within the district's permanent supportive housing programs or housing voucher system. It's about whether these supports actually work. For residents living with serious mental illness or substance use disorders, the period between receiving a voucher and moving into housing is not merely an administrative delay. It's a vulnerable time when symptoms can worsen, trust can erode, and progress towards recovery can stall. A behavioral health housing voucher should mark the beginning of stability, not another chapter of uncertainty and/or crisis. As the district's behavioral health authority, the Department of Behavioral Health, DBH, has a responsibility to ensure that its processes reduce harm, support engagement, and connect residents to care in trauma-informed and person-centered way. Yet we've heard repeatedly that while the district's coordinated entry systems function well overall, behavioral health considerations are often left out of those assessments. This disconnect means that individuals are often not matched properly with providers who can meet their needs, particularly those who would benefit from assertive community treatment, ACT, or intensive case management services. We know that much of the infrastructure already exists. ACT teams, community support workers, single-site housing programs that pair residential stability with on-site medical and behavioral health care. The challenge is ensuring that those resources are used effectively, matched appropriately to people's needs, and certainly sustained over time. Housing first was never intended to mean housing only. It was always about pairing permanent housing with individualized, high-quality support that help people recover, reconnect, and thrive. I look forward to hearing from today's witnesses about how the system is working in practice. Does it truly support recovery and long-term stability? Or are there too many individuals still caught in the cycle of crisis, hospitalization, and homelessness? Our shared goal must be to ensure that permanent supportive housing in the district is not only permanent, but again, supportive, responsive, restorative for every resident for which it serves. So thank you, Chair Fruman, and I look forward to today's conversation.
Thank you, Chairperson Henderson. I turn now to Ward 7 Councilmember Wendell Felder.
Good morning, everyone. Thank you, Chairman Fruman and Chairwoman Henderson, for convening this morning's joint roundtable discussion. We know that the district's public supportive housing voucher programs are a vital resource for residents across the District of Columbia. These programs play a critical role in contributing to the city's goal of ending chronic homelessness and are particularly important given the significant number of PSH participants who are experiencing mental health challenges and substance use disorders. But we know to make sure our programs and services are actually reaching the people who need them the most. When we look at a place like Ward 7 specifically, we see that homeless families are starting to leave downtown and relocate to places like Minnesota Avenue and Benning Road. We need to understand if this is because there's a disconnect in services and how providers are responding to our most neediest families. The effective delivery of these services and behavioral health supports to vouchers, households is a prerequisite to safety, stability, and housing to ensure that we are protecting our most vulnerable residents. However, it's clear that the support currently being provided is limited, and when these supports fail, the consequences are dire. Hundreds of PSH households have opted out of case management entirely, leaving them at an additional disadvantage. Delays in inspections and leasing leaves units empty and people unhoused. And when tenants lose housing, they can end up cycling between shelters, hospitals, or the justice system. Within the Home First Housing Voucher Program, voucher households, neighbors, and property managers report many of the same challenges. These challenges are aggravated by the informed administration of the Home First program, which is managed primarily over email and results in significant delays, loss in documents, and unclear lines of communication. It's our responsibility to explore how we can strengthen collaboration to better meet the needs of residents receiving district funding housing vouchers. And I look forward to today's discussion and exploring solutions to ensure that our residents receive the level of care, engagement, and supervision they so desperately need. So with that, Mr. Chairman.
Thank you very much, Councilmember Felder. Before we hear from public witnesses, I would like to offer a note on logistics. I ask that all witnesses limit their testimony to their allotted time of 5 minutes. If you are here to testify in person when your name is called, please take a seat at the table in front of me. Before you speak, please make sure to turn on the microphone in front of your seat. If you're testifying on Zoom, I will call your name when it is your turn to testify, and a member of my staff will make you a panelist. If you wish to appear on video, you must click the button in the toolbar at the bottom of your screen that looks like a video camera. Please remain muted until it is your turn to testify. When it is your turn to testify, please unmute yourself. For any technical difficulties, you can send a message to the host, who is labeled as Committee on Human Services, and they will follow up with you. Our first public witness is Dr. Sam Tsimberis, and I would invite him to be elevated as a panelist. Mr. Tsimberis is perhaps the originator of the Housing First model, and we are very, very grateful to have him as a witness today. Dr. Tsimberis, I turn it over to you.
Thank you very much. It's an honor to have a moment to speak to the council members, and so I appreciate it. And I was very heartened by the preliminary comments you all made, because it says to me I don't need to explain Housing First. Everyone is quite well versed in it. And I'll just jump directly to the observations about that have already been made, but I'd like to make maybe some connection between what has been said and what might be possible remedies. The first thing I'd like to clarify is that when this program, Housing First, is actually not about housing. This program is actually about helping people who have mental health and addiction challenges and other health problems. And the entry point, ideally, for a Housing First program should be the case management, intensive case management, or ACT team that is going to be the provider of services for the person after they're housed. the way that the program in a hurry to end homelessness has been implemented is overly focused on the immediate provision of housing and then essentially retrofitting the support services after the person is housed. Not only is that model challenging in the spirit of relationship forming, but it's also difficult to establish relationship once the person is housed and feels like they don't need services. The service availability for Housing First has to match the needs of the client. That's one of the program principles that makes the program successful. I mean, just as a sidebar, and I think you all know this, this program is very successful. It houses people that other organizations or other models cannot successfully house, keeps them housed 80% of the time. That's only if the program is operated correctly. So when I talk about the principle of matching services to needs, if you're housing someone that's got multiple problems and diagnoses, you cannot have a caseload of 1 to 20, as someone mentioned, or a college graduate, well-intentioned person who is a case manager for 20 people. So the ACT team or the intensive case management team bolstered would be a better fit. The fit between the service support and the client is essential to the success to reach that 80% housing stability. Even when it's done perfectly well, you still have 20% of the folks that struggle and need other interventions beside Housing First. So that I don't know that we want to focus on the 20% who aren't working and consider, this program isn't working. The question is, how do we improve it so that everybody is doing 80 or 90% or better? The support services are not only for the tenant, but they should also be for the landlord. Anybody participating in a Housing First program should have a number to call. The final thing I want to say is that it's not just DHS or DBH. Those are the essential players, but we need to have a larger community of practice, the landlord community, the business community, the faith community, all convened by the city council or the mayor's office. So as a community, we're all on the same page about what to expect, what Housing First is about. It's not about housing only, it's about housing and a lot of services, and hold ourselves accountable to provide the services and have the outcomes we expect. There are issues in referring people to ACT teams, for example. There's an overemphasis on serious mental illness as a diagnosis. So there are bureaucratic administrative barriers in the practice at DC currently that could be improved by taking on a systems approach, all of it aiming towards a Housing First, flexible services, around the clock support if needed, 7/24 on call. But I think that the pieces are there. The program is vast. You're clearly well informed on the model, and I think with some improvements, it could be made better.
Thank you very much, Dr. Simbaris. I'm going to start with questions. I think with Dr. Simbaris, we should start with 10-minute rounds. Thank you very much. And really, really appreciate your testimony and the spirit of it. The spirit of it is like the spirit here on the dais and in the room, which is we want this program to work for people who have needs. And then the question is, how do we make it work the best that we can? And I know you have a concept called fidelity, and I'm curious if you could speak to how you measure fidelity to the model, maybe some reaction to fidelity to the model here in the District of Columbia as you have heard about it, and then what kinds of results do you see when the model is adhered to with fidelity, and perhaps with an example of a place that you see as a model?
Fidelity refers to the degree to which Housing First programs are actually following the protocol. Housing First is what they call an evidence-based practice, which means it has been tested across multiple geographic regions with different populations, and in over 26 papers reporting on randomized controlled trials about its effectiveness. But the effectiveness is only achieved when program fidelity is high. There is a checklist that looks at the principles of Housing First: choice, separation of housing and services, matching services to needs, as I mentioned, having a community integration approach. And that checklist is what we use when we visit programs, talk to clients, talk to staff, and observe the work that's being done, and it's scored, and that score reflects the fidelity of the team. There are about 40 items, and the Housing First programs range from 20 to 35 on this scale. The one thing that we've learned from the research on fidelity and outcomes is that the higher the fidelity, the more that the program is actually operating in the way it was designed to, the higher the housing stability, improved quality of life, less use of acute care services, as someone mentioned about people cycling in and out. People stop cycling if they have the supports that they need. So that's how program fidelity is assessed and how it relates to program outcomes. In the district, several people mentioned providers doing this or providers doing that. My experience in the district, I started the Pathways to Housing DC program many years ago and was part of that for about 10 years. And so I'm very familiar with the district's work, but I don't think that to say providers is a fair description of the service support system on the nonprofit side or on the DBH side. There is quite a lot of variation in the extent to which providers understand the model and practice it. So we could be calling things, all kinds of programs, Housing First. Oh, they're part of the Housing First program. And yet the actual program being delivered is a low fidelity program, and people are having more problems. So that I think the fidelity is an important issue. And if we're thinking about system-wide interventions that would improve outcomes for Housing First and reduce the number of troublesome situations, and I want to say just point blank, we're never going to eliminate problematic situations. The model is not like 100%, it's 80%, or if you do it really well, 85 or even 90. But we're going to have troublesome situations, and those should not be the guiding principle for policy. They should be outliers, dealt with absolutely, but we're never going to have a perfect fit. But so I think just to manage expectations, but the system-wide intervention would be to have the providers participating in Housing First, both as housing providers and as service providers, make sure that everybody understands the model and is practicing it effectively and is resourced sufficiently to provide the kinds of services that are needed. So I think there's room for improvement there, both in terms of interagency collaboration between DBH and DHS and others. And I think that would go a long way to help systemically make things better.
Okay, well, thank you very much for that. One of the things that I think you said is, in effect, there are two things that are mandatory. One of them is adherence to the lease, and another is participation in case management. Can you speak to those requirements for a Housing First model that have fidelity, and what kinds of things are done to enforce those?
Yes. Well, adherence to the lease is exactly the same adherence that any of us would have when we sign a lease to rent an apartment. You know, in terms of the hours, the paying the rent, keeping the conditions of the apartment, the way that we rented it, making sure that other people are not staying in the apartment when they're not on the lease. You know, the standard lease requirements, which is for some people a high bar. The support services take different forms. Tenancy support is helping the person understand what the requirements of the lease are. And when there are problems and the program needs to work quickly with the landlord to address them. The people don't move into one apartment in Housing First and stay there and live happily ever after. Many do, like 60%, maybe even 70%. But the 80 or 90% housing success rate I'm talking about does require the program and the person to allow for mistakes. Relocations are part of the process in Housing First. 20-30% of the time the person moves into the first apartment, they can't say no to their friends or family members, and then they're violating the lease and they're evicted. They learn a painful and expensive mistake from that mistake. But then the people who go into a second apartment actually have a higher level of housing stability than they go in the first time, which says to us from the data that people learn by their mistakes, just like we do, and they're much more careful and better tenants the second time around. So that's adherence to the lease, and I think a commitment to work with landlords very closely. Landlords will tolerate problematic situations if they know there's a number to call and they're not taking on the problems of this tenant alone. So that this idea of, we can't talk to you about the tenant is not an acceptable idea. We're not talking about their, psychological issues. We're talking about their tenancy behavior. And I think that needs to be a collaboration strongly with the landlord to avoid eviction, to work out problems, then the landlord feels supported. That's actually a huge help to have other landlords join and rent to us. The requirement for a home visit needs to be discussed right up front. I was a little shocked, actually, when somebody said some PSH programs are opting out of case management. I don't even know how that's allowed. How is that even ethical? How could you put someone with a mental illness and an addiction into a place and not have someone look after them? The responsibility of the Housing First team is to make sure they're making those home visits as frequently as necessary. This is not a coercive program or, outpatient mandatory commitment. We have to have clinicians on the team that understand how to engage people. We've just given them an apartment, so they should be happy to see us. There's something wrong if they don't allow you in for the home visit. And the expectation should be right up front. And this is something is very troubling to me because HUD has it wrong from the very beginning about this idea of choice. Yes, people have a choice to participate in a treatment or not, but they never had a choice from the day the program started about that home visit. The home visit is absolutely mandatory. So, but it's up to the Housing First staff to figure out how to make it happen. And so that's a bit of an art, but very manageable. But at the bottom line is, we're going to have to see you because that's what we agreed to right at the beginning. Those two conditions help to bring structure and supervision and the kind of support that make the program a success.
All right, well, thank you very much. And you stuck the landing and finished right at the end of my 10 minutes. So I will now turn it over to Councilmember Henderson.
Thank you. Thank you, Dr. Sombreros, for being here, even though we know that you're traveling. I want to pick up on something that you were talking about, which is something that I have had questions about, and we've had questions about for DHS in the past, which is the voluntary nature of the PSH program to allow for folks to participate in the services part or the supportive part of the program. So if a client opts out of says, I don't want to do the home visits, I don't want to do the group meetings, I don't want to do the check-ins, et cetera, I've been trying to figure out how then someone is still able to continue to participate in the PSH program if you're not going to if you're not going to participate in the supportive part of the program. And it sounds like what you're saying is, how is you two are questioning sort of the opt-out nature of some of this.
Absolutely. I I don't see I don't see how people can opt out of the home visit. The treatment is a different issue, right? It's not a program that requires treatment, but it is a program that requires a home visit so that relationships are built. People need all kinds of things besides treatment. We, as treatment providers, talk about treatment much more than the tenants. Tenants need a ride to the store, money for groceries, to see their relatives, the utility bill's too high. I mean, people have, a lot of issues that they want to work with, and the team is there and helps them in the order that they want. We have found that treatment works much better, like it does for all of us, when we see we have a problem and we go voluntarily to take care of things. And it's not unusual, by the way, that someone moves into housing and says, I thought my problem was homelessness and that's why I was drinking, but now I'm in this apartment and I'm still, I need a little help with this.
Yeah.
So that's a great moment, and the housing does help with that. So you're not required to take treatment, but the ongoing relationship allows the person essentially to determine the kinds of things in the priority that they think is important to them. And that's more of the relationship building. And they come to see the case management services as helpful and useful, which keeps it going. Now, going to groups is a different story. We never required things like going to groups. If we had a community group or any self-help group that we would operate, that was voluntary. We suggest things. We suggest people go to treatment. It would be better. What about this? And have you thought about that? What was the last time you were taking medication? Was that helpful to you? So it's not a passive kind of laissez-faire, do what you want. It's a very active effort to engage people in what we think is good for them, but leaving them enough room so they come to it themselves.
Yeah, I hear you on that. I do feel like there is a perception, though, that the program has allowed for a lot of laissez-faire approach, particularly if a person who's enrolled in the PSH program is not in a single site place. And I actually want to ask you about that because in your testimony, you talked about there needing to be a larger community of practice beyond DBH and DHS and the case managers. And you talked about, right, the landlords and the property managers being a part of that. But some of the tension that we've had here in DC is where you have someone who has a PSH voucher who is in a traditional commercial apartment building complex situation, right? And I don't know that we have an army of landlords who would sign up to say, yeah, we could do 20 to 30% relocation and we'll call the hotline every time we need to and sort of do this excessive, intensive case management style work for a particular client. So I guess my question is, does a program like PSH work better when it's a single site versus an integration where someone might have to travel to see a case manager or services, et cetera, as opposed to just coming downstairs?
Yeah, that's a huge philosophical question, to tell you the truth. And my own bias is that we want to drive the program by client choice. And in our experience, when you have someone who's homeless and you can show them a program that says, oh, you have here 30, 40 people who were formerly homeless living in a place of their own, services on site. How do you feel about that? Most people would choose an apartment of their own in the community because they don't want to be identified as living in a building with formerly homeless people. Because once you have that lease, you're not, you don't want to be part of that past. And so people want to have just an ordinary, affordable, decent place in the community where they feel like everybody else. What also happens when you drive the program by choice, you get more people living in scattered site, we call, the apartments in the community housing, and you're purchasing without actually having to pay a dime for it. a kind of a normal community where people like, see each other, good morning, how are you? Like there's a kind of a neighborhood feeling to the housing that is not program housing. Program housing feels different and is different. It's like everyone is, the neighbors are struggling. You have 40 people with high emotional needs. It has a kind of an institutional feel to it that doesn't promote a lot of recovery. Like I started saying, this is really not about housing, but it's about recovery.
Yeah.
So if your goal is to have people get their lives back, it's easier to put them in a place where this is what their life would be if they had it back already. So you're already in the graduation program as opposed to having to go through the other. I don't know.
I hear you on that. I would also
Yeah.
say though, so there's another program that is not related to health. It's related to education. It's called Posse.
Okay.
It's a Posse scholarship program. And the whole idea of that is that they have a group of students who go off to school together.
Okay.
So that you have a supportive system within the larger system
Yes.
of a university. And I think some of the cases that are perhaps more high profile or incidents that we've had in DC is where you have someone who is in a scattered site
Mm-hmm.
and they're kind of there by themselves.
Yeah.
They've also opted out of some of the other traditional supports, et cetera. And then that's when you're kind of having some of these more issues. And so I guess
Yes.
it's not to say that it shouldn't be a single building, but if there were like 3 or 4 other people in your building of 400
Yes,
or however many,
Oh no, yes.
that could provide some support within the larger system. I guess my question is around
I totally agree with you. And we don't do like one apartment per building. If we do 10 to 15% of the units, it's fine to rent. Okay, it's like that integrated housing model. So if it is a building of 100 units, having 10 or 12 or 15 people in that building is not going to disrupt the whole character of the building. It's still overwhelmingly people in the neighborhood, with some people with sort of special needs, if you will, as part of it.
Yeah.
And so you're touching on a huge point. That's why I was saying it's a huge philosophical issue, because people are like lonely in the apartments, and it takes work to connect them back up to a faith community or a social community or somewhere where they have, you need more than the case manager who's visiting you. Even if they're visiting you 4 times a week, it's like still a lot of downtime. So this community integration piece is really challenging, but hugely important to do in the scattered site. Some people think, well, if you put people into this one building, they'll become a posse or work out. It works out that they're not lonely, but people are not socializing with their neighborhoods. They're not with their neighbors in those buildings. There's a lot of, it doesn't alleviate the loneliness. They're definitely not living alone, but I'm not sure it meets the emotional need of the support and friendship. But the thing is, we need both models, because some people, even after you try 2 or 3 times in the apartment, they can't make it.
Yep.
They'll need something supervised. So I'm not saying one or the other. I'm just saying the pluses and minuses of each.
Okay. My last question to you, in other cities, like if you had to pick a city that was like a gold star in terms of application of the model as you envisioned it,
Yeah.
who's your gold star?
Okay, well, my gold star today is, I have 20 seconds for this. My gold star is the city of Milwaukee. Organized by the mayor and the county executive, they put together a housing first approach for the city. They had the district attorney, the police, the business community, the faith community. They set targets for themselves each year, accountability for the housing first programs, and they did extremely well. It does take a whole community approach, and so that people aren't arrested, but they call the Housing First program. It needs much more coordination than we're actually putting into it. And why I like Milwaukee is that they have achieved this level of coordination.
Okay. Thank you so much for being here, Dr. Sambaris.
Thanks for inviting me.
Thank you very much, Councilmember Henderson. I'm going to follow up on a couple of things. I just want to tease out things that I think you talked about in your testimony and you talked about in response to Councilmember Henderson. One of the questions I had, and you talked about, well, it might not work for the first time in one apartment, and so we shouldn't be shy about moving someone from one apartment to another, that there are lessons learned from that. There can be gains in different kinds of ways from just the accountability of that. I think in your last reference, you may have suggested that you could do that once, twice, but it may also be that the third move or the second move is to a place with a higher level of supervision. What, did I hear that right?
You heard it absolutely correctly. And one of the questions I've been getting for like the last 3 decades, is it? How many apartments, people want to know. And it's almost a question of hope. Like, people do change, but if you're noticing that the person's going through it and the same disaster is happening over and over again, there's no point doing the same thing and expecting a different result, right? It would be just like going back to the old, let's get treatment first and then they'll get housed. But people never got housed because they couldn't complete the treatment when they were homeless, and they just kept trying the same thing. So we don't want to be in that position. We want to figure out, if it's not working for them with this, we have to do something different. And that's certainly an option.
So I hear that on coming out, and I wonder if you can speak to this on going in, because there's an evaluation done to determine what level, what's the appropriate response to support someone. And there
Yeah.
may be a determination that a PSH voucher is the right answer for this person. And I do have questions sometimes about how well we're doing that measure, because then we find some number. For many,
Yeah.
many people, it is successful, but for
Yeah.
some number, it doesn't work right out of the box. And you kind of talked about the acceptance of case management as being a prerequisite, but once somebody has gotten an apartment and somebody new comes and knocks on their door and says, I'm going to be your case manager, it's
Yeah.
harder to get the acceptance. So to what extent is it important in the model that folks who probably should benefit from a higher level of care at least go through a transition process before they get to independent living, and that a condition of the grant of the apartment in the first place is acceptance at least of case management and home visits?
Okay. These are they're great questions. Um, I have to say that the measures, I don't know if you're referring to the VI SPDAT or other kinds of measures like that, um, frankly, quite disappointing in their ability to predict. They have very little predictive validity, and they have very little validity even in terms of assessing the person's level of need, because there are biases, gender differences, racial differences in the response to instruments like that. In the in one of the randomized controlled trials, we looked at all of the baseline data of almost 2,000 people that went either into housing first or the treatment as usual model. And after 2 years, we thought, oh, we could look at the data for who did well in housing and then look at that baseline data. And then we could come up with a profile at baseline to address exactly what you're talking about. On the front end, could we get the characteristics, and then we'll save ourselves enormous headaches. When we did the regression analysis, we could only predict correctly 3% of the time, meaning zero. The only way we're going to find out if somebody is what level of services they need, and is to put them into the situation where they're housed and then learn about them, because the way the person is and lives and thinks when they're on the street is very different than when they're at home. And that goes in both directions. Some people, you think, oh my God, how's this person going to be in an apartment? And they come into an apartment and they do spectacularly well. Another person who's like on the streets but so organized, goes into an apartment and they don't do well at all. So I mean, I wish I knew the answer to that question or had some instrument that could predict, but frankly, we can't predict. So we have to just take, chronic homelessness, additional conditions, the kinds of clinical data, frequent use of the service system, like real life data, not a 5-minute assessment thinking we could do a quick and dirty prediction of who will do well and not. But with real administrative data, you would be able to at least select the people who were vulnerable enough to qualify for the program.
Okay,
Once you,
that
well,
is, yeah. Go ahead.
I was going to try and address your second point about why should they accept a second person knocking on the door after they have the apartment. I would say that's not the way the program should work. If you are accepted to a Housing First program, then you should meet the case manager who's going to be visiting you in the apartment before you get into the apartment. In fact, that person should, from a practical level, have the keys and let the person in, so that person going to the apartment sees that their case manager is the one who gave them the apartment. That creates the relationship. When I come and see you the next day, you're the guy that gave me the apartment. Of course, I'm going to open the door for you. So this like systemic disconnect and handing people off from outreach to coordinated entry to this. It's just it's people are not FedEx packages. It's not like handoffs work. You need the continuity, and the key point you can have handoffs, but the key point on Housing First is that the person letting you in has got to be the same person who visits you the next day.
Okay, super helpful. Thank you very much. And the takeaway that I have from the first part of that is, and it kind of goes to your point that there's going to be some mistakes that happen here. The question is minimizing it. And so
Yes.
the predictive tools may not be great, but then we still need to be nimble and firm in enforcement of requirements going forward, particularly since we know going in, there's going to be some level of mismatch that occurs. A different thing that you talked about indirectly is when you talked about a 100-unit building and you said 10, 12, 15, maybe that could be great, that could be a community, but I think you've also spoken to that it shouldn't be over 20%. And we have a challenge here in that we have source of income. There can be no source of income discrimination, and so there is no way to manage the number of folks in a building benefiting from these programs in order to get to the kind of balance that you're talking about. Can you speak to why it is you think 20% is a right number and what folks in other places do to try to make sure that we don't oversaturate any individual buildings?
Well, I don't know that the 20% is, we haven't looked at that. It's a rule of thumb almost from a common sense property management perspective, and looking at housing authorities that look to balance the composition of housing authority operated buildings. And they vary between 20% and 30% and even 40% high needs. And so the thing becomes from integrated to more like looking like PSH. So there's no, precise point. We have found that 20% works well because, again, it's the balance of the building being primarily people who have financial issues, but not necessarily other challenging and symptomatic, publicly visible kinds of issues. I guess the best way to manage the composition of a building is it requires a detailed knowledge of the landlords that you're working with and the buildings that they're operating, so that from that information, the collaboration with the landlord, you would want to know. I mean, if your organization's bringing in 10%, but the landlord has rented another 20% to another organization, I think you'd want to know that going in, like what kind of a building am I working with, but there isn't a quick and easy answer to that other than a collaboration and with the landlord.
Okay, appreciate it. I don't want to go too far over, but I want to ask one last question about a different topic, which is home visits. And I think you've spoken to the importance of home visits. I'm curious what you think is the appropriate number of home visits, though it may differ, I would say, I would imagine based on the circumstance, but also what should happen at those home visits, whether or not it's important that the case manager lay eyes on any children in the unit? Is it if somebody has been subject to, been involved in a lease violation or other kind of inappropriate conduct, whether the number of home visits should go up? Can you speak to how we should be thinking about managing home visits and what we should be expecting from those home visits?
Yeah, you're absolutely right that the number of home visits is variable and depends on what we learn from the very first visit with the client. I mean, if the home visit gives you a tremendous amount of information in terms of scanning the environment, how the person has set up the apartment, what their kitchen looks like, what their bedroom looks like. So are they managing that piece of it? You also want to see how they're doing in terms of the use of the apartment. Do they have they moved in? Have they personalized it? Over time, you want to know that there's food in the pantry, the stove looks like it's been used. You're also getting to know the person. And so you can, like we know our colleagues and our friends, like you can tell from their expression or the way that they're carrying themselves or their tone of voice, are people doing okay or, are they struggling? So the home visit gives you an enormous amount of information. And that will determine, should I come back like tomorrow or is this person okay? I can come back next week. What we typically say is, this is not Section 8. This is Housing First, and there are home visits. We'll see you, next week. Like if people move in, frequent visits, they have to set up. And then, you settled into a pattern maybe once a week. But if there's a crisis, it escalates 2, 3 times a week. It depends on what you see, and you want to titrate the visits flexibly to be on top of the needs of the person that you're seeing.
And then I'm going to go just a little bit longer, and then we'll be able to let you go. But one of the things I think you mentioned was you saw references to case managers having 20 clients who they were serving, and I think you were surprised about that. What do you think is an appropriate client level for case managers? And again, recognizing that it may differ, that if you have a very high needs client, if you have 5 very high needs clients, it might be one thing, but
That's
if you can speak to that.
Well, I don't know if you've worked in a mental health agency, sir, but you certainly know all of the criteria that people use to set up case management caseloads. There is a kind of a sense of a client acuity. Like if you have very high acute need clients that are requiring frequent visits, if you have 10 of those on your 20-person caseload, it becomes overwhelming. So you want to balance the caseload number by the intensity of need of the client. I mean, both of those are considerations. If you are housing people who have been chronically homeless and have mental health and addiction issues, 20 is not only overwhelming, but the case manager only model is not going to be sufficient. You're going to have that case manager be working with an assertive community treatment team or with an intensive case management team, some level of collaboration where you need, I don't know if I've been able to convey this, but this is actually a sophisticated clinical treatment program that also includes housing. Okay. Now, I know it's been relegated to housing services, and we talk about homelessness and housing, and that kind of makes sense how we got into this mess. But it's not about that for this population. We're not talking about ending homelessness for people who are poor. We're talking about helping people with mental illness get their life back. And that also includes, of course, housing as a first step. So the case management will help with the chores and help with support and, invaluable, but you also need to have the treatment, the clinical piece, either with that organization or working very closely with an organization that provides ACT or intensive case management. And we've left out a conversation about primary care and ophthalmology and dentistry and all kinds of things that people need, but that's also part of it. I mean, the case manager can be a great broker, but let's not pretend that case management alone is actually going to take care of the needs of a population that we're talking about.
Okay, well, thank you very much. And on the your gold star for Milwaukee, I wonder, in Milwaukee, do you think that each of the clients has an acuity measure, and so that is taken into account in the distribution of case managers? I don't know one way or another
Yeah,
whether we
yeah.
do that, but in Milwaukee, do they have an acuity measure for each?
They use it's a complex measure. They use administrative data and clinical data and what the outreach team reports back. It's based on real clinical assessment rather than a checklist.
Okay, so I mean, we got data on the number of case managers, and it was a little, it's just a long list of numbers, but part of what I'm hearing from you is that that's not particularly meaningful without knowing the acuity of the people who are in each of those numbers.
Right. Those numbers have to become actual people.
Okay. One of the other things that you said in your testimony is almost a discouragement of on-site services as compared to off-site services. And it surprised me when I saw it there. And I wonder if you can speak to what you were getting at.
Well, I may have been referring to on-site services being part of the single site building, what we call the permanent supportive housing or congregate housing building. And then off-site services refer to the scattered site. And so maybe just that.
But in a scattered site setting, would it be a positive thing to have, and where there was 10 or 12 folks or 20
I see.
folks,
Yeah.
would it make sense to have on-site services from your perspective?
I think that would be very useful, like somebody who's in the building in an apartment or an office there, so the access is easier. Yeah, it wouldn't create a program sense. And also because the tenants overall, the big picture is that it's a normal building and, some people are living there and they have a case manager.
Okay. Well, you have been very generous with your time. I really want to thank you, Councilmember Henderson. Any other questions? So really grateful for your testimony. I think we're very fortunate. I also want to express thanks to the people in the community who pointed us to you so that you could be here today. I think later we'll have folks from what we refer to as ANC3F who've been very active on this, and your name has come up in that process. And again, really very grateful for your contribution to this conversation. If there's any last words you wanted to offer as the creator of Housing First, I'll give you the last word.
All right. I'll just say this, which is, when other people ask me about some of my favorite cities, I say Washington, D.C., because Washington, D.C. is one of the very few cities that created its own housing voucher. And I think, given the level of commitment in Housing First in the city and all the good work that you have all been doing, like I said at the beginning, it's like going from good to better, So thanks for inviting me, and I hope my testimony has been helpful.
Thank you. Okay. We will now move to our next panel. And we have Rochelle Ellison, who I understand is virtual. Harry Robertson, if you could come to the table. And Andy Wasenich. And we will start with Rochelle.
Good morning.
My name is Rochelle Ellison. I am currently
Hold
the
on.
assistant. My name
You
is
did
Rochelle.
put my phone to do it. I'm sorry. I'm here to bring that. I'm here to bring the number to a personal perspective. My name is Rochelle Ellison. I am currently the Assistant Director of People for Fairness Coalition on the Way Home Steering Committee, a member, speaker, and advocate for the National Coalition for the Homeless, and a DBA certified peer specialist in good standing. And I wear many hats. That wasn't always the occasion. I'm an individual with 17 years of lived expertise with being chronically homeless with co-occurring disorders. Today, I have multiple years in recovery and now reach back out to help others on many different platforms. I started in Housing First in February of 2008 with Pathways to Housing DC, and I was very mentally unstable, had a substance abuse disorder. I needed the wraparound services that Pathways to Housing offered on the ACT team. At that time, my very low self-esteem had endured enormous amounts of trauma. I slept at Freedom Plaza right across the street from the Wilson building, still feeling invisible and unseen, and didn't know where to begin to change. Pathways to Housing DC, Housing First, gave me the foundation I needed to be able to choose to decide that I could live a normal, healthy, fulfilled life. I knew it was going to take a lot of work on my part, but the foundation of PSH with mental health services attached, I grew and healed day by day. I can't emphasize enough that mental health services is a major component of success and growing and from street survival mentality that most of us have coming into PSH. I have since graduated from Pathways to Housing DC and have been released from DBH Mental Health Services after 16 years at Pathways to Housing DC. The reason I was able to become the woman I am today was I was on an ACT team with Wraparound Services for the first 10 years. Even in my early recovery, I was very reluctant to leave the ACT team because I had such a big support system. I then grew to community support, ultimately graduated from the collaborative, giving back my PSH voucher, receiving a housing choice voucher, and finally ready to work to become the productive member of society that I am becoming and growing to be today. Is this not a goal for all individuals chronically homeless entering the PSH sponsor base run by DHS and their CSAs and collaboratives? I believe given the same opportunities with the same resources, that would be a lot more successful people because we are not data, we are human beings. And I just want to say that it's about, like you were talking about how you bring people, get your first apartment in scattered sites. I didn't want to live in a building with everyone else like I was in transitional housing. And mental health services for me started in the street at the soup kitchen called Zachariah's Kitchen, where Pathways to Housing was running that. I was constantly told, I see potential in you, even when I didn't see potential in myself. I was constantly told that people believed in me, even when I didn't believe in myself. I still get emotional from gratitude. But today, I'm a fierce advocate. I sit on the Interagency Council on Homelessness in an advocate seat. I've never seen myself grow into these links and these potentials. And it's only because there was a Housing First model that didn't give up on me when I made mistakes, that didn't give up on me when I relapsed in the first 6 years of being on the ACT team. They believed in me, they supported me. I felt it was a safety net. And after 6 years of being in Housing First, I had made the decision that I wanted to live life a different way and now have double digits as a woman in recovery from substance abuse and mental health. I keep my certification fresh and stay in good standing at DBH as a certified mental health peer specialist because how can I help other people with obstacles that I haven't been able to overcome? And I wouldn't have been able to overcome any of these obstacles had it not been for the Housing First model, had it not been for someone believing in me. Because once I got that foundation underneath my feet, I knew that I could do something different. I moved the whole neighborhood into my first apartment. You have to remember, people are in different stages of change. And when they're in different mindsets, you can't have a whole group of individuals being I forget what Councilmember Henderson called it, but the reason that that posse doesn't work is because it will keep in some individuals stagnant in that posse because everyone's not going to grow at the same rate, at the same speed, or be the same stages of change at the same time. So being in scattered sites allowed me to see quickly that it does not work bringing the whole street into my apartment, that I could help them another way. And finally, I decided to help them the best way I could by working on me first, reaching levels of elevations where I could really reach back and help, which is where I sit today. And I am so grateful for Pathways to Housing, the Housing First model. The ACT team services are so much needed because mental health services, when rendered in the street before you get your keys, actively causes there to be success stories such as myself. Thank you for this opportunity to testify, and I'll be happy to answer any questions.
Thank you very much. Mr. Robertson?
Good morning. My story is no different than anybody else's. I suffer with addiction and mental substance abuse and mental health issues. I've had a 38-year journey in the addiction field and mental health thing, suffering, and going to over 25 different treatment centers. My last treatment center was in 2017, and that was with a career with Amtrak for 19 years. I became homeless and lost my job in 2010. From that moment on, when I went to my last treatment over at RAP Incorporated, I was able to surrender to the addiction part, but I was still homeless. And what happened was I lived in abandoned buildings, wherever I could stay, parks and benches and stuff like that. But something kept telling me just to keep going forward. And what happened was when I got in touch with my mental health services, which is MBI Health Services, Maria Black is the CEO there. And when I was able to get to the Pet V program, I think that's what really saved my life. They allowed me to bring my service animal there with me. So for 3 years or so, it was just me and my service animal surviving on the streets of Washington. And what happened from there, and I'm so grateful for Marin Bowser, for that program really turned me around and it opened my eyes up because I was a productive citizen at one time. Came from a good family and an upbringing, but I was lost for a lot of years. And what happened was going into the Pet V program, I seen how people was getting matched and stuff like that. I didn't know anything about that stuff. PSH has really been a blessing to me. I don't take it for granted. And when I see people that are struggling, I became an advocate by just having the people that I got matched with, and I can say this, which is Marion's Kitchens. From day one, my caseworker, she's been like a blessing. They really do care about how others are treated. In homelessness, everybody deserves a place to live. And from meeting them and being matched with them, it changed my whole mindset, because from getting matched with them in 2021, I wasn't able to move out of the Pet V program in 2022. And from that moment on, everything's just been a total change. What it did for me was it made me become an advocate for others that can't advocate for themselves. There's a lot of people out there that are mentally have mental disabilities, like myself, but most of us do recover. So from that moment on and where I'm at today, it's been a 120-degree turnaround. I'm a certified peer specialist through DBH. I work at that same treatment center now, which was my last treatment center in 2017, which is RAP Incorporated. I'm also a recovery coach. And I still suffer with disabilities, but what I am doing today is helping others that can't help themselves. This program has been a blessing to me and many others that I come across. Through the help of Marion's Kitchens, I've been able to, they did a story on me about 2 years ago, me and my service animal, how we've been able to make progress in my behalf on where I'm at today. And somebody said something earlier about where you live. I'm so grateful where I live at today. I live in a community called Eckington neighborhood, which is minutes from my job, which is walking distance to RAP Incorporated. And the only things that I asked for when I was looking for a place was a place where I can take my dog to, and somewhere where I can be comfortable at. I've never had any problems where I'm at today. And if it wasn't for Marion's Kitchens and other organizations like PHS, we wouldn't be here. And it's so needed. What I do today is I help individuals on a daily basis. And that same mental health organization that I've been a part of, which is MBI Health Services since 2017, I've been a part of their stakeholders member board meeting, a person like myself. So people do change. And I also sit on the board with Marion's Kitchens also. And I will continue advocating for others because they can't advocate for themselves. That's why I'm here.
Really appreciate it. Thank you very much for your testimony. Mr. Wasenich?
Wasenick, it's okay. Everybody gets it wrong. Members of the committee, thank you very much, and good morning. My name is Andy Wasenick. I'm the Director of Policy with Miriam's Kitchen, a permanent supportive housing provider serving 310 individuals. Before my current position, I was the Assistant Director and Lead Outreach Coordinator of our outreach team, also funded by DHS, and I have a deep knowledge of all the PSH and ACT service providers in the district. I participate in a number of ICH work groups and committees. I'm also a former certified peer specialist with the Department of Behavioral Health, completed my practicum requirement working on an ACT team, and I have worked as a peer specialist at St. Elizabeth's Hospital. I have a lot of thoughts on this topic, and I could talk for hours, and I'm just gonna hit a couple things, and I may go off script here. But the first thing and the most important thing that I want to say is that permanent supportive housing is a program that works. And I would say it works for the majority of the people who are in it as it is. Of course, there are a percentage of people that probably need to be better served. And I'll just say, maybe we can follow up on another time, having different levels of permanent supportive housing, as the program, have a PSH plus or something like that. These are ideas that have been talked about for a long time. Why they've never come to fruition, I don't know. And I would also say that not everybody in PSH, needs 24/7 care. They don't, and the way that it works right now. And also just kind of coming to light in what's been said, at least in my experience, a lot of people who have opted out, and I know this isn't everybody, but have been in the program for 5, 6, 7 years, and they're doing fine. So that's one of the ways, I don't need case management anymore. And I think that that's something that maybe should still be allowed. If you're doing well enough and you're strong enough in this program, that you can graduate, right? I also need to say that it's really, and it seems to me in my perspective, on a day-to-day basis, getting to be a worse travesty that we don't have any resources to connect anybody to at this time. I know that this is not the topic of this hearing in particular, but the DHS told the CSON outreach teams last week that the White House has given a deadline of getting everybody off the street, either sheltered or housed by June of this year. And so it just makes things more dire in my eyes. I want to say that one of my gut reactions to people being dissatisfied with homeless services or with behavioral health services is my gut, having been somebody who's been in it for a long time, is that, well, you get what you pay for. A couple of years ago, we matched hundreds of people to emergency housing vouchers, federal vouchers, and the limits for that, the income limit for that was $54,100, which means that the vast majority of people who are in the frontline jobs in PSH and outreach and behavioral health would have been eligible for that had they been homeless themselves. You cannot work this line of work and afford to live in this city. And I think that's problematic when we're asking folks to, even if it's a smaller caseload, to work intensively with people who are in crisis or have high emotional or behavioral health needs, while you are saddled with your own economic stress and you're probably commuting 45 minutes to an hour because you're living way outside of the city. In some cases, people come from Baltimore to do these jobs. And yet I want to definitely shout out anybody and everybody who is doing great work despite of all those things. But I think that investing in the staff that we currently have doing this work is essential, because turnover is something that is just too frequent. And one of the real things that we need to do better at, and as the first witness testified to, relationships are what is key here. You have to build relationships and trust, and there are too many places where that trust gets broken, both because of bureaucracy and because of just the state of things and because of all kinds of reasons, right? Trust is broken, and it's just so important that we that we have to keep it. And then I would also say, as PSH is set up right now, to a lot of degrees, it's really only as good as the services that we can, refer people to. The PSH program is not set up to be an ACT team, as we know. And I think it's worth talking about, well, maybe do we need to change the model a little bit, or does there need to be more collaboration? Yeah, but I think that we find that the services that we refer to like are often left wanting, or it's very difficult to get those referrals through, not just behavioral health, but our own program estimates that probably all of our caseload that's over 65 would benefit from, being connected to some, age-related services, or like knowing that that pathway is a lot, smoother. And that's not, and as this population that we're housing gets older, like that is going to be a more increasing need. Not to say nothing of, the number of people who may be in need of ACT services and under our program, but, for a variety of reasons, including, the inability of getting them connected, for a number of reasons, which I'm more than happy to talk about, but over my time.
Well, thank you. Thank you very much for all of your testimony. I will say this is a challenging conversation. These are hot button issues in lots of different ways, and it should not be lost that the program does work for the majority of people, and Dr. Sambaris talked about that. And when we talk about the places where it isn't working, it shouldn't be perceived as an indictment of every place. We had two witnesses who have told us very inspiring stories about the way in which it transformed your life. And that is something that everybody in this room wants to lift up. In my questions, I'll come back to those witnesses and ask about their personal experiences. But it should not be lost how important this work is and that it works for many people. The question is, how do we make it work better for those it's not working for, and frankly, for their neighbors? I'm going to stop there and turn to Councilmember Lewis George, who has joined us, and I'll give her the opportunity to make an opening statement and take the first full round of questions. Then I'll just do a little one at the end.
Thank you. First, thank you, Chairpersons Fruman and Henderson, for holding this roundtable today. I firmly believe that housing is a human right, and no person should ever struggle to find housing or remain housed. And I think that's why these programs are so critical. We absolutely need to provide people with the support services they need to remain safely housed in the community. And I'm grateful to Ms. Ellison and Mr. Robertson, especially for their testimony today about their lived experience. It is powerful to hear directly from folks about what works and what we can do to support those coming up through these programs right now. Decades of data also demonstrates that housing is healthcare, and that in order to tackle complex behavioral health challenges, we need to address root causes that make our neighbors more vulnerable to these challenges. We know that these interconnected supports are life-saving, and I appreciate the work that Directors Pierre and Bazran have put into ensuring they are as impactful as possible. That is why I have been so concerned by reports of these services falling short of their mandate. When a person who recently secured their first home in years struggles to newfound stability, the answer cannot be plunging them back into a cycle of homelessness. When people are struggling to manage substance abuse challenges, we need to find ways to help, not threaten them with eviction. Now, I know that the jobs of those tasked to support vulnerable residents are not easy, but we as a city have a duty to invest in them to ensure that our residents have their most basic needs fulfilled, because the consequences of not meeting those needs go beyond just the individual receiving services. In Ward 4, I hear stories of communities struggling to find the balance between supporting vulnerable neighbors and keeping their families safe and comfortable. And I hear stories of gaps in services left by these providers being filled by predatory developers who make false promises of their own services for these vulnerable residents and instead take advantage of higher paying vouchers while allowing their tenants to live in slum conditions. This speaks to systemic issues within our programs and housing systems. These residents need support, and those needs, along with their vouchers, should not be exploited for profit by developers who abandon them while collecting government money. So I'm looking forward to hearing how these issues are being addressed by DHS and DBH, and how they provide services to some of our most vulnerable residents. And I'm glad to be able to ask this panel questions on this issue today. As I said, thank you to both Ms. Ellison and Mr. Robertson for your powerful testimony and your continued advocacy. Can you both tell me more about the kinds of interventions you've seen work best for folks in these programs?
The best interventions that I've seen that work best is weekly case management when you're on an ACT team, because you're
Mhm.
building relationships, which is something we've never had. And I'm living in survival mode in the street.
Mhm.
We're very untrusting of everyone. So as you're building these relationships and these rapport, we kind of tend to overbuild at that time because we finally have someone we trust and believes in us and we want to form a rapport relationship with. So having those case management services and people doing your 6-month treatment plan, it's always the same case manager.
Mhm.
We're trained in nothing about me without me, so knowing that we need to be there and being involved in our own treatment plans is very empowering and it brings
Mhm.
you to a new mindset. So that's very effective when you have passionate, empathetic case management for
Yeah.
me. And people constantly speaking life into you has
Yeah.
helped me to
That's right.
elevate and graduate from the housing first model.
Absolutely. Mr.
Uh,
Robinson, anything to add there?
Yeah, I can add. What I can say is that, thank God for Department of Behavioral Health when I got my certified peer specialist, because even though that 38-year of using drugs and mental disorders, I was able to learn something about my lived life experiences that I had. The 25 treatment centers that I had been in prior to that in 2017, I haven't been in anymore. I did have something to give people, and which is meeting people where they at. The treatment facility where I work at, I'm able to. I guess God gave me the wisdom to meet people where they at, and that's hands on. And a lot of people can't do that. Meet individuals where they at. And I thank God for that. Even when I'm out in the public or going to different rallies and stuff like that, I'm able to meet folks where they at. And that's one thing I love about what I do today. It's like helping them help me, you know.
Yeah.
And that's the main thing. And never give up on anybody because,
Yeah.
people gave up on me a long time ago, but I didn't give up on myself and neither did my family. So at some time, at some point, just gotta whenever it's their time, it's their time.
Yeah. Amen to that. I appreciate that. Both of you have spoken about building strong relationships with case managers and other supports. Are there any barriers to building strong relationships, and how can agencies do better to break down any of those barriers to building those strong relationships with case managers and other supports?
I would say the only barriers that I came across were case managers that, as I was growing in my journey, even before stepping into the recovery journey, were talking to me or communicating with me in a very unhealthy tone for me at that time,
Mm-hmm.
almost like they were talking down to me. I'm the case manager, you're the client, not client centered, not meeting me where I'm at,
Mm-hmm.
but expecting me to meet their expectations, which was quickly rectified by Pathways to Housing DC.
Right.
Those are the case managers that normally there was a high turnover rate,
Mm-hmm.
didn't make it because Pathways has a standard
That's
of
right.
you have to meet clients where they are, have empathy and compassion to
Yes.
their plight. And I could normally, in the beginning, I feel like I was one who trained a lot of the case managers because they would put them in a car with me or send them to the home visit with me. And
Yeah.
back then, I gave them a run for their money. So I would come back to Pathways and say, "This one's going to make it. Oh, he's
Yeah.
going to be out the door soon." But it's the tone of voice, the
That's right.
passionate empathy. You don't
Mm-hmm.
have to baby us, but speak
Yeah.
to us like we're equal human beings
That's right.
because that's who we are. We're just
Absolutely.
growing into the person we were created to be in a process.
Amen.
Absolutely.
I
Thank
don't
you.
really I don't really have too much to add to that other
Yeah.
than only thing I would say is that they need to hire more certified peer specialists to work with the case managers because it's not where you're from or your education. It's about trying to help someone get to the next level. And I love the live life experiences that I've been through. And if I haven't been through something, I don't share about it. You
Yeah.
know.
Thank you all. Thank you. So helpful. Mr. Whiteson, I'm sorry you're saying your name wrong.
Wasenick.
Wasnick.
Yeah, or just Andy. That's cool.
Okay, Andy, I like that. I can do
Yeah.
it. success. Andy, thank you for joining us today to speak about what you've seen on the ground in your work, especially as it relates to how we invest in staffing these programs. I think that's a really serious issue. We need to make sure that the people serving so many of our vulnerable residents are not also dealing with housing insecurity of their own. Do you have a sense of what pay looks like for case managers and others providing these services? And what have you seen sort of turnover, and what have you seen as far as turnover in case managers, and what that means for the clients they serve?
Yes. So I would say that like this, on the better end of things, the starting salary for a permanent supportive housing case manager is probably mid-50s for most agencies. That's not the case across the board. We have encountered people working for agencies that are contract and don't have health insurance, or they only work part-time, or we have unfortunately had situations where we discovered one person was working two full-time jobs, one for a permanent supportive housing provider and one for a CSW, or two permanent supportive housing providers at once, because like, hey, some of them were actually really good at what they did, but like, obviously that doesn't work, and is problematic. I was looking around at this the other day. I saw an ACT case manager job that was listed as starting at, I mean, they had an hourly rate, but when you did the math, it was 47,000. So like, I don't think that, it's not that like somebody who's going for that job wouldn't be capable of doing the job well, because like we continue to find people who, are, willing to take these jobs and do them well. It's just that like, you can't then, there's nobody who's going to be a case manager for 20 years, really. Like, the problem is then sometimes that like, in order to retain somebody who's good, then you make them a manager. And I'm actually a living example of this, right? Like, I was a good case manager. I'm being hard on myself. I don't think I was a great manager, and I know I hated it. So like, right? Like, so in order to retain good people, you put them in positions where they don't do as well. Like, I had an outreach case manager tell us, we would say that the average lifespan of an outreach case manager is 2 years, right? That's what we expect. Like, if you last 2 years, then you did pretty well. And he said, look, well, I'm good at what I do. Why would you expect to be rid of me in 2 years, right? Like, why can't I do this for 20? I mean, that's valid. Like, when we're keeping somebody for 20 years, then, you have to be able to pay them accordingly, and then the program gets more expensive, right? And so it's just like, but I think it's essential. I mean, and it just speaks to like, we're talking about this issue of people who are homeless in this environment of a city where we know that the economic drivers of this as well is like, that it makes it hard for the staff who's responding to this very important issue to live here and respond to it well, right?
Yeah. Thank you. I appreciate that. My time is up, but you all's testimony and feedback has been very, very helpful. Thank you so much, Councilmember Fruman and Councilmember Henderson.
Thank you, Councilmember Lewis George. Councilmember Henderson.
Thank you. Thank you to this panel of witnesses for being here. Ms. Ellison, it's good to see you again. I know you testify at the Committee on Health hearings quite often. Mr. Wasenick, I want to start with you.
You were show off to pronounce it right.
Well, she had no number of chances.
Truly.
In all fairness.
He said it. I wrote it down phonetically, so I remember. I wanted to ask if you had to sort of say like what has been one of the bigger challenges or barriers for more success for the program. What would you say that is? Is it needing higher salaries to be able to retain case managers? Is it something else?
I mean, I'm just going to say that like everybody's underwater. Like even those like our organization that is one of the better ones, and I would say, I mean, we have a 99 success rate. The success rate is like still housed after a year, but like and I'm fortunate to be like a well-funded organization and raise lots of money, and so we're able to like fill in gaps and things like that. Like it's like I often find myself saying to myself that I don't think the leaders of our city really understand the depth of need that exists in this city. You don't see it on the surface, but there are people across the city who are struggling. And even the ones that look like they're not are struggling, maybe not necessarily talking about it, but like, I just put it this way, whatever percentage of people in this city who are on Medicaid, for example, in my mind means that they can't really afford to live here. and so that they are economically taxed one way or another. Like, and so, and food security, right? Like, we can house somebody, we can get them connected to behavioral health, we can get them connected to physical health, and everything can go perfectly. But they're still only getting $200 in food stamps. They're getting SSI, like they're getting $29 in food stamps because they're getting $900 in SSI, right? Like, and so we have to find ways to fill in their food and get them connected to food banks and like bring them food from our own organizations and give them gift cards and things like that. That like by itself is a lot. And we have people calling us who are otherwise fine saying, I need food, I need food, I need food, I need food. So like when you're kind of operating under that, like just in general, like I would say the sense that everybody in homeless services feels like we're underwater a lot of the time. And that's why I also speak to like the pay issue, right? Like these are hard and stressful jobs and we're doing it because we love it. And then we have our own economic stresses, right? Like, or many of us do. And that makes it even harder to stick with it. The turnover, you know, I mean, I don't know how many times, like, you know, we're hiring new outreach, like a new case manager, I don't know, a handful a year, right? Like at least, you know, we have a certain amount of turnover. We are lucky to have people who have been around for a long time. Many of them have become managers, right, too, but like they still work with clients and have specific roles. But like I would say that it's fair, and I think it's pretty high on, and I can't really speak, but like I think in other organizations, like there's a lot of turnover in PSH case management.
So let me say this,
Yeah.
and I hear you in terms of what you're saying. I say that for, right, I've got hospitals that are
Sure.
having issues, I've got clinics and providers in the whole nine. And if I had infinite amount of money,
Yeah.
I could solve all of these different things, but I don't. And one of the things that we, in some of the other programs, we've had to sort of make decisions around if the staffing piece is most critical to achieving the success of the program, then perhaps we have to step back on how broad we expand at this time so that we can build a strong foundational infrastructure on that. And, you know, in the pre-hearing responses, for instance, right, one of the things that has always been like even when I was a staffer at the council, everybody's talking about like during budget season, how many vouchers do we have? How many vouchers do we have? How many vouchers do we have? We have over 1,100 vouchers, which we haven't been able to lease up. And that's partly because you don't have enough people on the administrative side to be able to sort of do that process. Would it be worthwhile for us to say, instead of pounding 5,000 more vouchers onto the street, we instead maybe do 150 and we steer some of that funding into the administrative piece for a year or two to stabilize it?
My answer is always going to be probably to, I mean, we'll find some sort of a balance, but to lean more into the vouchers. Like we got to get people off the street. Like people are in crisis. And I think that like, the way that I put it is like, if there were a flood that put 1,000 people on the street, right? You know, like say in North Carolina more, but like I used North Carolina a couple of years ago as an next, like if there was a flood, there would be a massive response under normal administration. You know, there would be FEMA, there would be this, there would be GoFundMe's, there would be like benefit concerts and things like that. And among that population are people who are now, displaced in a house, are people with serious mental illness, perhaps untreated. There are people with serious substance abuse issues, perhaps untreated, but they're now unhoused. And nobody is questioning whether or not they deserve housing or should they be prioritized about it. Here, when we're dealing with of 1,000 people or more, right? Because they've all trickled into it from their own different, life streams, that like somehow we don't respond to it as the emergency that it is. Like people who are living outside in crisis.
Yes.
And we need to so that's and I know I'm getting into a longer thing, but like some emotion behind it.
No, I hear you, and I certainly can appreciate your passion. Yeah. I'm just trying to understand the other side of it. If I could put you in an apartment all day long,
right?
Can you stay there? And what is happening while you're in the apartment in terms of, to the part of something like the loneliness piece of things, right?
It's a big part.
So is there not the responsibility for us to try to do both?
I think this is where we need to lean into community a little bit more too. I think that like, and this isn't just for like the unhoused population who are lonely. I think we've all read articles and whatnot about how like, people are lonelier and more isolated than ever. And so finding ways to overcome that, I mean, it is specifically an issue here. One thing that I'm just unaware of, but back in the day, like there were day centers for behavioral health programs had day centers that people went to and they took classes and like, I don't think that since the pandemic, at least to my knowledge, and I could be wrong about this, that exists in the way that it used to, or getting people connected to. I know in the ICH meetings, we've had DACL come to them and talking about how can we get people who are unhoused to go into like the senior centers for meals and things like that. Well, we got plenty of them for our house too, who could like take advantage of those services. And so and again, and I think like one of the biggest challenges, that comes to mind is just the siloing that we have, between, we work at it, but like DHS, DBH, Department of Aging, Department of Health, Unity Healthcare, right? Like there's so many, you have to be an octopus to make all the connections, right?
Okay. I'm going to be respectful of the time because we've been going at this for 90 minutes and we're really on the fourth witness. So thank you. Thank you.
All right, thank you very much, Councilmember Henderson. A couple of questions for this panel. To Ms. Allison and Mr. Robertson, you talked about the inspiring way in which this program lifted you up and got you on your feet. I wonder if each of you can speak to how it worked with your case manager out of the box and services, because in some senses, what you are the good news stories, but to the extent that you engaged with case managers and you also engaged in services, you're sort of not the issue that we're trying to get at now. It's wonderful to hear about the success, but if you can speak to your experience with your case manager and support services over time, and perhaps the extent to which there were periods where you rejected one or the other.
I can honestly say that you are so wrong because it's over a period of years in a process, and you're very misinformed about the fact that on just a success story, it didn't go through those periods. Those periods for me, I was in Crossing Place, Jordan House, while in Housing First, because I didn't build a rapport or didn't feel like a case manager had my best interest at heart. This happens over a period of time due to different thought process changes. If I felt as though I didn't want to participate, there's been plenty of times that I had a case manager I told I had to be paired with, and I refused to pair with that case manager. I refused to let the case manager into my home. I refused to meet the case manager at any place other than Pathways to Housing where there could be supervision of that case manager because I didn't trust that case manager. This all happens in processes, and you go through different stages of change, from pre-contemplation to contemplation to preparation to action to maintenance. And that happens over a period of time, not overnight. And the trusting and the rapport building with case managers was hard because, as I stated, Pathways has a very high threshold of who they want to interact with, the clients that they serve. So not everyone that I first came in contact is still working at Pathways to Housing DC today. And I always knew when they were going to be there for a short period of time or not, because you could feel a person's energy. Like, one thing that we are coming from survival mode, we're skilled at feeling people out right away. So the case management services it wasn't always the problem of the case management services. In retrospect, it was me. But you don't know that until you grow into the person that can have an outlook and have a retrospect, right? So it wasn't always me not willing to participate. It was me not trusting. It wasn't me as a human being unwilling to be open-minded. It was me not having the experience of being able to deal with the case manager to get to another level that I felt didn't have my best interests at heart. And I've had mental health crises in this 16-year period of being at Pathways, as I stated. and had to seek outside help from Pathways, go someplace other than my apartment to get myself back to being feeling like I had a little foundation or a little baseline, even though I wasn't baseline at all at the time, even though I thought I was. So it takes very empathetic, very educated, and very passionate people, such as the people we are that are DBA certified peers now. And I think that if in the retrospect, you should have, I thought the DHS peer case management cohort was created because we didn't have enough housing case managers to do the documentation. I know that's why I fiercely advocated for it. And that's why I'm looking forward to hopefully becoming a person that enters this new cohort. However, I am a DBA certified peer and could do the job as we speak now. So if someone would give us the opportunity to come in and do the housing case management, we'd be happy to become the case managers that the people need because we know exactly where they're coming from.
Okay, thank you
sometimes
very
that
much.
isn't the case.
I just want to be clear. I mean, you said you went to a couple of different places at different points. You said Georgia something. What were you?
Jordan House and Crossing Place, they are mental health crisis houses
I
where
see.
you're not in St. Elizabeth's and you have to stay in 24 hours till you see the psychiatrist. However, you can still come and leave, but you have curfew, you have dinner time, it's still structured. So, but it's just some place to get out of your own apartment where you may be getting overwhelmed, or you may need to just get out that space of the responsibilities at that point. And it's somewhere to go where you can relax, get some more therapy, get the help you need. At that point in present time where I was in my life, I needed that. I needed those mental health crisis beds open to me. They are ran by some, so others might eat, but they are also paid for by DBH.
Okay.
They were back then.
Wonderful. Thank you for that response. I do want to give Mr. Robertson a chance to speak as well.
What was the question again?
The question was your path along the way, and to the extent that, to what extent did you work with case managers along the way? To what extent did you embrace the services that were offered to you along the way?
Well, the most recent one would have been when I first got to the PEP V program in 2021. I had a Samaritan, I had a Catholic Charities caseworker, I had my MBI caseworker, and I had Marian's Kitchens caseworker. And for some reason, I just knew that I didn't want to do the same thing again. So I allowed them to help me. And what happened was I formed a dream team because right today, each one of them I learned something from. And it built my confidence up to keep moving forward, to keep, and that's why I said I became an advocate. You know, you have good case managers, you have bad case managers. And today, if I see someone coming that's not a good fit for me, I recognize that. But it's only because I've done A, B, and C. You know, I didn't try to go from A to Z and read the whole book. You know, and that's the thing. You know, the live life experiences that I have with myself, I can pretty much meet somebody where they're at and get a good vibe. And just, you know, and that's because of the program. You know, this PS, the Permanent Supportive Housing Voucher Program has been a life. That was the only piece that was missing for me. You know, and I suffer with diagnosis and certain PTSD and all that, but I'm able to function to help somebody else, you know, and that's the blessing because everything else was coming into play. But without that housing voucher for me, no telling where I would be at.
All right. Thank you very, very much, Andy.
Sure.
Going to play it safe. So, Andy, what should we do in a setting where there's somebody who is in an apartment who is declining services and is behaving in antisocial ways and seriously detracting from the quality of life of their neighbors? I know you are a powerful advocate for this program, but put yourself in the shoes of those of us who are trying to contend with that reality that happens. What should we do?
Yeah, I mean, if they're declining services, I also, like, one of the things that I wanted to flag is that, like, since the voucher limits changed in 2017, like, it's not just PSH voucher holders who were able to move into new neighborhoods, like, people with Section 8 and HCVPs that maybe they got in Maryland or Virginia or any other state in the country can also move. And I don't know to what degree that is also the population in a lot of these buildings, but I think it's some of it. And I think actually it's possible that some of the more tragic situations were people that weren't in the program. So we can solve a lot of these issues and we're still going to have problems. I mean, in my mind, like, the recommendation would be if there whatever the issue is that the community response team should be called. Like, they should be called. Building managers should know that they have the crisis response or the community response team to come out and try and deal with the situation, particularly if it's acute mental health, right? They should be the ones who are called. And then ultimately, like, I think, as we've said, there have been situations, like, I don't want this to happen, but, like, if the person needs to be evicted, they need to be evicted. What I fear, though, is that then they will be exited from the program if they are in the program. They won't get connected to whatever services that they do ultimately need. And unfortunately, what I have to say is that, like, not necessarily because of any negligence, but it could be negligence. Like, the person who's refusing help has not, like, the relationship wasn't built, right? We have a lot of situations where, like, relationships have been, the trust was never built. In outreach, like, we see this. We meet people's needs on a daily basis, and we're the ones that get them connected to housing, and they love us, and then we have to say bye-bye, right? And we don't get to see them in outreach, and we still get calls. I get calls from people who I housed 8 years ago, right? Like, I mean, just to say hi, but, like, they don't forget. And so, like, I really think that that's part of the equation, and I don't know how to fix it. And I also want to say that, like, one of the things that we may be experiencing today are still the effects of the pandemic, because rightly or wrongly, during the pandemic, PSH providers did not have to see people in person, and nor did ACT teams, to my knowledge. And so, like, there was nobody for a year, 2 years, right, however long it was, that were actually receiving services. And so I know a lot of relationships were probably lost and broken.
All right, super, super helpful. The reverberations from the pandemic are being felt in all different kinds of ways, so I don't doubt that you're right. And it's another thing in the housing space is people who have not been paying rent, and I see folks over from the housing provider world that I think we may hear more about that. What I'm going to observe, a couple of things that you said come very close to where Dr. Simberis was.
Yeah.
And one of the things he pointed to was the importance of the person who gave you the keys being a person who you're dealing with going forward.
Yep.
Because of that, really, and I hear that from you. And then I also hear from you, yes, maybe a person should be moved to another place, and maybe there's a point where a higher level of care could be appropriate. But that's a stepwise thing, in that there will always be noise here. I don't think any of us want to get to a place where you have people with very high needs and we abandon them. We just also cannot abandon the people who live next door.
Yeah.
So,
And I think that, I mean, that's everybody's fear. And I don't know. I mean, like, we've had, I mean, people get evicted in our program and then we rehouse them, but, like, sometimes they don't. And I, like, that's where we would want to make sure, or that they're getting the services that they need from wherever. And part of it is, like, look, I also think that in the behavioral health field, and the ACT teams and just providers in general, like, and outreach providers and things like that, when somebody doesn't have any insight into their illness, right? Like, that is often its own diagnosis, but it's really, really challenging. And it's really challenging because somebody will say, like, no, I don't want it. I don't need help. I don't need to see a psychiatrist. And so everybody says, okay, he doesn't want to see the psychiatrist. He doesn't need help. We can't help him. But that shouldn't be the case, right? The case should be like, no, we can easily see that this person needs help and we need to find ways to help them. Even if they never take medication, they have behavioral health issues, they have things that we can work with them on. We can help them learn coping strategies. We can open them up to other things. We can, like, there are things that can be done with somebody who is medication refusal. And we can try and build trust and relationship and meet their needs and maybe get them to the point that one day, a year or two or three down the lines, where they're like, you know what, I'm having trouble sleeping. And like, oh, really? Why don't you come see the doctor and he'll give you something for that? And then we get it, start that road, you know.
So again, really, really appreciate it. I do think the Venn diagram of overlap of what people from different dimensions are saying is getting tighter. So I think that's the goal of this hearing. But with that, I think we need to turn to our next panel because I'm nervous about Councilmember Henderson next to me. Thank you very much for your testimony.
Thank you.
Thank you.
Thank you.
Marilyn Lance and Commissioner Courtney Carlson. All right, nice to see you both. Ms. Lance,
Yes. Am I on?
you are.
Okay. Good afternoon, Councilmember Fruman, Henderson, other officials and guests. Thank you for the opportunity to testify before you today. I'd also like to take a moment to also thank Dan for patiently listening while I vented last week. I tried to justify not attending today, all the while I kept hearing my parents' voices telling me to go, share my concerns and experiences that I've had over the past 5 years. So here I am. My name is Marilyn Lance, a 20-year resident of the Brandywine Apartments on Connecticut Avenue, and also a member of the Board of Directors for the Tenant Association. My day job, however, is a human resources consultant. In late 2017, I and other residents began noticing an uptick in police activity in our building. It concerned us. We eventually learned the increase was not due to regular college students' Saturday night loud beer parties that we'd gotten used to, or someone parked illegally in another person's space. The normal reasons MPD would be called for, but now they were being called for more serious reasons. In 2018, as a member of the board, I began collecting data through FOIA reports, which summarized the calls reported by MPD that they had made to our building. Prior to 2018, MPD would be called once, maybe twice a week. Now, 7 years later, we have reached an average of 1, sometimes 2 visits a day. In 2024, there were a total of 362 incidents in our building, of which 45% were connected to behavioral health, mental health issues, domestic violence, and child abuse issues. This year through September, the Brandywine has had 60 calls related to the same type of incidents, approximately 43% of the 297 calls so far. Allow me to share some of the incidents that we've experienced since the last 5 years. We've had calls for suicide attempts. We've had people feces spread on the corridor walls while the person was screaming profanities. Resident deliberately turned on the gas stove, left their apartment, and proceeded to walk the hall in the nude, totally out of control. Occasionally, a dedicated 40-year employee has been verbally threatened, just trying to do their job. 2 mothers stabbed each other. There was blood everywhere, 8 o'clock in the morning, as their children observed, hysterically crying. We have a wheelchair person who publicly gets intoxicated, falls out of the chair onto the floor, and is found just incoherent in the corridors. And we've had a significant increase in domestic violence and child abuse incidents. Those are a few examples. There's more. Sadly, this behavior is not isolated to the Brandywine. It's become the norm in apartment buildings up and down Connecticut Avenue. The behavior has resulted in some residents moving, leaving the community, fearful of their and their family's safety and security. It is no secret in the past several years, there's been 4 innocent children, babies, I might add, have lost their lives at the hands of the very people who should have protected them. These were senseless deaths. We've been told that we live in a bubble. We are NIMBYs. I personally have been called an Uncle Tom. While all I and other residents want is to reside in a safe and secure community. In the past, officials have told us to deal with it. You should live in Ward 7 or 8. We cannot continue to put Band-Aids on something this severe that needs stitches. In closing, I trust what I have shared with you will be of value. It is obvious the Permanent Supportive Housing Program, whose objective is to provide long-term housing vouchers and intensive case management to individuals who have been chronically homeless, will not be successful without more intervention, involvement, and more wraparound services available. Let's be honest, some folks are not capable of living independently without these services. Our community has and continues to be negatively impacted, and signs of deterioration are evident. Together, we can fix this concern. The program, although parts of it may be broken, we can fix it. We deserve more. Everybody does. We really should be ashamed that we are exposing our children, the next generation, to these unfortunate events. Thank you.
Thank you, Ms. Lance. Commissioner Carlson.
Good morning. My name is Courtney Carlson. I serve as chair of the Advisory Neighborhood Commission 3F. I'm a DC native and moved back here with my family in 2007. As a high school student, I worked where my current SMD is now, so I know the neighborhood. I'm in my 3rd year as commissioner. Nearly a year ago, ANC's 3F, 34G, and 3C jointly requested a hearing just like this. Unlike the ANC, you're in a position to take meaningful action, and by holding this meeting, you are showing that you care. Over the past 5 years, there's been no shortage of meetings and no shortage of good intentions, but what's been missing is decisive action. So thank you for seeking that here. Meetings are good. Meetings and goodwill alone can't solve the worsening problems in our community faces every day. And I wanted to say I'm so grateful to Dr. Simbaris for being here. And if I could retitle what I want to say, it's how could you put someone with a mental illness in an apartment with no one to look after them? Because that's what we've seen here. I'm no expert in housing policy, but I am an expert on ANC 3F. And from where I stand, I see a well-intentioned program that has had serious unintended consequences. The experiences of Ms. Ellison and Mr. Robertson on your last panel is unfortunately not what's happening for PSH voucher holders in the apartments along Connecticut Avenue. They're not getting what they need. Over the past several years, the ANC has heard countless reports from tenants along Upper Connecticut about deteriorating conditions in their apartment buildings, residents described being threatened, harassed, and even assaulted in the hallways of their homes. We've heard about unchecked drug activity, prostitution, and domestic violence with little or no response from building management or oversight agencies. There are no consequences for repeated and severe lease violations, which leads to chaos and disorder in apartment buildings in our greater community. Councilmember Fruman and Ms. Lance reminded us here that about the tragic deaths of children. The condition still exists where if a child died tomorrow, no one who certainly frequents an ANC 3F meeting would be surprised. DC's Child and Family Services Agency showed investigations of child abuse and neglect have quadrupled in Ward 3 since 2017. The agency has this data, and neighbors warned us that something terrible could happen, and it did. 911 calls from these buildings have also skyrocketed. Monthly call volumes now match what used to be annual totals. These repeated calls are an enormous strain on district resources. The problems with the program extend beyond the buildings and into the community. Forest Hills Park has been repeatedly vandalized. Brandywine Street has become a dumping ground for litter despite ongoing cleanup efforts and requests for more trash receptacles. In the early evenings, while children play, people openly smoke marijuana at park tables, and the smell wafts over to the swing sets. We also know of residents who clearly cannot live independently and who threaten or harass neighbors and building staff when asked to comply with building rules. Families who choose this neighborhood for its excellent schools and safe environment now see a park deteriorating, and the local elementary school, where one teacher's made a small bed in the corner of the classroom so exhausted children who can't sleep in their apartments, as we've heard from residents, can rest when they arrive. That doesn't just affect those children, it affects the learning environment for every school student in the class. In March 2025, ANC 3F unanimously passed a resolution urging the mayor and Department of Human Services to ensure weekly case management visits for all PSH voucher recipients, especially families with children, and recommit to the Housing First model in its full form, including the crucial wraparound services that make it effective. I'd like to share an excerpt from an email I received last October from a longtime resident of Ellicott House. I'll try and make it brief. I'm the fourth resident of Ellicott House at 4849 Connecticut Avenue to move, and building management has been unable to evict a tenant, who has caused numerous.
Take your time.
Yeah,
Good.
thanks. Okay. Who has been unable to evict a tenant who's caused numerous police calls to the building, including throwing a metal end table through the window, which landed on a driveway 4 floors below. In May 2024, someone connected to this resident kicked in the metal front door of this apartment so hard that it was completely bent and had to be replaced. Several times I've been afraid to leave my apartment and enter the hallway due to sounds of domestic violence and police presence in the hall. I tolerated this behavior for 4 years, but just 1 month ago, I finally moved out of the apartment after 3 months of a roach infestation caused by that resident. I've been a resident of DC and this building since 1995. This is no longer a safe or desirable place to live. The housing voucher program needs to be changed because relying on standard eviction procedures doesn't work. Instead, you have 4 other residents who move while the one tenant who's there continues to terrorize neighbors. These people also have the ability to be able to move. The safety of all tenants needs to be a first priority. Unfortunately, this is not an isolated story. A 30-year resident of Connecticut House moved out after years of threats from her next-door neighbor. A young professional who moved to the Brandywine Apartments to care for his aging parents a block away from his childhood home left after enduring months of sleepless nights due to constant domestic violence disturbances on his hall. Domestic violence, often described as isolated, feels anything but. It reverberates through walls and hallways. It stands in an elevator next to you. One neighbor told us that she repeatedly witnessed violent events through the window for an apartment next door and pleaded with building management to intervene, warning, there will be blood on your hands. These are our neighbors, and this is our shared responsibility, every single one of our neighbors. The community has risen to the moment. Murch Elementary has raised additional funds for aftercare for families and stipends for activities. Another wonderful neighbor founded Northwest Community Food, which now feeds 380 families a week. We all know now more than ever that needs are growing. Housing voucher recipients are not the only tenants who need our compassion. What about the federal employee who lost their job and is struggling to pay their rent at the Saratoga? The recently divorced parent who's stretching to pay rent in their to stay in their child's school district living at the Brandywine? The young Murch teachers who live at Ellicott House? The voucher recipient who is stable and ready for a fresh start who moved to Connecticut House? They live in the same buildings and they have no peace. Lease violators cannot be allowed to continue to terrorize hundreds of other residents and strain MPD and other city resources. Every resident deserves to feel safe in their home, and we owe it to those who've spoken up to act with urgency. You've heard from tenant representatives along Connecticut Avenue for more than 5 years, warning that there were serious problems long before these children lost their lives in conditions that no children should endure. had a social worker stepped into some of these apartments, several described in police reports as squalor, there might have been an opportunity for us to intervene. Thank you for acknowledging these issues. We now need to do the hard work of figuring out how we get the services to the residents who so desperately need them. Thank you for your attention and your renewed commitment to act, and we're counting on you.
Thank you very much to both of you for your testimony, but also for all of the work that you've done over the past years on these issues. ANC3F has shown real leadership. I think this hearing grows out of a couple of different dimensions of meetings that folks at ANC3F, and I see Marlene Berlin over your shoulder, have held to try to raise the profile of these issues, and very grateful to you. There's other names out there. There's Harry Garral, Kim Farmer, Faith Mullen, Tracy Zerpat, a lot of people who have focused on this. And one of the things I want to say on the record is often there's a pushback. I represent Ward 3, and there can be a pushback that, oh, this is Ward 3 not wanting to share the burden that the whole city shares. And it is not. It is not folks saying, don't do this. It is not folks saying, we don't want anybody different to be in this community. It is folks saying, we see something that isn't working. Often it works. I'm seeing Andy over there, and I want to acknowledge, often it works. But when it doesn't work, and there's feces on the wall, or there's domestic violence that happens in front of you on the elevator, we all have to acknowledge it's not working, and how do we fix it? And ANC3F has played a very positive role in trying to put ideas on the table of how we can do this, as has Marlene and others in the community. One of the things that ANC3F has talked about is the idea of mandatory home visits, and that is an idea that we are looking at and trying to figure out how to do legislatively. We did hear, there may be a point at which someone graduates, and so that becomes an issue. But is there a hierarchy, Commissioner Carlson, of folks who you think we ought to be mandating more frequent home visits for?
I would defer that back to Dr. Sambaras, who seems to be
I
pushed it. Oh, sorry. I defer to Dr. Sambaras, who's seems to be the foremost expert on this and has so much data on these information on these issues. But it seems at baseline that lease violators have to be, when there are violations of leases. I don't know how the council, how social services, somebody has to say there are rules for which we live in our community, and they have to be upheld, as particularly in apartment buildings. But my understanding of Housing First is that it is, and Dr. Sambaras said this, you don't put someone in with a mental illness in an apartment without looking after them. And you have to see a caseworker, because this is what you agreed to when you got the keys to the apartment. Let me show you where your apartment is. Let me help you. As we heard from the earlier panel, it's not a straight line. It's so complicated. There's so much to learn from everyone who's spoken here today about how, if the answers were easy, we'd have fixed it by now, right? But I will say that I agree with you that especially when I hear Dr. Sambaras, it's a great model, 10 to 15% of people in a building who get the benefits of this great elementary school, who wants to have a diversity, who wants to show their children that, we can be a compassionate community. We want this in our community. We want people to succeed. And I think we had a woman at a meeting this week who last month who said, a person arrived in her apartment building with just a mattress. And she's like, this is an outrage. And everybody in the room, it was our first in-person meeting in a long time. Everybody in the room, we all were like, this is an outrage. What can we do? How can we help? Can the ANC write a grant? Can we get Judy Ingram's Northwest Community Food to get, can we connect her with Wider Circle? What can we do? How can we, we all were like, yes, let's help. But we can't, this is happening every day. People are coming to apartments that the city has provided without any help. I mean, you can't, it doesn't work.
I will thank you very much for that. And I do think I'm also particularly grateful that you're lifting up the ways in which the community is eager to help.
Really.
And Murch Elementary is a great example. I remember a couple of years ago being on the playground and a young woman came up who was benefiting from a voucher who said, ironically, in some ways there's less services for me here than there was in a different community because that infrastructure doesn't exist. And yet people in the community are building that infrastructure. So
we've heard that precisely, that there's no free aftercare or aftercare that accepts vouchers. So the Murch community raised the money to help people get their kids into the Murch sponsored aftercare, into the Murch language program after school. They've raised money to allow kids to not have to pay to be on the soccer team, things that they know are integral into being a part of the community and feeling supported, and your kids feeling like a part of the class. Everybody wants that.
Again, really, really appreciate it. I'm going to turn to Ms. Lance. Ms. Lance, thank you for all of the work that you've done over the years and for your steady and sensible voice on these topics. I am curious, to what extent have you had the ability to reach out to caseworkers or have other tenants reach out to caseworkers or others to try to address these issues as quickly as possible? And it may be that you also connected with property managers, and I'd encourage you to speak about that as well. I will say, we're going to have a panel of property managers, and what they are going to say, because I've heard it, is their frustration at their inability to address these issues. So there's lots of people out there who need to fix this, but they also need to be empowered to fix it. But I'm curious, in your day-to-day, what kinds of things have you tried to do to turn the oil tanker?
To answer your first question, I have not had any involvement with case management. It's my understanding that's relatively private, confidential. So no, I haven't, and I do not believe, or I should say I know no board members have. There are two things that I can say. Property management, our property manager and his staff do an excellent job. They are working with Dr. Bazran's group now. I've worked with her, so we're involved with behavioral health, building a relationship, and it's going well. And our property management team just last month had an excellent seminar. It was Domestic Violence Month, and we all took part in it, and we had them come in, and we had a seminar October 17th, I think it was. So we're working with community people, and MPD has just been excellent. So that's the extent of what I have done as president of the board. But my hat goes off to our property management team. They're doing a good job. They're really in the process, or the outreach is great. It really is.
Can we just all savor the moment of the tenant association praising the property management company?
Well, we work hard at it. The property manager and I meet monthly. We sometimes have a outside guest. We have MPD, the lieutenants come in. We talk about those FOIA reports so we can get a better understanding of what is listed on the reports. So we have a good partnership. I mean, we worked hard at it, and I'm impressed with what we're doing so far.
All right, well, I really appreciate it. Part of the idea of this is to get all the information on the table, get all the ideas and perspectives on the table. This is super helpful.
Hats off to Dr. Bazran also. She came to a meeting, her and Tanya Trice for Child Family Services, and they did an excellent job and provided us a lot of resources. So we're getting there, but it's still a problem.
I hear you. Thank you
Still
very
some
much. We're looking for models and you're describing some. I'll turn it over to Councilmember Henderson.
Thank you, Councilmember Fruman, and good afternoon. Commissioner Carlson, I remember, I think it was almost a year ago or so, we started to have this conversation with a group of neighbors and sort of conceiving what this hearing would be. I think originally you guys wanted 5 committees together. Sorry. Hopefully
We can get.
we're good together.
This is.
But I think some of it was around misconceptions, right? A lot of people thought that the PSH program was being run by the Department of Health, which wasn't the case. And I think there were some questions around levels of integration, but also the fidelity to the model. And I recognize that there have been lots of challenges. I've heard from neighbors, certainly heard from property managers, heard from property managers on the weekends, where I have called DBH to say, okay, we got to do, like, this is sort of reaching a crisis level situation where there needs to be an intervention. But I don't feel like it should always get to the point of someone needing to call an elected official on the weekends to be able to call a director to then actually see some action happen. That tells me that there's some sort of breakdown in the system. And I think that we've worked really hard to try to improve. Now there's a hotline that folks can call to DBH to sort of get more direct access, as opposed to sort of going through a game of telephone.
Yes.
Trying to do some of those things. But I know that a hotline alone doesn't necessarily solve some of those issues. We have a lot of information and data, but then there's also some pockets of information. So for instance, while Ms. Lance, you talked about a variety of different scenarios that have taken place in your building, I don't know if every one of those instances was involving someone who's receiving a PSH voucher. It could be a different.
I don't want you to think that that's what I was saying. I'm just telling you that's what's happening in our building.
Yes, no, I know. But what I'm sort of thinking about to Dr. Simbaris's comments around 10 to 15% is whether or not DHS, DBH, and others have engaged in a bit of an audit to see, are there some buildings for which we have higher concentrations than perhaps what might be successful for all parties involved? And then obviously there's choice. Obviously, we're looking for where the availability of apartment buildings in order to lease up and do those pieces. But I think that there has been some sort of silo things. And also in some cases, when you're operating in a crisis of, hey, we need to close an encampment, or hey, we need to move folks out of a particular shelter, or hey, rapid rehousing is ending and this family needs to move somewhere. I think we've been doing a lot of plugging holes in sort of like, okay, you're housed, but not necessarily providing the follow-up pieces that are necessary. I'm curious, when you're talking to property managers, and they'll obviously testify, but I'm sure Ms. Lance, you're talking to other neighbors in the building. What is generally the process of response in terms of a particular incident or issue?
The process.
Oh,
process.
yes.
If I saw something happening myself.
Yes, ma'am.
The first thing I would do is, in fact, talk to the property manager, because those are things that, as a tenant association or as a resident, that I can't do anything about. So that's why the communication with property management is so necessary.
Yeah. Okay. I mean, I also think about, I know that there had been some issues in terms of evictions and that process, and I know there was some frustrations there, which we've passed legislation to hopefully improve on that problem, but it doesn't necessarily solve it altogether. So I know I'm not asking a lot of direct questions because I have so many questions for the executive and the agencies who are managing this program, as well as the folks who are otherwise, but your voices are certainly important in terms of how you all are experiencing the program, not as a participant, but just as an observant and neighbor. So thank you so much for being here today. Thank you.
Okay. Well, thank you. And thank you very much. If either of you have a last word you'd like to offer, I'll leave it to you. You're the two representatives of neighborhoods. I would like to say, as it happens, you're in a Ward 3 neighborhood, but it is not exclusive to Ward 3. We heard Councilmember Louis George talk about Ward 4. We had some very passionate people come to earlier hearings about Ward 6. This is an issue that goes across the city. But if you have any last words that you wanted to offer, given all of the work that you've done on this issue, I wanted to give you the opportunity.
I think I've covered everything. I again would like to take a moment to just thank property management and how our relationship has grown. We have, I think they find us credible because sometimes you go back and forth as a tenant association versus property management, but we've gotten past that point. I guess the only other thing I would say is I would not want anyone to think that I'm saying that everything that happened was in fact a PSH voucher. I don't know that. I can also say that a lot of people who have a voucher will in fact let you know that they're there on a voucher. So it's not anything that's hidden. They share that kind of information.
Thank you very much.
I'll just go back to one other thing that I heard Dr. Sambera say, which is you're purchasing a community when you take, the percentage of housing vouchers and put them into apartment buildings, regular apartment buildings, and that's part of what makes it work. And so this is a delicate space because then when it's not done well, the community is really suffering, which is what we're seeing with our playground. I just got an email this morning from Terry Hewitt, who's been very involved in the ANC 3F housing. She was the chair of the ANC 3F housing, and she said there's just been a rash of vandalism, car break-ins, and burglaries right around the Avalon, her apartment. We're having quality of life issues, which are then changing the experience we're providing to people to whom we would like to bring in and support while their lives get better. So we need that. We need to, and I think that the percentages are really important. And what I've heard is the percentages, and I don't have the exact data, but in Connecticut House are much, much higher, closer to 40%. I think in the Brandywine, it's maybe 38%. So that doesn't serve the mission we're trying to serve. And I would again say that, ANC 3F, as a commission, wants to help in any way we can, but we hear over and over and over again that people don't feel safe. And that is the fundamental responsibility of our city, is to keep our citizens safe. And we gotta listen. And we have to support everybody. The most vulnerable, as Mr. Wasenik, right, said, the people who are working in these social service jobs probably can't afford to live in the places that they're serving at this point, like those people are also struggling. Like you're just, there's so many people, like he was saying, it was so impactful, who are struggling. You see it or you don't see it. You don't know. They tell you they're on a voucher or they don't tell you on their voucher. Like people are struggling across the board, and we need to create a compassionate community for everyone. And we're here to pass along the information and do whatever we can to help. And we need, and we thank you for your leadership on this.
All right, thank you very much. I think with that, we're going to turn to our next panel. Excuse me, took a minute to find my place. Catalin Peter, Timothy Taylor, Ariana Royster, and Greg Selfridge. All right, Ms. Peter, when you're ready.
Good afternoon, Chairperson Fruman, Chairperson Henderson, and staff members of the committee. My name is Catalin Peter, and I serve as the Vice President of Government Affairs for the Apartment and Office Building Association of Washington, D.C.'s residential portfolio. We represent nearly 120,000 rental homes across all 8 wards of the district. AOBA members range from small local owners to mission-driven operators and long-established affordable housing providers. Collectively, we work every day to house Washingtonians at every income level and share the district's goal of ensuring housing stability and safety for all residents. The challenge we see on the ground, however, is not only about affordability. It's about supportive services that are too fragmented, inconsistent, or difficult to access when they're needed most. Housing providers, which you'll hear from today, are being asked to stabilize individuals and families whose behavioral health and service needs far exceed what any property management team can responsibly manage without reliable partnerships. When the network breaks down, landlords are trying to manage crises they are not equipped to address, and too often eviction becomes the only remaining tool. We know that case managers and service providers are doing incredibly difficult work. They are carrying heavy caseloads, navigating layered client needs, and doing their best within systems that are stretched beyond capacity. Our members' concern is not with these individuals. It's that the broader structure supporting them isn't strong enough at this time, which is why we appreciate Councilmember for holding this hearing. Without more resources, coordination, and shared responsibility, even the most dedicated professionals cannot meet the level of need we're seeing in the field. Across our membership, we hear familiar challenges, turnover among case managers, unclear points of contact, and delayed responses when issues begin to escalate. The more acute the need, the harder it becomes to get help. This dynamic hurts everyone. Tenants who lose stability, neighbors whose safety and peace are disrupted, as we've heard, and the case managers themselves, who are being asked to carry more than any one agency or individual reasonably can. To strengthen the system, AOBA believes we need clearer structures for collaboration and communication between supportive service providers and housing providers, which I feel confident that the committee shares that goal. Earlier and more consistent interventions when behavioral health or substance use issues threaten housing stability. We do believe that you can catch things early, and when you do, there are less dire consequences. We also ask for additional investment from the district to expand capacity, including intensive outreach and crisis response teams, so that services can reach people before situations escalate. Again, the early intervention is critical. And finally, a shared framework of partnership where housing providers are part of the solution and supportive service providers have the time, tools, and resources they need to succeed. Our members want residents to succeed in their homes, but they cannot and should not be expected to shoulder this responsibility alone, which we believe, again, the council and the committee agree with. This must be a shared effort supported by meaningful district investment and strong coordination amongst agencies and partners. We thank you, our entire association, for the opportunity to testify and for your continued focus on building a system that supports housing stability, safety, and dignity for everyone who calls the district home. We're happy to answer any questions, continue working together, and we look forward to making progress on these critical issues.
Thank you. Mr. Taylor?
Good afternoon, Chairperson Fruman and Chairperson Henderson, and members of the committees. My name is Timothy Taylor, and I am the president of Voucher Residential, a property management company that has served this city for more than 95 years. We manage thousands of apartment homes across the district, including a significant number of residents who participate in DC voucher programs. I have met with Ms. Lance. I would like to thank her for her comments, and I do validate her concerns. Let me begin by emphasizing that we fully support the District of Columbia's commitment to affordable housing and to ensuring that residents with behavioral health needs have access to stable housing. Many of our voucher residents are wonderful tenants who respect their neighbors and take pride in their homes. However, we are increasingly encountering situations where residents with serious behavioral health challenges are not receiving the support or supervision they need. Without that support, property managers and on-site staff are often left to manage behaviors that go far beyond the scope of what a housing provider is trained or equipped to handle. These include repeated lease violations, verbal aggression towards staff and neighbors, property damage, and in some cases, unsafe or threatening conduct. These incidents not only create instability within the building, but also impact on the well-being of other residents who are maintaining their housing successfully. When these challenges arise, we follow the required processes, contacting caseworkers, documenting incidents, and reaching out to agencies for assistance. Unfortunately, we often encounter delayed responses, limited follow-through, or no action at all. Caseworkers are frequently overwhelmed, and behavioral health interventions rarely occur in time to prevent situations from escalating. This lack of coordination has very real consequences. Our on-site property teams are placed in unsafe and unsustainable positions. Residents who engage in disruptive or harmful behavior remain housed without receiving the treatment or support they clearly need. Other residents feel unsafe and ultimately decide to move out. The result is a deteriorating environment that undermines both housing stability and community trust. In most cases, we are not asking that residents with behavioral health challenges be penalized or displaced. However, we are asking for stronger behavioral health support and more active case management for voucher program participants. That includes timely communication between housing providers and agencies, clear accountability for follow-up, and access to mobile crisis teams or behavioral health professionals who can intervene easily or intervene early when issues arise. Housing providers like Voucher Residential want to be part of the solution. We see firsthand where the system breaks down, and we believe that with the right behavioral health infrastructure and agency coordination, many of these residents can remain successfully housed while preserving the safety and stability of the broader community. Our goal is the same as yours: safe, supportive housing for every DC resident. But that goal cannot be achieved unless behavioral health support is integrated into the voucher system in a meaningful, consistent, and responsive way. Thank you for the opportunity to share this testimony, and I would be happy to answer any questions. Thank you.
Thank you. Ms. Royster, good to see you.
Likewise. Good afternoon, Chairpersons Fruman and Henderson. Thank you for the opportunity to provide testimony and insight into a housing provider's point of view on this very important topic. My name is Ariana Royster, and I'm a AOPA board member and a property owner. I have seen firsthand both the successes and challenges of housing stability efforts in our communities. I initially set out to talk about one of our most pressing issues in terms of the lack of comprehensive wraparound services to support individuals and families once they're placed in housing. However, after being able to review the extremely comprehensive handbook and training slides that were uploaded by DHS and DBH, I believe there's a major disconnect between what the housing provider views as wraparound services versus what the government is providing, which is quite expansive, however, lacking in one vital area: training, education, and consistent communication with the housing provider. After scanning the hundreds of pages of detailed steps to housing residents, I could only find less than 5 pages that address the relationship between the housing provider and the agency. So I want to talk today about what happens after the resident gets the keys. On paper, a successful housing placement looks like a win. But for many of the residents we serve, that's actually when the real challenges begin. While securing an apartment is often celebrated as a success, too often there are no consistent support systems in place to help participants stabilize and acclimate to their new living environment in multifamily housing. People are moving in with complicated lives, mental health needs, trauma, substance abuse recovery, or years of housing instability. And they're expected to suddenly thrive without the necessary coordination between service providers and housing providers. That simply isn't happening at the scale or quality needed. One of the biggest gaps is communication between case managers and housing providers. Case managers are often passionate and hardworking, but they aren't trained in the day-to-day property management operations, and property managers are not trained social workers or case managers. The lack of understanding leads to frustration on both sides. Property managers feel unsupported and case managers feel overwhelmed. The people who suffer the most are the residents caught in the middle. This disconnect leaves both housing providers and residents frustrated and ultimately undermines the long-term goal of housing stability. Additionally, the participants themselves are not often adequately prepared to be housed. The pre-housing orientation or readiness training to set expectations like rent responsibilities, maintenance requests, neighbor relations, is not yielding a successful transition. The high turnover among case managers severely impacts continuity of care. Residents lose trust when their support contacts change repeatedly, and housing providers are left without consistent points of contact. Each new case manager must build relationships and rebuild relationships and learn the history of each household, delaying interventions and allowing preventable problems to escalate. Furthermore, housing providers are often led to believe that case managers are all social workers, but that is not the case. While it seems the agency is staffed with licensed social workers, their interactions directly with residents are extremely limited in our experience. We have even sadly experienced case managers that are afraid to visit their clients and have asked our staff to accompany them. We need to build systems that connect housing providers and service agencies, not leave them working in silos. Stronger and more effective resident readiness programs before placement, and a renewed focus on retention and support for case managers to reduce turnover. Stable housing requires more than just a key. It requires coordination, consistency, and care. Because when we give someone housing without the tools and support to keep it, we haven't truly solved the homelessness. We've just delayed it. So thank you for listening and your commitment to making housing stability a reality in our city.
Thank you very much, Ms. Royster. Mr. Selfridge?
Thank you, pardon me, and good afternoon. My name is Greg Selfridge, and I'm a Ward 6 resident and managing partner of Novo Properties. Novo Properties has been operating in DC for over 20 years and owns and manages approximately 1,500 apartments in the District of Columbia. Novo largely operates naturally occurring affordable apartments and provides housing for a cross-section of DC that reflects the city population as a whole. While the DC affordable housing market faces many challenges, the breakdown in supportive services for high-need residents is a crisis within the housing ecosystem that negatively impacts all residents and the housing providers that serve them. Thank you, Chairperson Henderson and Chairperson Fruman, for convening this important roundtable. Far too often, we have found case management for subsidized tenants to be inconsistent, opaque, and unaccountable for the services or lack of services that are delivered. While there are an overwhelming number of good operators and individuals in the space, many others are ineffective, unengaged, or just plain uncommunicative in the face of crisis. Our preference is always to work collaboratively with supportive services to resolve tenant issues, and we welcome their partnership when they bring issues or concerns to our attention. However, far too often we have found ourselves resorting to the court system to resolve behavioral issues that are destructive to the community at large, the tenant in question, and the property owner. As housing providers who are on the ground day in and day out, I am speaking from personal experience. We find that there's an inverse relationship between the amount of supportive services needed and the ability to effectively provide the services. Said another way, the larger the problems, the less effective the support services are. From our perspective, support service providers lack the tools to solve the really difficult problems that can plague a community. If a tenant is uncooperative, unable to change their behavior, or housing problematic other occupants that are not even on the lease, I do not believe that the tools exist to force those tenants to comply. Or if they do exist, I have rarely seen them employed. As a result, the landlord is forced to petition the courts in what is a lengthy, expensive, and ultimately destructive process for the tenant, the housing provider, and the surrounding community who is forced to endure the disruptive behavior for far too long. The district has embarked on the laudable goal of housing everyone that we can possibly house that is in need. However, there are people that do not possess the skills to effectively manage the shared responsibilities that being a tenant in a multifamily building require. In that event, wraparound services are proffered as a bridge to fill that gap. In the many situations when they are unable to fill the gap, chaos often emerges. The landlord possesses very limited tools to remedy that behavior. The process is exceedingly time-consuming and resource draining, both from a people and a financial standpoint, and if the landlord is ultimately successful, it often, unfortunately, ends in an eviction. Thank you for the opportunity to present testimony today. I am happy to answer any questions you may have.
Thank you very much. Thank you very much to all of this panel. And I have to say, Mr. Selfridge, I'm particularly grateful for your testimony. When we talk about, this is a hard issue. And when we talk about it, there is a powerful impulse to just talk about improving services. But there is also a dimension of accountability. And we can't forget that dimension of accountability. I think Dr. Simbaris talked about where there are lease violations or antisocial behavior towards another neighbor, person has to move. And if that continues, they have to get a higher level of care than what they're getting. I think you get at this, Mr. Selfridge, when you talk about whether or not wraparound services in a scatter site setting is going to be enough for certain people. And I'm not trying to say that this is the case for every single person. It can be a small minority, but we get to situations, and I know, looking at the folks at this table, you've been in this situation. And I'm not going to name names, but you know who I'm talking about, where there might be a resident who has been physically threatened for years by another resident. And there may be an eviction process that gets stymied by a last-minute twist in the process. We cannot leave that resident exposed to constant threats to her safety. And so what are the things we all want to improve services. I want to improve services. Everybody wants this to work, but when it doesn't work, where it tangibly doesn't work, where one tenant is threatening another, where somebody is operating, doing drug sales out of an apartment next to a family, what can you do and what are the barriers that you are experiencing to trying to do what I believe is the right thing vis-a-vis the other tenant? And I will tell you, I was at a federal city council breakfast and somebody very high up in your company said, it breaks my heart that we have situations like that. And I felt like I wish every tenant association that I talk to all of the time could have heard him say that. But talk to me about what you can do when it breaks down, because the reality is, and it may be a small number of cases, it breaks down and we have to fix it. What do you try to do? What are the barriers to taking action?
So I'll take that. You and I have had many conversations about this issue, and the major barrier that we face is the court intervention. Obviously, we try to work with the residents, we try to identify the case managers, but we cannot control the actions of any individuals in our buildings. And when that happens, the only resort we have is to file a 30-day notice to cure or quit. We all understand that the court process is lengthy. We also understand that judges are reluctant to evict residents. Residents, rightly so, are reluctant to come and testify against neighbors. And so we are only left with documentation, as Mr. Taylor alluded to point to when we go to court. And so oftentimes we are not left with a writ of eviction. The case gets continued, and in the situation that you've talked about, it's been a 5-year process, if not longer. And it's not for a lack of the landlord trying. It's not a lack of financial resources that we have put towards attorneys, financial resources that we have offered residents who are not able to continue to get along with their neighbors to help support them, potentially looking for other places in our portfolio. So it is a difficult and long process, and we feel like our hands are tied because the only option that we have is legal in most cases. I don't know if you want to add to that.
Yeah, I just want to add, I agree with everything Ms. Royster just said, but the big thing is the disruption of everyone that's on the affected floor, the disruption of the broader building, and the time that it takes to try to resolve these issues are months and years. And the affected residents, they don't fully understand why. We've identified this person that is being disruptive and causing these issues, that we can't quickly do anything to remove them from the building. So the disruption that it creates and that it causes is just so negatively impactful for all of the other residents in the building. It's really hard to explain to the other residents that we are actually trying to deal with this issue.
All right, I really appreciate that. And I want to kind of turn to some of the folks in the advocacy world and in the government world on this and echo something that Commissioner Carlson talked about, which is there is actually a deep well of support to try to help people. But then we get into situations that are egregious, and the destructive quality of those situations, there's lots of victims. So there's the victim who's the person who's been threatened. There's the victims of the people who live on the floor, who see it and who are experiencing the person down the hall who's screaming all night. But there is also support for the enterprise, because the more we see with these kinds of issues and don't all work together to try to come up with solutions so that we're meeting people where they are and not just wishing away problems, the more at risk support for the program over time is. And so I implore us all to work together to try to figure out how we can make this system work, and where it's not, acknowledging it and trying to come up with solutions. That's what today is about. That's what the work of ANC3F has been about. And that's what tomorrow is going to be about too. So with that, I'm going to get off my soapbox and turn it over to Councilmember Henderson.
Thank you. Thank you all so much for being here and your commitment in terms of the affordable housing, being an affordable housing supplier. Mr. Selfridge, you know, the properties that you talked about, right, naturally occurring affordable housing is super important in terms of the ecosystem that we have. I have a few follow-up questions. Ms. Royster, in your testimony, you talk about that you felt like there was a disconnect between what the government believes is wraparound services versus what the housing providers believes is wraparound services. I'm curious when, and I think for both of your companies, given its history in the district, you know, your participation in the PSH program probably extends beyond your time working for those companies. But when you were providing an explanation of what this would look like, what were you all told?
So just to be clear, what housing providers view as wraparound services. I know the government obviously has their definition, but what housing providers view as wraparound services, I was never provided what that looked like. And I was so thankful that I had the opportunity yesterday to actually look at their handbook, to look at the training. I mean, there's 3 days worth of training that is provided to, I guess, the community-based organizations and the case managers and everyone who works with trying to house an individual. But there's no training for housing providers. So I have, the knowledge that I have about the program is knowledge that I sought out myself to try to assist our teams when I was with the company, and knowledge from very good friends who are licensed social workers, because I would call them constantly to say, how do I address this situation? So if there was more training, if there was training, period, I guess, and that's one of the things that I alluded to in my testimony, that we would like to work with the CBOs and the case managers, not just to process the voluminous pages of data that, or paperwork to get the person housed, but let's have that same type of energy and that same type of time when it comes to how are we a partner with you to make sure that this resident of ours and your program participant is successful. And so we just learned, well, I learned through, again, the information that was uploaded, that there was a initiative on Connecticut Avenue for the apartment communities to have case managers visit the communities on a daily basis. It was supposed to have started the beginning of the year, but we just learned that it happened last week for the first time. So that's a step in the right direction. But the greater team didn't know that until I saw the testimony of one of the government officials. So I'm glad to see it, but there's a lack of communication when it comes to putting that information out, so that AOBA should be the first source because they are the,
I think we collectively represent the industry. So
Thank
similar
you.
to what Brianna is saying is, so often we have members of our community, property managers, who they have to seek mental health services because of the situations that they're put in where they're not equipped to be put in those situations. And for a long time, with all due respect, there was a very adversarial relationship with housing providers, with landlords. And I do believe that we are bridging that gap, that we are recognizing that we need one another to work well collaboratively. And so providing us with information, with outreach, we can disseminate that information. We can put on seminars, we can put on webinars with our housing providers. Yeah, we need professionals. We can't do it ourselves. We need it to be someone from the government who says, no, this is correct. This is how you should do it, or you have taken the right steps.
So let me ask you, and this is helpful feedback. When you all have a particular issue that occurs at your property, do you have a number to call prior to the hotline? But like, what happened before the hotline existed?
I smile because I'm the person you were talking about
Yeah.
that reached out to you on the weekends. That's what happens. There was an initiative a couple of years ago where there was a hotline number, and we had a couple of management companies that were doing this beta testing to see how effective it would be. And we were excited, and I was gung-ho to help, and it just sort of fell off.
Yeah.
And so right now, the only thing that we do have is the crisis hotline number to call.
But that's for crises. And sometimes
So
a beginning incident might not necessarily elevate to that. I guess I'm trying to understand is like, what conversations, if any, do you have even back with DHS? Or, I mean, I don't know if you have the information to even know who a person's case manager is. I imagine that's not necessarily information that's shared with the property. Oh, it is?
And that's why I talked about the turnover, because when the individual moves in, there's typically a case manager, and we have the case manager's contact information. But if there is an issue, oftentimes when we go to reach out to that case manager, they are no longer employed, or they're no longer that individual's case manager. And so then you try and go through the telephone circle of trying to figure out who the case manager is. Now, again, I applaud the efforts of the government, because there have been many efforts that they have tried to communicate, but they haven't always been successful. So there was a database, a website that we were supposed to go to with DHS. I had many, many meetings with DHS about this, but that website isn't always updated. And so again, we go back to trying to figure out who's the right person to talk to. And obviously the resident isn't able to give you that information because sometimes they're just not wanting to talk to us, or oftentimes they don't want us to call their case manager, or they don't know who their case manager is either. So that's why the communication piece is extremely important in terms of us being able to reach out to the right person before the situation becomes a crisis. But right now, that's what we're relying upon, is the hotline.
Okay.
Yeah, I just
Mr.
want to
Taylor?
add that ideally, the caseworker would be the first person that you would want to call. And from an on-site perspective, personnel perspective, if you're not able to reach that caseworker, which in most cases you're not, you're left with, who do I call? That's the big question. And depending on the severity of the issue, it's 911, right? That's your last resort, is to call the police to try to get some help in resolving the matter. But we want to be great partners, and we want to have this partnership, but our team members are not trained or equipped to deal with a lot of these crises. And when you're not able to reach out to someone who should be able to deal with these issues, it just prolongs the issue, and it's just not helpful not knowing who to contact and having those resources to help you deal with issues in a quick manner.
Yeah, Mr. Selfridge?
Yeah, thanks. I just want to echo that. It's really tracking down the casework can be one of the more difficult aspects. There's a lot of turnover. From time to time, there are some great caseworkers and great organizations out there, but there is a lot of variety, and that can be the largest challenge. I also think that they're limited. We've had cases where there's extreme behaviors where we need interventions. And, the case managers really only have soft tools at their disposal. If somebody rejects their interventions, I think they're stymied. I don't think there's much left that they can do. And then it moves into an enforcement judicial phase. That is long and that is expensive and that is damaging to all parties. I also want to point out that there's people sitting up here from larger companies that are well-resourced, who have large staffs that are highly committed to this process. There's a whole ecosystem of smaller housing providers out there that don't have the time, the resources, the background, or the knowledge to navigate this. It's one thing to say that there are resources available, hotlines, numbers to call, seminars to attend, handbooks to read. But there's a lot of people out there who can't do that, and they suffer, and those communities suffer. So it's not just the large buildings on Connecticut Avenue, which are very, very important, but are blessed with great property management and an engaged tenant association and an active ANC. There are communities all over this city that are suffering in silence because they don't have the access to those resources. And there needs to be a larger intervention to try to serve everybody, not just the larger landlords.
No, I hear you on that, and I appreciate that. I've heard from some of the smaller landlords in sort of the one-off situations, and then they're the ones, like you said, are sort of they don't know who to call. And in those situations, more often than not, are having to rely simply on the judicial system to help navigate or solve some of the challenges. I'm curious, and I don't know if you all were here earlier, but the first witness, Dr. Sombreros, talked about percentages, right? And sort of trying to avoid over concentrations, if you will. And I don't know if your property companies have ever sort of done an audit of, I guess it would be payer mix, maybe not, I don't know, but to sort of see like, okay, there are some buildings where you might have some imbalances in terms of one particular type of, trying to find the word, but you guys kind of know what I'm talking about. Have you all sort of looked at that? Your companies? I don't know.
Yes. There are instances, and Councilmember Fruman talked about source of income. And so there is no resident who comes to apply that we do not allow to apply, right? So whether you have a permanent supportive housing voucher, whether you have a HCVP voucher, everyone who applies and is qualified can live in the building. As a result, there are some buildings that I will just say are more than the 25 to 30% that the doctor talked about. So yes, there are buildings that have a much higher concentration.
Okay. One of the things you also talked about is that the existing sort of onboarding process, like once you've gotten your keys, now what's next, sort of going through the steps, et cetera, isn't perhaps sufficient. I'm trying to think back to like, last time I was a renter, but like, they give you your keys, they give you the handbook, if you will, of like, here's where you pay the rent, here's who you call for maintenance requests, this is how you book the room, this is where the fitness area is, X, Y, or Z. It sounds like you're suggesting that there needs to be more, not on your part, but from the part of the case managers in terms of going through that information step by step, because I don't know if property managers do that step by step. Let me sit down with you and go through the whole packet, as opposed to just handing you the packet and saying, and having the expectation that you'll figure it out.
If I could answer that, I don't think that there is enough in terms of someone who is there are things that a property manager can tell a tenant who perhaps hasn't lived independently before that could be helpful. And there are things that a case manager would be able to tell them in terms of, okay, how do you make sure that you maintain this stably? What is paying rent on time look like? What does all of this look like? If you have issues, just like you said, or if you have a behavioral health challenge that comes up, who do you call? I feel like that is lacking because there are plenty of areas in which a property manager isn't even allowed to touch a conversation. So while they can give you certain logistical information, they can't touch plenty of areas that are very delicate and where a case manager would be better suited. And we do think that if you do that early on, you establish that trust early on, I think you can have a better long-term success. But I don't think there's enough in terms of when someone moves right in.
Okay. Thank you. I've gone over my time. Thank you. Thank you all for being here.
Do you mind if I just add to that?
By all means.
So all of that is actually very factual and very accurate. I think what would be helpful is when the case manager is meeting with the participant, identifying areas that are challenging for them in terms of their lease compliance, and then meeting with the property manager to talk about those areas where they're having challenges with lease compliance. And I'm very specific about saying lease compliance because I know the privacy issues, and landlords don't want to know, what the situation the resident is in. But if there are lease compliance issues that we can help solve together to help them be more successful, then that would be an area where case management and housing providers can work together to support the resident.
All right, thank you. Thank you very much. Really appreciate it. And if we can move to the next panel, I do want to really appreciate the work that you've done over time. Thank you. All right, our next panel, Christy Respes, Marie Moros Black, Veronica Starr. Okay. Oh, no. All right, wonderful. Ms. Respes, when you're ready.
I think, okay. Good afternoon, council members. My name is Christy Respes, the President and CEO of Pathways to Housing DC. In 2004, Pathways opened its door with the clear mission to end chronic homelessness for people living with serious mental illness. The solution was simple. Ask people if they want housing, and if the answer is yes, get to work finding them a home while simultaneously providing intensive, community-based wraparound supportive services with an interdisciplinary assertive community treatment, or ACT team, like we've heard a lot today. ACT is the highest level of outpatient mental health treatment available. Teams are comprised of a psychiatrist, nurses, social workers, peers, addictions counselors, and employment specialists, all working together to help people recover their lives. It's not an office-based service, and in fact, 80% of the team's time is spent with clients in their homes and supporting them in the community. Since 2004, Pathways has ended chronic homelessness for over 650 people living with serious mental illness using our scattered site housing vouchers coupled with ACT mental health supports. We currently have almost 700 people housed in our supportive housing programs, including PSH and our ACT teams, as well as veterans. People enroll in Pathways mental health supportive housing program, maintaining their housing over 90% of the time. That doesn't mean that every person stays in the original apartment they choose. You heard that from Dr. Sambaris. Sometimes their symptoms get in the way and they need inpatient mental health or substance use treatment and they need to move. We rehouse them and modify their supports until they're thriving or we find a different solution that works better. While the solution of housing first is a simple concept, it's complicated and nuanced to implement. It takes creativity, stick-to-itiveness, and a relentless belief that people with even the most serious mental health challenges recover and can live successfully in the community of their choosing with the right supports. Why am I sharing this history lesson? Because I worry when I hear words like housing first isn't working. Housing first is working. I implore us to pull up and look down on the facts. There are currently 5,400 people housed in the district's PSH program, and that's amazing. We are celebrating the city's commitments to ending homelessness and continuing scaling our housing and prevention solutions to meet the need. We also know, we've talked a lot today, that a small percentage of people, primarily with substance use and or mental health challenges, are struggling to maintain their housing and be good neighbors. This is where we need to focus the talents and resources of DHS, DBH, and our community providers to find new solutions, fix what's not working in our system, and create innovative new strategies, such as the program Community Connections we'll talk about, and the solutions we outline in our written testimony. Attached to my written testimony is also a detailed list of gaps and challenges that our PSH program staff have identified and some corresponding potential solutions. I won't read them all, but I wanted to give voice to a few. The first area that needs improvement is coordination, collaboration, and communication between PSH and mental health providers, both community support workers and ACT teams. While the majority of DBH certified mental health providers provide high quality of care, even the best providers struggle to answer calls and coordinate services when someone is struggling with their mental health in ways that impacts their housing stability. A recent and extreme case involved a 70-year-old PSH client we were working with. Our team reached out to the CSA requesting they conduct an FD12 or involuntary commitment due to extreme psychiatric decomposition and concerns for his safety. The agency didn't follow up. Things did not end well. Finally, the CSA is now doing paperwork for guardianship, but he's since been arrested for shoplifting and a Five Below. We believe with earlier intervention from the CSA and better collaboration, his case could have had very different outcomes. This is not just true for PSH providers. Our clinical staff have seen multiple instances in which CPEP documents their inability to reach CSAs. I'm going to kind of leave that there. There's many more suggestions I have for some better coordination there, because I really want to jump to my testimony around assertive community treatment. Another theme is around access to care, specifically for assertive community treatment team referrals. We know that PSH case management is the intervention that works for the vast majority of tenants in the program. Case managers connect people to community-based resources to meet their physical health, mental health, and social needs. The success of this intervention is evident in the number of people who remain successfully in housing. Pathways believes that DHS needs to collaborate with DBH to modify the enrollment process so that if a person needs an ACT level supportive care at the entrance, they're assigned to an ACT team in addition or in lieu of a PSH case manager at the time of enrollment. This needs to happen while the person is literally experiencing homelessness so that it's the ACT team building connection and rapport throughout the housing process. This is the way the original Pathways Housing First program, both in New York and DC, was designed, and how we have successfully moved so many people that were historically seen as resisting care. In this model, the relationship continues with the person as they move into housing and beyond. We've seen that time and again that when a person needs ACT level of care who has no insight into their mental illness is assigned only to a PSH case manager, it becomes almost impossible for them to enroll in ACT once they've moved into housing, unless they admit to having a mental illness, which many people do not. So I'm going to leave that, stop there, because I have many, many thoughts about all of this and suggestions in the chart that it's attached, and I look forward to hearing some more questions.
Thank you very much. Marie Morales-Black.
Yes, good afternoon. Thank you so much for the opportunity to testify at this hearing. My name is Marie Morales-Black, and I'm the CEO for MBI, and we are a large agency that provides behavioral health as well as permanent supportive housing and homeless prevention programs. This past year, we served over 600 people in our homeless prevention program, which means keeping them from getting homeless in the first place. And then we served over 800 people in our permanent supportive housing. And I want to share that of those 860-something plus people, 2 had some serious behavioral health issues and was creating havoc at their apartments. 5 was evicted. And 3 of those 5, we probably could have kept them from getting evicted if we had the teaming that we have as policy that's supposed to happen, that in that particular case did not happen. And so I'm saying that to say that, yes, we still have some work to do. However, overall, the system works. 0.01% is the behavioral health problem that the 800 something people, serious behavioral health problem that our team has. It's less than 0.1% that actually had gotten evicted. So when you do the work well, it works. When you do the wraparound services, it works. When the system gets together and communicate, it works. And so I agree with my colleagues in that the permanent supportive housing program works. Some people will graduate when you hear opt out. That's okay because that means they've done well, they've succeeded, they've paid their rent, they keep their rent going, they are good neighbors, and that's okay. I have a couple of suggestions that I feel would be very supportive. One, I agree with our expert witness. 20 cases is too high. I think 15 cases would probably be the way to really provide the supports to many of the people that need to have it. The other piece I want to say is that when you have folks who've been homeless for 7 years, for 14 years, they need an adjustment period. And we also have to support them and retrain them on how to be good neighbors. Communication and relationship with the landlords matters. I ask my case managers to touch base with the building managers whenever they go to see to make sure all is well. And so they do know who the folks are. And I also ask them to go with to the participant when they go lease up so that they know that they have support. And so that really matters. The other piece is that communication between the DBH providers and the PSH providers has to improve. Often, the participants are receiving services from both agencies and neither one knows that it's happening. And if the participant does not share, they know that that's happening, the communication does not work. And we know that when they work together and provide supports to those folks that we serve, they get better outcome, they stay housed. The last piece I want to share is that shared responsibility of the tenants and the participants. We have something at MBI called Real Talk, having difficult discussions with the people that we serve. And they also have to understand that they have some responsibility to their own well-being and to stay housed and to do house with our support. And we have found that whenever that has happened, sometimes we bring them in, we have those discussions with their clinical team as well as their case managers, that needs to happen. And when we find that those things happen and those communication and seamless support occurs in a teaming, those participants get better outcome. And so for me, I think that there's room for improvements in the system. However, we do need to make sure we pay the case managers. We make as part of the cost of living adjustment that is mandated to go to the salary of the employee. We've had that in New York. We can do it here so that we can sustain the people that we serve and reduce turnovers. Because the turnover in this case is really, really high. And part of it is because they don't get COLAs and they don't get the cost of living. And I think that would also have an impact in the success of the program. I know I'm running out of time, but I think it can get better. I think that if we work together, it will get better. But we all have to work as a team to make sure that these vulnerable population get what they need. And for those who are, lastly, those who are seriously and persistently mentally ill, transition bridge housing is key because we have to help them to adjust to neighboring living again before we just put them out there in an apartment with other different folks that sometimes they don't know how to adjust and really, and they're lonely, and to support them in reconnecting with the community system.
Thank you very much. Veronica Starr.
Good afternoon. Thank you, Chairperson Henderson and Chairperson Fruman, and members of the committee. for the opportunity to testify today. My name is Veronica Starr, and I'm a licensed independent clinical social worker and the clinical supervisor for Everyone Home DC's Permanent Supportive Housing Program. Founded in 1967, Everyone Home DC's mission is to support the holistic needs of individuals and families at risk of or experiencing homelessness in the district. We envision DC as a thriving and diverse community where everyone has access to safe, affordable, and comfortable homes, regardless of wealth or social status. I'm here today to talk about the work of our Scattered Site PSH program and the efficacy of the supportive services we provide to help people exit homelessness and remain in stable housing. Before helping launch our PSH program in 2023, I spent 7 years working alongside parents and children at DC's Child and Family Services Agency, supporting them with wraparound services and addressing and remediating barriers that led to abuse and neglect. There, the value of safe and secure housing and regular in-home supportive services was evident. Transitioning to PSH was an exciting and seamless move as it focuses on housing as a foundation for stability and provides tailored, person-centered case management services and home visits. Since launching our PSH program nearly 3 years ago, we have housed 60 households and are currently working to house 36 more. Because our program is new, almost all of our clients needed to be housed, meaning we had the opportunity to work closely with each person to identify units they were excited to make their home. This could mean selecting the right neighborhood that's close to family and friends, schools, or medical providers, or finding a unit with the right amenities like a washer and dryer or building concierge. Moving people into the homes they choose has been the laser focus of our program since day one. It should come as no surprise that this is a lot of work and requires a high level of skill. Not only are we meeting new people, working to gain their trust, and building lasting relationships, we're also acting as real estate experts, identifying units, working with landlords and management companies, and navigating an overly complicated bureaucratic voucher process. Once clients move into their apartments, our goal is to ensure they remain stably housed. As case managers, we are a steady presence, a resource, an ally, and a connection to other resources. Our team conducts regular home visits to support people in their environment, where we can communicate with landlords regarding repairs, link people to benefits and community resources, and track rental and utility payments. In circumstances where people are hesitant to let us inside, we turn to our creativity and motivational techniques to get in the door. By and large, the people in our program are doing well. Currently, we do not have anyone in landlord-tenant court and only one person with a 30-day notice for a lease violation. This is not to say that there are no challenges, but the challenges we encounter do not differ drastically from those faced by tenants who are not in subsidy programs. For the small subset of people in our program who present with behaviors that could impact their tenancy or their ability to be a good neighbor, we believe the right approach is to provide ongoing and consistent support. Through long-term engagement, listening, and meeting people where they are, we do make progress. As an example, one of our clients was experiencing paranoid thoughts about things she believed to be happening in her building. We worked alongside her mental health provider to ensure she remained housed while advocating for her needs with her landlord. We were able to communicate directly with the landlord while she was able to process her emotions in therapy so that the issue could be resolved in a timely manner. I also want to highlight the benefit of the Scattered Site program model as it allows people to relocate to resolve tenancy issues. Over time, we might discover that a person does better in a smaller building with only 4 units versus a large building with hundreds of other tenants. The flexibility that Scattered Site housing provides can improve tenancy outcomes. On the subject of tenancy, landlord engagement is crucial. Our case managers start building relationships with landlords during the application process. That way we can partner with them when there are concerns. We appreciate the ongoing communication and want to make sure we address concerns to the best of our abilities. We also recognize that there are limitations to our reach and we cannot always resolve concerns on our own. Sometimes the appropriate call is to the community response team or 911. As a Housing First PSH program, our charge is to help the people we work alongside achieve housing stability and optimal levels of health and wellness. Housing First does not mean housing only. It means that we must take a tailored approach to allow individuals time to engage, providing them with options for a broad range of services. We are a consistent presence in the home to help navigate housing-related concerns. I'm excited for us to reach a point where we're working on housing stabilization with everyone in our program. I will close with some thoughts from a mother in our program. She told us that she is truly blessed for the opportunity to be in PSH. She went on to say that she believes anyone affiliated with PSH will be successful due to the backbone and foundation of support provided. She compared the supportive services to a one-stop shop where she is able to get information from her case manager versus having to run around and find everything on her own. I'm proud that all of our team has accomplished, and I look forward to celebrating more stories of people feeling blessed to have the opportunity of PSH. Thank you again for the opportunity to testify, and I'm available to answer any questions.
Thank you. Thank you very much. And with MBI in front of me, it reminds me that before I joined the council, I was on the Superior Court fiduciary panel and represented folks who needed support in different ways, and found myself at the MBI offices a number of times and was always struck by the empathy and professionalism of your team. So thank you for the work that you're doing. With now moving from that PSA, one of the things that that you said, and I want to get opinions from others, was the case management load. 20 was too high, 15 struck you as more appropriate. One of the things in the conversation with Dr. Sambaris was this idea of acuity, and where it might be 20 low acuity folks might make sense, but 20 high acuity folks wouldn't make sense. And I'm curious, for Pathways, do you measure acuity and take it into account in case management? And I'll ask you as well, in case management assignments?
Sure, and we keep our case management around 18-1, and we've been a long-standing provider since 2008. So it really, size matters, and also the time, length of time, right? When you're housing everybody newly for the first time, much higher acuities typically, but we have people who've been in the program for many, many years, since it opened in 2008. So we really work on getting a balanced caseload for people, but it really, so if you have a new program that's housing a lot of people, you need even a lower caseload, right, than the 18, like a 15-1. As people get better and recover, it really is about managing the scale. Like, you know, we have some larger programs, so we can manage that scale a little better. But in times of growth, we have to reduce the caseload so that we can, especially with newly housing people, help them get the stability they need. Yeah.
You know, when I looked at the spreadsheet of all of the different numbers, and they varied, and it was hard to know why they might vary because you couldn't see underneath it. And do you have a reaction on that?
Yes, we have tried to keep it between 15 and 17. Unfortunately, we are down a case manager now, so we are pushing 19, which thankfully we have more housed, but it is definitely something to keep in mind, because those requirements to see them, you're taking them to view units, you know, you are running around a lot more than just, I'm going to come to visit you and sit in your home and give you, you know, the hour to 2 hours that you need to kind of talk.
Our ratio is 1-17 for individuals and 1-12 for families. And as everyone said, is that when you have a case manager who has left and you're trying to fill the vacancy, sometimes it goes up to like 19.
Please hear it for what it is. It's not trying to be critical of any of you, but to figure out how do we equip you so that you can fully serve the people who you're serving.
Okay. No, I was going to say, when you speak to the acuity level, at MBI, one of the things that we do is we ask the case managers in consultation with their clinical supervisor. Because a few years ago, DHS moved to having a clinician to supervise the case managers because they recognized that there were some challenges that you needed that clinical expertise. And since then, all of the supervisors have to be clinicians. And I think that was a good move, even though at first we pushed back a bit, right?
Trying to find that.
Because staffing clinicians is really hard. However, what we find is that the case managers in consultation with clinician is to provide the expert services that the person with high acuity needs, right? And sometimes that's behavioral health services. And therefore, part of the case management role is to also make sure that they connect that person with the additional resources that they need for support. Because the case manager can't do it all. And then work together to really make sure that those services are happening and they're seamless. And for some, it may be ACT. For some, it's just regular, it's therapy. For some, it's therapy and community support or community support. But that's part of how you address often the acuity level within the system. At least that's how we do it.
So recognizing that what I'm about to suggest would increase the burden on case managers and might suggest bringing the caseload lower is one of the things, and that worth thinking about is, should there be settings in which home visits are more frequent than what we have now? And one of the things that jumps off the page from recent experience is where there are families with young children, and we've seen, it's not, all of this can sound like an indictment of the whole program, but the whole program is a success. It's just the cases where it isn't a success, but where it's children involved, rings an alarm for all of us. So how would you react to the idea of increasing the frequency of home visits in settings where there were lease violations, so there was issues in getting along in the community, in cases where there were young children, where you wanted to make sure things were going well? What's your reaction to ideas like that?
I think first of all is go back to the data, because I don't like to make these decisions on feelings, right? It feels like people aren't being seen, or are they, or aren't they? And this is where DHS actually has the data. So I would say yes, open to lots of creative ideas. I think I can't speak to the families. I'll let our two other panelists speak to the families. But on the individual side, I do want to add a couple pieces. We have an older and aging population. I will tell you, I think what would be more useful is just as useful, but to decreasing case sizes, we need to layer on some additional supports in PSH. We need really like an RN for one for every 150 or 200 people, so that we can focus on healthcare and care coordination. Our case managers, the goal of a case manager is to connect people to services in the community, right? But we have an aging population with very complicated and comorbid health conditions, because we targeted well who's moving into PSH. I've run the numbers in our program. It's not surprising how quick that people are aging and need more medical support. And there's a lot of barriers to getting that kind of care. And so really layering on, and not just, the program is different than it was, 20 years ago. We evolve, we innovate. I think looking at the service needs of the people we serve is going to vary based on agency, but also how long and the age and demographics of people in the program. So some supports are definitely needed differently. I don't think it's just caseload, but also expertise.
All right, thank you very much.
We serve 215 families, and those 215 families represent 517 children. It's a lot. And we do, that's one of the reasons that the caseload is 12, right? And one of the things that we have to do in preparation for that work is we have to see those families more often. Once a family is housed, they should be seen at a minimum. And again, it says it in the contract, and it says that, and I reemphasize that for my staff, right? It's a minimum of twice a month to make sure that they're okay. And I think, and so when you have a family with a lot of children and they're having issues, you'll see them more than that. And so I think that the case managers are also responsible not only for the housing, but to also connect those families with resources to meet the needs of those kids.
Okay, thank you. When you say see them, to what extent is it a requirement for you that they lay eyes on all of the children, or is it just touch someone in the family?
They are supposed to do a home visit with the family.
The whole family?
Yes.
Okay.
I would just like to add that I believe it's not necessarily the frequency, but it's the quality of the case management. It's the quality of the home visit. It's connecting, it's talking to the parent, understanding if there is a barrier to wanting to let us in and a barrier to want to connect to resources or truly spending time to listen to them to understand what the family's needs are. That way it isn't just, oh, I need to see you and then I'm done. I want to see bodies. Okay, I'm out. It's understanding what is the challenges. Do you need daycare referral? Do we need food? Is it job readiness? Are you needing to work? So how can we figure out how to build the relationship so that we are being welcomed and we are continuing the communication? Because it should be, I mean, I know that some of our case managers talk to clients daily and know exactly what's going on. There's a birthday, there's this event at school, whatever it is. So I think it's building that relationship and putting in the quality work to understand the needs.
All right, wonderful.
When I mentioned the data, what I also wanted to share is that we are seeing people as frequently as they need to be seen when they allow us. The minimum is, as Dr. Black said, the minimum. And I know that DHS, can see in the database, like that people are being seen much more frequently oftentimes. So I think using that data to figure out who has the highest needs back to the acuity and are they then getting the right level of care that they need is something that we do individually as agencies, but I think can also probably happen in monitoring if it's not.
And it's a work in progress, right? I want to be very clear that it's a work in progress. Supervision matters. Folks don't always write down, document all that they do, and we're working on that. But I want you to hear that as providers, we are really working hard to make sure, at least the providers that Pathways, MBI, I can tell you that we talk to one another and we are trying to work diligently with our landlords to make sure, and our participants to make sure that they are doing and their well-being is good.
All right, I'm going to turn it over to Councilmember Henderson. I actually apologize. I will have just a few more questions after.
Okay. Thank you guys for being here. Ms. Respers, you talked about how DHS has the data. And while I hear you on that, and I imagine that they do have some type of data, in the pre-hearing responses, I think we asked 7-10 different ways on particular questions around case management, interventions, et cetera. And the DHS response was, we do not collect that in the aggregate, or we don't have that information in the aggregate. And so it's hard for us to kind of understand then what actually is happening, because if there is no, right, you've got hundreds of individuals. We can't pull the case file of those folks individually to better understand. And so when we have folks who are questioning in the community, how are we tracking? What is our definition of success? It is a little bit difficult. So even on the question of, and Dr. Black, you brought this up, right? Okay, so one of our questions was around how many households have currently opted out of case management. Dr. Black, you suggested that an opt-out of case management or a waive of case management might be because you've graduated from the services, not because you don't want to be involved. Yes?
Yes.
Why would we code both of those things exactly the same way? Why wouldn't we code the people who have graduated as a success story as opposed to somebody who is opt-out or waived?
Because often the people who are graduating, they say, I want to opt out. And then in order for them to be discharged by DHS, right, they have to show that they're ready for it. And those who get discharged are those that are actually ready. So that means they're paying their rent on time, they are gainfully employed, they're doing well, and there aren't any issues with them. Otherwise, there is a revisit of that case, and they are often not asked to participate. And sometimes it works, sometimes it doesn't. But I think that's a very good suggestion that we should label it separately.
Well, because I don't know. Right now, I have a number of 78 families who have opted out. That could be 78 who were successful or 78 who said, I don't mess with y'all anymore. Yeah. I don't know.
But I talked to our staff about this. This was the exact suggestion that came out, which is it seems there are some data issues that we can work with DHS, get in the room and with their data people. We don't actually control the, unlike our behavioral health services, I don't control the electronic health record.
Yeah.
So I cannot actually add the fields that I need to pull the reports, et cetera. So that to me seems like a very simple, our staff add-on that would say anybody who's opting out is either opting out and successfully or wanting to opt out and needing the ongoing services, which I know DHS then is tracking people and providing additional case management. But those opt-outs shouldn't be approved. You know, like you shouldn't be able to opt out of service.
But now I don't have
not
a full, we're having a conversation. I actually don't have a full story, right? Because there is one part of the narrative or hypothesis that a problem with the program is that we don't have what is necessary in the case management. I don't actually know how to sort of define that because I don't actually know what we're dealing with here. Or based on the numbers, it seems as though it's actually a very small percentage of people who are not participating in case management. But then I think there's another level to that, right? How many of these folks are only participating in case management for the bare minimum, i.e. I'm only here so I don't get fined. So you get to 2 visits, we'll have a conversation. You may or may not be able to come into my home. Ms. Ellison talked about before, right? Until I built up trust, I'll meet you at the center. I'll meet you at your office. And then that's it. Versus those for whom are having a much higher engagement of touch. How do you define or quantify that?
We do this individually at the organization. I don't have a way, I'm not that close. I would have to talk to our program managers, DHS, but not that I'm aware of in the current database, the way it's set up. Do we track it that way? We do this in individual supervision with our caseloads every week. Managers are going over the caseloads with each staff member and supervision. So that's where that's happening. The data is not caught in the aggregate that I'm aware of at this level. It is back to acuity, right? Because just also some people like to be seen because they like to be seen. That doesn't necessarily they are the most in need, right? So it's the constant assessment, evaluation around who needs what. And I will say I'm just as concerned about people who aren't necessarily going in for psychiatric crises if they're quietly dying and not thriving in their apartment, right?
Right.
There are people who aren't doing well who we are continuing to engage and get creative with. So it is really caught on the provider side, and I don't believe it's aggregated well.
Okay, so on the provider side question too, another thing that I had a question about is it's entirely possible that someone can have a case manager with you. It's entirely possible that a family can have a case manager with CFSA. And so they have said, you know what, I don't actually like my housing case manager, but I'm cool with my CFSA case manager, so I'm talking to them. What is the level of coordination when you all know that someone has another touch with a government agency in that way? Is there any communication? Would you all even know that?
Yes, there's communication. So we do, when families are transferred to us from a different funding program, FRSP, rapid rehousing, we do a warm handoff. We're meeting with the outgoing worker and the family, the head of the household, to understand, are they in tenant court? Do they have past due balances? Are they dealing with other agencies? Is there an open CFSA case? We definitely are trying to understand all of that, to understand what we're getting, what kind of case we're getting and what services to support it. So there is, in one, I always ask for us to get every single contact person of anyone that the household is working with so that we can team and we can fully understand, and then go to that specialist. It's CFSA worker, they're going to understand this issue. It's a mental health provider, they're going to understand, let's lean on the other services.
Yeah, but are there any situations where all of y'all get together and talk about it?
It varies for the case, but if it's needed and it's going to be beneficial, absolutely.
It needs improvement. I can tell you right now, I'm being very transparent.
Thank you.
Okay, I'm being very transparent. It needs improvement. As a large provider that has mental health, and PSH, sometimes even in my own house, they're not talking to each other. We've had to straighten that out. Okay, and part of it is because the 2 departments didn't know. Okay, and so my sense is that's one of my recommendations, is that we have to be able, I believe Jack Fogel let us do this, right? With care coordination for mutual clients. And I had to say to my staff is that if it's for best interest and planning for that consumer, you should talk to each other. This thing about, oh, it's mental health and I can't talk to you is BS. So you got to talk to each other. And I think interdepartmentally, that's one of the recommendations that I did make, is that I do think that DBH and DHS should be walking their data. And if they have matching data, they should be letting the agency know who belongs to whom so they can make sure they're doing coordinated services. Absolutely.
Yeah, I think this is probably one of the hard parts is like with my health hat, I'm like, well, we've got a whole, it's called Chris. We got a whole thing where you could type in the person's information and pull up when's the last time they've seen the whatever. And on the housing side, y'all don't have that.
Yeah, and I'm so glad to bring it up. This is in my written testimony. This is where I go much deeper on this is probably one of the biggest challenges is that care coordination, right? Because for lots of reasons, sometimes we don't know, but even when we do know, many providers are fantastic and respond and we case conference. But what we really need from DBH is a process by which if we cannot, and we are not getting responses from a provider, sometimes they're in-house and we handle it, right? But externally, there has to be a way for our case managers to reach out to somebody at DBH to say, we are getting no response. We're getting no response. We've worked it up our chain. You know, if it's Marie's agency, I'm calling her, she's calling me, but we need a formal structure in place that we can report these things.
Mm-hmm.
Another thing is CRISP actually does not have MHRS data in the way that we need it.
Yeah.
And that's a big problem. So we are really, really excited about the hotline that was created with the Public Service Health Corps for outreach to coordinate with behavioral health. And we need that extended, staffed, and kept open so that we can do the same thing, because often clients don't know who their community support worker is because it's turned over, or they don't remember what agency they were with. And so best efforts, but I'm excited though, because these are operational issues, right?
Mhm.
Some things are resource issues, but a lot of this is operationalizing and getting the right people in the room, facilitating the conversations, and then holding accountable for the change.
Yeah.
So these are fixable, a lot of these things.
I can't remember which exactly one of you talked about scattered site being an option because it allows, or a better option because it allows for variety, right? Like if somebody, well, I can't do large spaces, 100-person building is just not my deal. Like, let me get a 4-person piece, et cetera. But I'm wondering, as you guys are sort of going through the process and working with clients, are you doing your own audit of how many of your clients is in a particular building, and perhaps maybe that we got too much going on, you know, right there. And so you might advise that they consider a different building in the nicest way possible. And of course, following all legal rules, et cetera, but like just sort of a nudge, if you will.
Absolutely. It's a lot of advising and guiding and informing and encouraging and just providing information and options, because it is their choice, but we can, with our knowledge, say, it seems like this isn't a good fit for you. What about this one? We have a landlord that we do trust who is voucher friendly, who understands what someone in the PSH program is going through. So can we show you that unit? Can we talk to you? But it takes time, and it takes all of that to understand their way of thinking and what's happened. So we absolutely, I mean, internally we are constantly, is this the right fit? Where can we move them? What other options do we have?
Yeah, I think it's the hard part with some of this is around the need to build trust. But sometimes we don't have that kind of time. Like we don't have the time to establish the type of trust that is necessary when we're dealing in some of these spaces. I was listening to a podcast with Brene Brown, and she was talking about sort of her marble theory of trust, and that like trust is not something that I just jump in wholeheartedly, but it's like through actions and comments. And so it's like one marble at a time. Well, I don't have, like in our government space, as we're trying to sort of run a program, but also from a landlord perspective, right? I am running a business and a property. I may not have the time to give you the 100 marbles necessary before you finally trust me enough to put your guards down and let me help you through the process. I might have enough marbles of like 10, and then we got to like move on to a judicial space or something to that effect. So this is like the unevenness of it all. Yes.
And I think that's where the real talk and the difficult discussions have to happen with the participant. And sometimes, and I have to say, Tawana Holland, who's over the PSH program, has been extremely supportive because she has come in sometimes with her staff and have met with us with some of those difficult participants to help nudge them on the best interests for them. And I think that really has to work, right? And I think DHS has been really good partner in those difficult cases to really come in and support us with the participant. Because sometimes their mental illness gets in the way. And the government sometimes is the leverage, even as a provider, we need to help them nudge to the, and they're willing to do that. And I think we have to be willing to ask. And then they have shown to be receptive. But we do keep, at MBI, I feel like sometimes I'm like a government agency because we do have a lot going on and we have a.
Saw you yesterday, probably gonna see you.
Thousand employees plus and all the programs we run, so we are like a government agency, but we do keep track of all of the reasons there's a challenge, right? Abandoned humans, apartments under abatement, deceased, displaced, hospitalization, all of that. And I think that information is shared with DHS through.
That part, right? But that's like when you've exited, not you're still in, but I just don't want to talk to you, which I think is not a little bit, it is different. And even then, I do have questions about the high number of deceased. And I don't know if that has more to do with SUD or age or
All of the above.
Okay.
Yeah,
all the above.
There is a disengaged number as well.
Yeah, one of the
There
things
is a disengaged number, and that will tell you those who might be in the program, but decide, I don't want to deal with you.
Okay, I'm over my time. Thank you, guys. Appreciate you.
All right, thank you very much. That was actually an incredibly helpful round. I have two things I want to touch on, and so hopefully I won't take 8 minutes. And you were talking about it a little about some of the hard cases, and a lot of this conversation is about the hard cases. And Dr. Simbaris this morning said, here's how I internalized it. You're not going to be able to predict going in with any accuracy, but then you go in and then issues may arise. And it may be, and Ms. Respis, you spoke to this, that it takes a couple of turns. And so you need to move somebody. And it also may be, and Dr. Simbaris, I think, said this, and I'm curious how you react to it, that if you have somebody for whom you've tried a couple of times and it's not working in the right way, that maybe the answer is to elevate to a higher level of supervision, that in good faith, you didn't think that going in, but now you've learned over time that that's probably the best way to serve somebody. Curious your reaction to that path and how it comes up in the work that you do.
Okay, so I have strong feelings about this, I will say. So Pathways in DC has been doing housing first with ACT level clients since, for 20 something years. And absolutely, it's true. There is no predictor. I'm telling you, there is no assessment. Now, the assessments are like functional assessments. Does a person know how to cook? We need to teach them. That's teaching skills. But in terms of the success level of who's going to make it, we don't. So we try with everybody. The higher level of care piece is a challenge, and I will tell you, it doesn't exist. So it does exist for people who want it. So for example, we do have, out of our 700 people in our housing program, I think 9 live in community residential facilities. And it's not because some people, a few more might not do better in that setting. It's because people don't often want to live in that setting. And we have some great CRF providers, but there are many reasons the folks who are chronically homeless, ACT level clients, do not care to live there. They get no money. The rules don't work for them. There's a lot of reasons. So we need to figure out the next innovation. One of those things, and it was alluded to earlier, I think Andy mentioned it, is looking at different kinds of settings for people, a lower barrier, single site housing first building for a small number of people potentially. We have a couple of clients who say, I can't say no to the drug dealers. I'm struggling so bad. And we've tried 6, 7, 8 apartments. in and out of treatment, but they're struggling, might be traumatic brain injury, lots of other reasons. We don't actually have a higher level of care for those folks. Nursing, skilled nursing, sometimes if someone has like traumatic brain or cognitive deficits, will not take them because of their high behavioral health needs and co-occurring substance use challenges. So there is a need for some different innovations, and that's when I'm excited to have these conversations with DHS, DBH, small number of people, but big impact, and we need to try something different for them. We just don't want to try it on the front end, force someone into something they don't want when they could be successful in the community.
Go ahead.
One of the biggest reason people refuse supportive residences is because of the money. For permanent supportive housing, they pay 30% of their income. For supportive residences, they get $100 a month in stipend. And they don't want to give up the money. Although it may be a better setting for them. It's not because of the place is not nice. It's it gives them what they need with behavioral health support, but they don't want to give up the money. So I think if we can even make it 50% of their income or whatever, I think that would really go a long way to ensure that some of the folks that may need a different level, which is considered a higher level, will get it.
Great.
Yeah, okay. So I really, really appreciate those answers. It isn't that it isn't a thing that we should be doing in some settings. It's we need the right tools in order to be doing it appropriately. Okay, in another tool that is out there, and this is a thing that we have suggested at different times, and I'm curious your reaction as frontline providers, is should we have hubs where providers and DHS providers can be present in communities closer to where folks are as a way of having welcome centers, having services available? What do you think about the idea of community hubs? And one model is what happened in Chinatown Gallery Place, and curious your reactions on that.
Well, I think this is actually happening a lot all over the system of PSH for people who have are working and doing in buildings that have set asides in the affordable housing developments where you have 20 units in a 200 person building. There is a staff there. Marie, you run an affordable housing building like this. So does it work? Yes, it does. You have case managers there. I will tell you though, in talking to our folks with serious mental illness, what they don't want is their ACT team located in their housing, right? Because that's not normal. And it means that your mental health is just there all the time. They want spaces where people can come and, have an office set aside when people are coming frequently. But most people are saying, I don't want my mental health team located where I live because there's no separation of my life and my treatment. It feels like the hospital. But yeah, it's working very well in set aside buildings with, where you have an office.
Yeah, we have worked with builders and property managers. If we have, 15, 16, 17 people, we house a case manager there. And we've done that with at least 2 buildings beside the side base.
All right, thank you very much. I had chaired the board of the Lisner Home where we had, I think built in was a set aside and also a case manager on site. What I'm talking about, and I hear you about not wanting the ACT team right there in the building, but nearby, we wonder whether or not that couldn't be helpful.
Everything's got to be tried. Right? Well, let us try. And that's what innovation is. Let's try it. Let's assess it, see how it works. Let's do it.
All right, wonderful. Well, thank you very much to this panel. I think we'll turn to our next panel now. Thaddeus Weinson, Damian Cabezas. Okay. And Betty Gentle, who may be virtual. Is Miss Gentle online? Okay, wonderful. And Miss McKinney is not online?
I won't be testifying.
Okay, great. All right. When you're ready, Mr. Weinson.
Okay, how you doing? My name is Thaddeus Winton. I'm a person in long-term recovery. I have experienced homelessness myself. I currently work at MedStar Georgetown University Hospital. I'm the Overdose Survivor Outreach Program Coordinator. I've got my master's in addiction policy and practice and a CAC2 here license in DC. I am testifying today on behalf of the newly formed DC Addiction Treatment and Recovery Coalition, formerly the DC SUD Coalition. Part of what I have to offer here today is a potential pathway to alleviate some of the strain and stress on the permanent supportive housing system, but it comes with an ask. So hang on for that. What we see here in DC today are major gaps in the continuum of care for individuals recovering from substance use disorder, or SUD, especially between residential treatment and stable independent housing. Recovery from SUD takes far longer than a 28-day treatment stay. Research suggests that continuing care, the lower intensity long-term phase after initial treatment, should last a minimum of 3 to 6 months, ideally up to 12 months, to support a robust recovery, providing enough time for individuals to secure stable housing and employment after treatment. Yet in DC, there are very limited options for therapeutic, recovery-oriented transitional housing that bridge this gap. After residential treatment, ASAM levels 3.5 and 3.1, most residents have nowhere to go except for shelters, unstable housing, or back to the environments that contributed to their substance use. The few transitional programs that exist, Samaritan Inns, Community Bridges, and SUM's Leland Transitional Housing, are primarily supported by SOR grant funding or opioid abatement funds. Oxford House operates independently. It exists. There are 2 female Oxford houses. There is one other independent female recovery house in DC called Arden House. That's an incredible need that we haven't been meeting here in DC as well. The demand far outpaces the capacity with long wait lists and no coordinated entry system. There is also no up-to-date database tracking transitional SUD housing capacity in DC. The last public directory dates back to 2020 and primarily lists homeless shelters, not recovery housing. Without accurate data, oversight, or dedicated funding, our system remains fragmented and ineffective. Without sustained support from DC healthcare finance, the city's few transitional programs are at risk. SOR grant funding is year to year and could be cut unexpectedly for a variety of reasons, creating unsustainability. This means individuals completing residential treatment will continue cycling back into unstable or unsafe situations, undermining both personal recovery and public investment in treatment. DC must put some skin in the game. Relying on only SOR or opioid abatement funding is not enough to meet the demand we currently see. So the DC Treatment and Addiction Treatment and Recovery Coalition is asking the DC Council to establish a $5 million line item in the FY 2026 budget for SUD transitional housing. I know that's a lot. The investment would support approximately 200 additional individuals per year, bridging the gap between treatment and permanent housing and giving people in recovery a real chance at stability and independence. The DC Addiction Treatment and Recovery Coalition estimates that roughly 1,200 individuals are admitted to residential treatment level 3.5 each year, yet there are only about 50 transitional beds available, a number that serves less than 1/4 of those completing treatment, leaving many without a viable next step in their recovery journey. Therapeutic transitional housing is not a luxury. It's an essential part of the recovery continuum. It provides structure, accountability, and stability during a vulnerable time, helping residents maintain sobriety, find employment, and secure long-term housing. This is an area where DC falls short. DC must invest in a sustainable recovery system and stop solely relying on federal SOR grant funding to help our residents recover. Without it, we will continue losing progress and lives at the critical point between treatment and recovery. Thank you.
Thank you. Mr. Cabezas?
Good afternoon, Councilman Fruman and Councilmember Henderson and the council members' staff. I'm Damian Cabezas, President and CEO of Community Connections. Since our founding in 1984, Community Connections remains committed to innovative and compassionate mental health services, addiction treatment, homeless prevention, affordable housing, residential supports, and coordination of whole person care for the district's most vulnerable. We have been a national leader in the delivery of consistently evolving evidence-based services and trauma-informed care for communities of deep disadvantage. Initially, we were created to ensure a connection to the community for consumers being discharged from St. Elizabeth's Hospital by addressing mental health and behavioral health issues. Community Connections has grown to help consumers with addiction find affordable housing and provide support for those recovering from the impacts of repeated trauma and violence victimization. Today, we provide comprehensive services to more than 6,000 individuals and families annually. Our services include behavioral health, integrated care, supportive housing, affordable housing, homelessness prevention, peer empowerment, and training and consultation in trauma-informed and trauma-specific modalities. We also have established and maintained safe and affordable homes as part of our whole health recovery. We're active with community partners and local coalitions of community providers to expand the availability of housing resources, especially for the city's most vulnerable individuals and families. We have a comprehensive understanding of and commitment to the district's strategic plan to end homelessness. And Community Connections provides a comprehensive range of outreach and residential support services to promote housing stability and prevent homelessness, especially with people experiencing mental illness, addiction, and trauma. Funded by DC's Department of Human Services, our comprehensive homeless outreach team touches and impacts the lives of up to 100 individuals daily, and on average provides about 1,000 services each month on average. We reach individuals, veterans, and youth living in the street. We offer housing readiness services, navigate barriers to permanent housing. We support consumers with accessing Medicaid and Social Security benefits. We support critical life-saving measures by distributing opioid overdose reversal kits. And we build trust and respect, dignity to reduce barriers so vulnerable individuals can move off the streets and into safe and affordable housing. Community Connections also administers 500 subsidies funded under federal and local rental assistance programs. We manage supportive housing programs that combine rental assistance with housing counseling and supportive services to promote long-term housing stability. We're also a landlord. We directly own and manage 45 properties, providing supportive housing, prioritized for serving special needs population. We offer a range of housing approaches designed to meet the needs of 275 people living with serious mental illness, addiction, trauma, and health challenges. And we also have a service-enriched settings range from independent apartments, unstaffed and staffed group homes, supporting life skills, meals, and medication management. We were an early leader in the district's effort to develop, implement effective coordinated assessment and housing placement processes. We believe recovery begins with a stable place to call home. In 2008, Community Connections was one of the original legacy service providers contracted with DC's Department of Human Services to launch the district's first permanent supportive housing program with low and chronically homeless individuals and families, utilizing a housing first model. Today, we serve over 1,027 residents, including tenant-based and unit-based. That includes 693 individuals, 334 families. That includes 650 school-age youth. We successfully have engaged with 99% of program participants. Approximately 40% of those participants are also receiving services with mental health or substance use disorders. And I heard the testimony earlier, and we consider ourselves a clinical housing program. We have licensed clinicians, credentialed clinicians, And so we consider ourselves also a clinical housing program. Every 90 days, our team collaborates with PSH participants to complete a service plan. We serve over 600 school-age youth, supporting IEP meetings, and we assist families with applying for summer camp, summer youth programs, and new schools. I wanted to talk briefly, I know I've gone a little over, but I wanted to talk briefly as a public health professional. We are thrilled that we are recipients of what I call as a prevention grant in March of 2025 from the Department of Behavioral Health that developed an innovative new grant to provide housing care management services. Housing stability can quickly turn into crisis, as you know, especially for people concurrently experiencing behavioral health challenges. We're providing rapid response assistance to stabilize urgent situations and prevent homelessness. We work closely with consumers experiencing urgent housing situations, helping them secure safe, temporary, and permanent relocation options. And over the 6 months in this program, we have served participants in every ward, providing 453 outreach services, fielded 84 urgent hotline calls, and enrolled 85 participants. Of those enrolled, 47% participated in behavioral health services, and 64% presented with co-occurring physical disorders. The program has yielded great outcomes so far, including 100% of those with housing disruptions did not result in evictions, 92% reductions in hospital utilization, 89% increase in access to care, and 84% resource linkages. I'll stop there. I had more, but I'll stop there because I know I have gone over. Thank you for your time.
No, thank you very much for your testimony and for your service. Ms. Gentle? When you're ready.
Greetings, Chairman Fruman, Chairwoman Henderson, and members of both committees. Thank you for the opportunity to testify today during this public roundtable. My name is Betty Gentle, and I serve as the Senior Director of Advocacy and Public Policy for SUM Incorporated, a nonprofit organization that has worked for over 50 years to break cycles of poverty and homelessness by providing essential services, deeply affordable housing, and pathways to long-term stability for our most marginalized neighbors. SUM is a proud member of the DC Behavioral Health Association, the DC Addiction and Treatment Recovery Coalition, and the Coalition. Across these networks, we work alongside providers and advocates who believe all district residents deserve access to safe housing, quality behavioral health care, and compassionate support. We also actively contribute to various ICH committees and work groups. First, SUM's mission to create low-income affordable housing is deeply rooted in our work to help district residents overcome addiction and maintain recovery. When our founding CEO, Father John Adams, immediately began receiving requests from individuals completing residential treatment who had nowhere safe to go, SUM responded by opening its first transitional housing program in 1986 and our first long-term affordable housing property just 3 years later. Since then, SUM has acquired, renovated, or developed more than 20 deeply affordable properties, housing thousands of seniors, single adults, and families through longstanding partnerships with DBH, DHS, DCHA, and DHCD. Our housing model primarily offers sober living environments with individualized supportive services. This model serves a population that often overlaps with those supported through PSH. About 70 to 80% of our single adult residents have experienced chronic homelessness. While participation in case management is voluntary, 88 to 95% of residents across the portfolio choose to engage with these services, which provide coordinated support for employment, service navigation, childcare, physical and behavioral health education, and financial literacy. Having on-site programming, case management, and property management teams allow us to build trust and consistent relationships, mitigate instability, and provide timely support when crises arise. At SUM, we have found that case management is a secret sauce that helps residents not only achieve but sustain stability. However, as evidenced by the annual point-in-time count, the needs of our unhoused neighbors are diverse and often change over time. SUM's housing approach works alongside other vital models within the district's housing continuum. All these models are needed. A healthy continuum must reflect the range of supports residents may require, offering multiple approaches that can meet people where they are and evolve with them. Second, flexibility and collaboration in housing and programming is essential. Our experience with SUM's Weinberg Transitional Housing Program, formerly funded by DHS, illustrates how flexibility matters. When DHS required the program to operate under FRSB standards that prohibited a sober policy or our previous practice of mandatory case management, we saw an increase in instability, domestic violence, and CFSA involvement. With collaboration and flexibility from DHS, we were later able to adjust the program model, leading to improved outcomes for families. Some has continued to adopt our models for different and specialized populations, such as veterans. In addition, we offer a rapid re-engagement program and recovery supports for residents who relapse and wish to restart recovery with intensive wraparound support. Our approach remains client-centered and responsive, recognizing that whole person care requires both structure and flexibility. Third, by utilizing partnerships with DBH and DHS, SUM has been able to build a continuum of care that works for the people we serve. Strengthening coordination between these agencies and their provider partners is essential to improving behavioral health supports across all housing programs. Drawing from our experience, SUM offers the following recommendations. First, funding and staffing for case management and DC-funded shelters have been reduced, limiting critical support at the start of a resident's housing journey. Restoring and expanding these services will help residents stabilize faster and transition successfully to long-term housing. Second, behavioral health providers face significant pressure to help clients secure housing, but often lack the coordination and guidance needed to navigate the system. Policies for DBH clients may also not always align with DHS requirements, and residents exiting institutional settings often receive coordinated care only to be placed in housing programs that do not fully support their needs. A dedicated navigator who works across DHS and DBH can help ensure residents are matched to the housing model where they are most likely to succeed, improving outcomes and reducing provider burnout. Expanding the capacity of housing navigators at DHS would also allow them to provide more comprehensive support to providers and improve the efficiency of filling vacancies at affordable housing properties. Third, delays in referrals for DBH subsidized units can leave housing vacant for residents with behavioral health needs. Improved coordination between DBH and housing providers would allow individuals already receiving services to access housing more quickly. Fourth, transition housing is a critical underfunded piece of the continuum. Sustained public investment in housing for recovery and homelessness transition will close gaps for individuals entering or completing treatment and for those needing a stable bridge to permanent housing. And last, the district must continue to support the creation and maintenance of diverse housing types, each serving different but equally vital needs in the continuum. Thank you for the time, your time and consideration for the opportunity to testify today.
Thank you very much for your testimony. A few questions for this panel. Mr. Weinson, the idea of $5 million for 200 beds for transition as people are dealing with substance abuse disorders. How does that compare to what happens in other jurisdictions? You said, as I heard you, there's 50 such beds now, which doesn't seem like very many. But if we had 250, how would that compare to a Baltimore or another city?
We'd be doing much better. As it relates to the SUD continuum, right? 28 days, you're creating a revolving door in doing so. If you can extend that continuum 3 or 6 more months, your odds increase that people get this, that they recover, that they get jobs, that they have access to internet, they can do their 12-step meetings with the support, IOPs and other step-down aftercare things in place. The odds go way up with longer term. I get that figure, the $5 million from Samaritan Inns has about 27 right now. It takes about $829,000 per year to operate that 27. So we're ballparking there with that. And I know it's a big ask, but I do see that is a major gap, that's creating these silos further that what we have today, creating that revolving door in relapse and return to use and back through this system.
I hear you, and we need to absorb the ask, but I think there probably is an argument that there are savings that come from it, because if you reduce relapse, then you reduce services that you need to provide over time. But you had your hand up that you wanted to.
It's on your investment that we put into our residential treatment systems. However, when you mention how does it relate to Baltimore, Baltimore has moved greatly towards an outpatient model. And if you look at Baltimore's overdose and overdose death rates, they're 7 times what we are right now. So they're in the middle of the worst crisis because of some of the decisions that they've made regarding this continuum of just, oh, you do it at home, figure it out, patchwork it together. And that's part of why this is such a critical ask right here, is that we don't want to be at that point with outpatient models the way they are.
All right. Well, and we asked Dr. Simbaris, what's the gold star jurisdiction? What's the model we should be looking at in terms of service in this area?
Building an SUD continuum that can, with opt-in, can take up to 9 months or a year, not 28 days. And maybe you can go and figure out the closest outpatient near your house. A lot of people don't have the wherewithal to navigate this system. This system is very siloed and fragmented. It was hard enough to find these numbers on our own. And this is the SUD Coalition members of treatment facilities and hospitals here in DC that, we should know these things. It's just very siloed, hard to find information. So the average person trying to figure this out on Google or just on their own, it's going to be even harder. If you extend the continuum longer and we provide better longer-term services, it just better outcomes, and you have a warmer handoff and a warmer step down, which results in less people needing permanent supportive housing vouchers.
No, I hear you on that. And the whole goal of this is how do we allow more people to succeed? I guess I hear you. Baltimore's the bad example. I am curious if there is some place that is the good example.
Right now, DC and West Virginia were kind of leading the way with overdose and overdose death. We have done amazing things here in the city to bring those numbers down some. And Baltimore has certainly leapfrogged us, but as far as DC is concerned, I don't really have the answer to that. Who's doing great? I can't think of a city that's doing great at the moment.
Okay, thank you very much. Ms. Gentle, part of a lot of the conversation has been about transition housing and the continuum of care. So it is really helpful to hear you talk about how you fit into that continuum of care and how that can strengthen the system. One of the things that we heard was often people don't want to go into a setting like what you're describing because they don't want to be in a place that is exclusively folks with very high needs. And I wonder how you experience that, how much of a barrier that has proven to serving people who you might like to serve, and whether there are things that we might be able to do that could lower that barrier, or if it's just a fact of life.
Well, I think one of the things for us and what I talked about with the fact that case management is being reduced in the shelters is that because our continuum starts like literally at a dining room where people are coming to eat, we've built those relationships through like our case management to help people figure out like what that next step is. So normally we know whether or not the type of housing that we offer is going to be the model that person wants or that will work for them. And so then we try to work with them to connect them with whoever they need to if we think that we are not the next best option. But because, like I said, we literally started developing housing because of people. So our treatment facility is in West Virginia. And there were people who, amazingly made it through treatment, but told us that when I get back to DC, I either don't have anywhere to go or I have somewhere to go, but it's going to be extremely difficult to maintain my sobriety. And so we have a lot of the people in our housing are in recovery. And so that is a preferable model for them. But there are also people, if other resources were available to stay at like scattered site, would probably choose that option. But the thing is, at this point, we don't have enough recovery housing, but we don't have enough models of any of the housing. But yeah, it definitely does. Some people won't choose it, but there are a lot of people who need that structure, and a lot of people who actually are able to move out into market rate rent get a voucher. Like shout out to DCHA and DHS. We've had more people who've been getting a voucher and leased up who do want to move out of that more structured housing.
All right, well, thank you very much for that. It does sound like, particularly in the recovery setting, it's a different population that may actually want to be in that sort of setting. Mr. Cabeza, and then I will be done, is it sounds like you do a whole spectrum of things. You're a landlord, so you might have site-based housing with folks with PSH vouchers. You also do support in the scatter site setting. Am I understanding your model correctly? And in your view, how do these pieces fit together? Are there folks for whom the on-site makes the most sense and we should be doing what we can to encourage that? Or is it just random where people land in your internal continuum of care?
Yeah, we do value the continuum of care that we have at Community Connections. Off the top of my head, to respond to your question, I think it's about connection to the individual on an ongoing basis, and evaluating and reevaluating that individual, because things change. Sometimes you can have a service plan or treatment plan, but things change for the individual. So having constant contact with the individual, having cross-sector partners that you're working with. It's impossible to do our job without cross-sector partners, both at the local government level and with other providers. So having cross-sector partners and just continuously evaluating their needs.
All right, wonderful. Thank you for that. Councilmember Henderson.
Thank you. Thank you to this panel of witnesses, and it's good to see some of you again. I don't have a lot of questions. I have a couple of questions for Ms. Gentle, because SUM's model is so interesting in that you are a housing provider as well as doing some of this other work. You mentioned in your testimony around the need to better match residents to the housing model where they're more likely to succeed. When you have a client for whom, I guess, has gone through the process and is approved for PSH voucher, but through the case management process, one of your case managers might say, I don't know if this is going to work. What happens then in terms of, like, if a case manager really feels like, no, I actually, in conversations with this person, they need a higher level than a scatter site or something to that effect, what options are available?
I feel like I would need to follow up with you, because I don't know if because that was one of the concerns when I was talking to our previous clinical director of behavioral health, where she said there's not really much communication with the behavioral health provider and like DHS, which is why she was suggesting that like maybe the DHS housing navigator also be responsive to the DBH behavioral health providers. So I don't know if that happens and if there's an opportunity to do that type of advocacy to perhaps suggest a different model. But I imagine it also was really up to the person seeking the voucher. Like if they prefer that type of housing, I imagine that that's what would take place. But I honestly don't know, because from our experience, there just isn't a lot of coordination taking place between the behavioral health side and DHS.
Yeah, I mean, I'm just sort of thinking about, I recognize that even, Dr. Simburis at the beginning was talking about, for some people, it might take 2 or 3 relocations in order for them to get settled into a place that they need. But if we're talking about building trust, I imagine every movement is sort of depleting on some of those trust marbles, if you will, from my earlier sort of metaphor. And so if we're able to do the triage at the jump, right, to set you up for success, as opposed to saying like, let's just try this and see what works. Because for some people, the trial and error it creates its own level of fatigue for not wanting to adhere to the process as well.
Right. Yeah.
Okay. Now that I asked you that question, I'm like, man, I wish I had asked like the previous panel that they do in those situations because
you should also ask the agencies too, because like I said, I know she said, like when the people, our staff I talked to said that was a gap. Like they will have focused so much time on offering care to this person, but then they learned that the housing placement doesn't seem appropriate for the level of need. That's why I said I don't know if there's any like negotiating or how to phrase that. Yeah.
well, it's not even maybe a negotiation situation too, but also whether or not there's even space in whatever that new model be, because you know, there are shortages there in terms of like other types of models as well. So that's my only question that I had. But I appreciate all of you for your testimony and for your commitment to working with us to help improve this issue. Thank you.
Thank you.
Thank you very much, and thank you to this panel. Let's turn to our next panel. Liz Wolfe, Rachel White, Mark Levada, Pamela Agava, and Jordan Gully. All right, when you're ready, Ms. Wolfe.
Good afternoon, Chairperson Fruman and Chairperson Henderson. My name's Liz Wolfe, and I'm the Director of Clinical Care at Sasha Bruce Youth Work. I'm here to share today about how these systems are working specifically for young people in the district. Sasha Bruce is one of DC's leading youth-serving organizations. We operate 27 programs, including 13 residential programs for young adults experiencing homelessness and other crises. Among our programs are 2 DHS-funded extended transitional housing programs, or ETH programs, which together serve 43 young adults ages 18 to 25. Extended transitional housing was designed for young people with significant mental health or substance use challenges who, with the right level of support, can transition to independence. In practice, however, many of the young people we serve require more intensive and long-term care than the model was originally designed to provide. Many of our ETH residents at Sasha Bruce live with serious mental illness, severe substance use disorders, or developmental disabilities like autism or intellectual disabilities. And many of our young people are managing more than one of these conditions at once. We estimate that roughly 3/4 of our ETH residents will need ongoing, long-term support and may never be able to live fully independently. For these young people, permanent supportive housing is the appropriate next step. However, there are very few PSH placements for young people in DC. When our residents reach the 3-year limit at the ETH program, they often have no good options for safe and stable places to live. So we think about young people who are 18, 19 years old when they're coming into our program. At the end of their 3 years, they're 21, 22, and there aren't a lot of PSH beds becoming available to clients that are that age. Without PSH, these young people are at risk of cycling back into homelessness or into unsafe living conditions. Beyond the shortage of PSH, we also face challenges in connecting youth in our care to quality behavioral health support, as others have talked about today. We link all of our clients to a DBH core service agency, but we find the quality and consistency of services is really variable. Some community support workers are excellent, where others are just not persistent in their outreach. They miss visits, they can't build rapport with clients, or they just aren't able to provide the level of support that our clients need. As one example, many of our clients would really benefit from transportation support to their psychiatry visits. But from what I understand, our core service agencies just don't provide transportation in that way. Young people who clearly meet criteria for ACT, which is that higher level intensive community-based treatment, do not consistently receive it. And as a result, young people go without medication and without consistent support, and their mental health deteriorates. Compounding these challenges are funding constraints. Our ETH programs have been flat funded by DHS since 2019. If you take into account inflation over the past 6 years, flat funding is a de facto 29% reduction in funds. During this same period, DHS has introduced new and important requirements, like we're now required to employ a full-time licensed mental health clinician in each of our ETH programs, which we fully support. We've implemented this at Sasha Bruce, but it hasn't come with a funding increase, which has left us to fill the gap. We've had to fundraise privately to maintain really high-quality trauma-informed programming. To strengthen the system and ensure that DC's most vulnerable young people have access to the supports that they need, Sasha Bruce offers 3 recommendations. First, restore and expand youth-specific PSH options for young adults with complex needs who meet the criteria for PSH. Second, ensure DBH core service agencies have the capacity, the funding, and the oversight necessary to deliver consistent, high-quality behavioral health supports, including ACT. And third, increase DHS contract funding to reflect inflation and these new staffing requirements for extended transitional housing programs. The young people that we serve at Sasha Bruce, they want to be stable and housed and well, and they work incredibly hard to achieve stability. But the system, as it is currently, leaves too many of our young people without the supports that they need to really get there. Thank you so much for the opportunity to share our perspective and for your continued commitment to strengthening housing and behavioral health services in the district.
Thank you very much. Ms. White?
Good afternoon, Chairpersons Henderson and Fruman. My name is Rachel White, and I serve as the Deputy Director of Youth Advocacy at DC Action. We lead the Youth Economic Justice Coalition, a network of young people, advocates, providers, working to ensure that all young people have access to stable housing, behavioral health supports, and opportunities to thrive. While today's hearing focuses on permanent supportive housing, I want to highlight, like Liz did, the parallel reality for young people who are ages 18 to 24 who remain largely excluded from these programs despite a clear clinical need. The youth permanent supportive housing system has effectively stalled. According to the Community Partnership, there is only one PSH program designated for young people. Of its participants, all but one are now over the age of 24, having been placed as youth there years ago, but remaining in those beds after they have aged out of the youth system. That means that young people entering the system today, those who are currently between the ages of 18 through 24, have virtually no access to permanent supportive housing, even when they meet the clinical criteria for it. PSH is designed for individuals, as we've heard, with serious and persistent mental health conditions or disabilities who need long-term intensive supports. Because youth PSH capacity is frozen, providers have had to rely on extended transitional housing, like the housing programs at Sasha Bruce, to serve youth who actually meet permanent supportive housing criteria. ETH is intended as a time-limited 3-year program, a transitional bridge for youth building independence, and should not be used as a substitute for long-term care. In practice, ETH has become a de facto placement for youth with disabling behavioral health needs, but without the duration necessary to meet those needs. Again, compounding this, the time limit for ETH used to be 6 years, but was reduced to 3 years in fiscal year 25, meaning youth with complex behavioral health challenges are expected to stabilize and transition within a time frame that does not align with their clinical realities. This puts both the providers and young people in an impossible position. Youth who require permanent supportive services remains in programs that are temporary by design. So there are some other barriers. There are billing and coordination barriers as well. Even when young people are matched to youth PSH programs, continuity of behavioral health care breaks down due to rigid billing systems, credentialing barriers, and fragmented funding streams. In my written testimony that I will submit to you all, I will highlight the billing challenges. Providers report that when youth are unhoused or transient, they can only bill through homeless targeted health codes versus homeless targeted services codes, and must track down youth repeatedly to make contact for billing. For youth who become housed, Medicaid requires both home visits and additional client contacts to meet billing thresholds. However, reimbursement is often denied, even when outreach occurs multiple times because youth may not meet the strict service frequency or documentation requirements. Uncompensated communication costs. Programs are not reimbursed for essential tools like phones and data plans that enable staff to maintain contact with young people who lack stable housing. Related to a concurrent hearing today, this is just another example of how the district underinvests in our nonprofits, indirect but essential operating costs. So some key questions that we would like the committee to ask. To understand and address the structural barriers, we ask the committee to request data and clarity from DHS, DBH, and TCP on the following. Youth permanent supportive housing utilization. How many of the current permanent supportive housing units are filled by youth under 25? Aging out and transition. When participants in youth PSH programs turn 25, are they recategorized into adult PSH beds? Do they remain in youth designated units indefinitely? And pipeline and flow. Are youth who are aging out of ETH being successfully connected to adult PSH programs if they qualify? What metrics is the district using to measure or demonstrate successful connections? Without these answers, we cannot fix the mechanisms that are preventing young people who meet clinical PSH criteria into moving into programs designed to support them in the long run. A few recommendations: rebuild a youth PSH pipeline, extend or add flexibility to ETH timeliness by restoring at least the 6-year maximum, or create case-based extensions for youth with significant behavioral health concerns. Require DBH, DHS, and TCP to develop a documented referral and transition protocol. Fix Medicaid billing and reimbursement rules. Right now, the district's youth PSH system exists mostly on paper. There's one program nearly entirely filled by people who have aged out of eligibility, while young people who meet PSH criteria remain stuck. Thank you for your continued commitment to ensuring every young person in the district can access housing and healing, and I will submit my written testimony with more detail. Thank you.
Thank you. Mr. Luvada?
Chairperson Furman, Chairperson Henderson, thank you for the opportunity to testify today. My name is Mark Lavoda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for district residents with mental illnesses, substance use disorders, or both, including the 35,000 district residents our 35-member organizations serve annually. The Council's decision to investigate behavioral health in local housing voucher programs provides acknowledgement that better coordination would be valuable to ensure that voucher holders who have behavioral health needs are offered appropriate resources to address those needs. Services to local housing voucher holders overall appear to be effective, but a subset of fewer than 1 in 20 voucher holders appears to have substantial unmet needs, many of which are likely associated with dysregulated behavioral health conditions. In my testimony, I'll offer recommendations regarding improvements to resource allocation for people with more serious behavioral health conditions, improvements to delivery of case management and behavioral health services for voucher holders, and improvements to care coordination across stakeholders. Resource allocation strategies need more thoughtful alignment with voucher holder functional assessment, as you've heard already in testimony today. The lack of a routine process for determining whether a functional assessment should be conducted or when to assign behavioral health services leads to placing a segment of voucher holders in units without the care that would likely support stability and help to prevent community disruption. The Department of Human Services should also assign additional monitoring to voucher holders who decline services despite functional assessments that indicate services are needed. Delivery of case management and behavioral health services for voucher holders also needs to happen with better role clarity. Case managers often express frustration that a voucher holder is assigned to a DBH provider, but the DBH provider is unresponsive. Case management program leaders should be provided with information about the best ways to escalate issues concerning non-responsive frontline DBH provider staff members, and case management provider organizations should be provided information about how to bring concerns to DBH if a DBH provider organization staff members and leaders are persistently or egregiously failing to deliver the care that is their responsibility. Conversely, case managers should be offered information about DBH provider treatment goals and activities and be asked to work on an aligned service strategy to ensure that treatment interventions are not being undermined. Stakeholder coordination can be further improved through better information sharing and policy alignment. There needs to be a better shared understanding that Medicaid beneficiaries have choice whether they agree to receive services and from which Medicaid provider they're willing to accept care. There are very good reasons that mandatory treatment is time limited and requires a court order. Classification of these services as health services also means that payment, treatment, and operations information can be shared between case management and behavioral health providers and among other healthcare providers. Contract restrictions and policy guidance to the contrary undermines eligible care coordination and leads to unnecessarily fragmented care. DHS, DBH, DHCF, maybe DCHA should take whatever steps are necessary to remove policy barriers to information sharing across service providers and to remove policy barriers to sharing their own separately collected information about voucher holders receiving services from multiple agencies and from multiple community providers. Agencies should develop joint guidance and offer regular training regarding best practices for seeking consent and information releases for community providers to speak with landlords and building managers to help prevent or at least mitigate lease violations or community disruptions. Agencies also need to review opportunities for better handoffs when housing needs change, including building a better pathway from DBH community residential facilities to receipt of a housing voucher. For the Home First program, DBH also needs to evaluate voucher amounts, which have significantly fallen short of market-based rent, and cancel unused vouchers with funds reallocated to increase voucher amounts. Alternative housing options also continue to be needed for people with specific behavioral health needs, including non-CRF congregate settings with supports to allow residents to age in place, and both sober living and non-abstinence-based recovery housing. The lack of availability of these alternatives sometimes contributes to an unsuccessful voucher placement. Thank you for the opportunity to testify today. Look forward to answering any questions you might have.
Thank you very much. Ms. Agava?
Good afternoon, council members and everyone else who's managed to stay here for the last 4.5 hours. My name is Pamela Agava. I am the Associate Director of CSH in the Mid-Atlantic region. CSH stands for Corporation for Supportive Housing. Unlike the rest of my panel here, who are great service providers on the ground, CSH is an intermediary. We are a CDFI who does lending to deeply affordable PSH, as well as doing training and education. We offer a property management institute for property management and landlords to understand how to actively engage with service providers and be on the ground. We've supported DHS with a Medicaid Academy where we helped service providers in the district prepare to bill Medicaid as one of their billing sources for PSH. We also offer an operations institute where we talk to developers and property managers about how to financially support being on board with service provision for PSH. But in addition to all of that, we also do systems engagement. So we can step back and take a look at the bigger picture, which is what I want to offer today in my testimony. And that's the infrastructure that PSH sits in. I think based on all the testimony you've heard, I hope that it's clear that PSH is a successful intervention and framework when implemented to high fidelity. And so the question that should be in front of the council members here is really, how do we build the infrastructure and capacity of the systems that implement and oversee PSH within the district? And for us, that results in a couple of simple things, right? Increasing the capacity of the entities that serve this population. We've heard a lot about different subpopulations, those with serious mental illness, the SMI population, SUD, substance use disorder, as well as the youth population. And so there needs to be investment into the service network that serves this population. And that would come through deeper investment into the agencies that directly provide oversight and in reality provide program management, thought partnership, as well as financial management to the service provision network. And so in our vision, we see this as a quilt. Everybody has their specific part that they are responsible for, but there's deep connections that make a clear picture and strategy and vision of how PSH is supposed to look. And that means that DHS has clear connections with DBH, and that DBH has clear connections with DCHA. Everybody's connected. we know that that's a challenge across the country. Specifically in DC, it's a challenge because of the different funding sources. And so if the money is not aligned, you can't have people collaborate and coordinate and come together in the ways that you're talking about. If DBH is pulling money from particular sources that require certain eligibility requirements, that have different definitions of homelessness or serious mental illness, you're going to see that lack of coordination when it comes to service, which also leads to a lack of implementation on the ground of how we handle crisis and how we're able to support tenants and individuals in their communities. So our ask is really that there's an investment that's strictly geared towards supporting the agencies to build the capacity to do the thought partnership that's necessary to continue to implement evidence-based interventions that they know work, that they hear about either through CSH or any other technical assistance provider that they're in contact with, but haven't had the ability to do because they're constrained by funding, capacity, to just being able to only provide oversight and compliance. That's not going to work long-term for a system, and that we're seeing the results of that now. We also want to focus on not just effective voucher administration, but voucher management. And what that looks like is agencies like DCHA stepping up to the plate and it also interacting with property management more often and coordinating with DHS and DBH. And that is something that we have not seen in DC at the levels that it needs to happen to avoid some of the, what I would say are outlier experiences that were testified about today. Lastly, it would also be important, and Mr. Fruman, I think you've been leading towards this with a lot of your questioning, to a specific evaluation process. What does it look like to evaluate PSH? And that is something that programs across the country grapple with because it is an iterative program. It's not like going to the dentist and getting a cavity filled. It's not a one-time treatment that's done. So how do you measure something that continually has a moving goalpost? There are many different practices across the country, some that could work in DC, some that may not work in DC, but the opportunity to effectively evaluate what could work in DC requires the capacity of all of these agencies having that space to do that work alongside the management and compliance that they're currently doing now today. So that's all of my thoughts kind of distilled into the 5 minutes. Thank you for your time.
Thank you very much for your testimony. Jordan Gully.
Good afternoon, Chairperson Furman, Chairperson Henderson, and community members and staff. Thank you for the opportunity to participate in this joint public oversight roundtable on behavioral health supports for local housing voucher programs. My name is Jordan Gully, and I'm a senior consultant with the Technical Assistance Collaborative, where I work across multiple states and jurisdictions to strengthen programs at the intersection of behavioral health and housing. In my role, I've worked directly with the Department of Human Services, the Department of Behavioral Health, as well as district housing and behavioral health providers. However, prior to coming to TAC, I spent over 10 years working within the DC system in a variety of roles, including co-chairing a work group for the Interagency Council on Homelessness, overseeing DBH's homeless outreach program, and managing a permanent supportive housing program. Also, until a few years ago, I resided on Connecticut Avenue, giving me a firsthand perspective on some of the community dynamics. So all of my remarks today come from those experiences. The district has demonstrated significant recognition that housing is the cornerstone of health and community well-being, but there's always areas of improvement, including strengthening coordination at a system level between DBH and DHS. A lot of what I was going to talk about today has already been covered, so really just going to hit on some of the high points. Intensity of case management is critical for promoting positive outcomes for permanent supportive housing, and we've already talked about the tremendous evidence that shows how effective that it is. But the benefits of strong PSH are when services are intensive, integrated, and individualized to the needs. While PSH programming is currently effective and DHS has a strong infrastructure for quality oversight, there's opportunity to further enhance the consistency of monitoring practices across PSH providers to ensure high quality service delivery, and ones that are meeting frequency, consistency, and quality standards. But moreover, the district also has an opportunity to create a system-wide standard of understanding of quality standards and aligning monitoring practices across systems. As we've talked about at length today, PSH is effective for individuals with behavioral health conditions, but a small and visible population with more complex behavioral health needs require additional supports beyond what housing programs and coordination or care might provide. And this is where closer integration and community behavioral health services are even more essential to ensure the appropriate level and the appropriate type of support. A key challenge that's been throughout the theme this evening is the consistency and quality access to behavioral health services. In my work, DC-based providers have often noted challenges connecting residents to behavioral health services in a timely manner, which has been further exacerbated by workforce shortages. So intentional steps for system integration to equip providers with innovative engagement strategies is needed. DC has an opportunity to create a more cross-system approach at the time of referral and initial assessment for PSH. And this has been brought up previously by other witnesses today, but really a joint comprehensive assessment and assignment that takes into account appropriate services, both of behavioral health and of housing at the point of entry to ensure a system approach is setting people up for success and ensuring people are accessing an array of services at the appropriate level of care. It's not one size fits all. And so ensuring that people are met with services that meet their need in the array of services. Often individuals with chronic homelessness are more likely to get connected, are likely already connected to mental health services, but may struggle with consistent engagement in these services due to the nature of homelessness, or that behavioral health service providers have an inability or limited ability to bill for outreach. DBH has recognized some of these challenges and has introduced the Housing Care Management Program, which implements critical time intervention strategies and care management interventions to integrate behavioral health support into housing. And while it's an important step in centralizing process responsibility and public accountability, CIT is a time-limited intervention, so this should also be accompanied by efforts to enhance the quality oversight and community-based mental health services that is necessary to provide long-term support and sustainability. DHS and DBH can further strengthen their partnership by coordinating to expand expertise, capacity, and capability for substance use outreach and targeted peer support services within PSH program, as well as taking intentional steps to enhance on-demand access. What's been talked about a fair amount is that services are voluntary, and while services are voluntary for the individual, it's not voluntary for the provider. So engaging in effective outreach that takes time requires substantial outreach and creative engagement, especially for those who have experienced negative or traumatic interactions with the system. And so ensuring that behavioral health and housing providers are equipped to provide assertive outreach and employ innovative strategies is necessary, as it's been consistently found that demonstration of quality relationship is really what enhances stability and recovery. So cross-sector targeted strategies are necessary. Thank you for the opportunity to testify, and I'm happy to take any questions from the committee.
Thank you very much. For both Ms. Wolf and Ms. White, message received. I have a feeling I will see you again in the oversight season, and we'll see you again in the budget season with similar asks. Really appreciate all of the work that you do advocating for our youth, and we hear you. Mr. Lavoda, one of the things that you talked about was improvement of the assessment going in. And it was interesting talking with Dr. Sambaris, and others have said this, that it's always going to be imperfect, the assessment going in. But another thing that you talked about was monitoring going forward. And as I heard you, I thought you were saying where there might be issues that an ongoing assessment process would be important. If I heard that correctly, let me know. And if that is what you're suggesting, what then would you do with that ongoing assessment?
So first, I want to make a distinction between our screening for eligibility versus our assessment for level of care. And I think that we're doing fine with screening for eligibility, but we have a huge weakness in terms of actually assessing for level of care. And so I think we do have to be more sort of upfront about figuring out what's the array of services that this individual actually needs. And in many cases may not be just case management, as many of us have said today. And so making sure that they are connected to the right services up front. When I talk about monitoring, I have two concerns that come to mind. One is about that ongoing assessment. Do we have a good sense that people are still at the right level of care? Is there some frequency with which we're evaluating that they might need to be stepped up? They might be ready to step down. They said that they want to opt out. Have we actually done an evaluation to see whether or not they could be successful? The other thing is just the reality of different services being delivered by vendors for different agencies not being well coordinated, and the steps that we need to take to make sure that a DHS case management vendor can have a conversation with a DBH provider and that they know who those folks are. And if they're not getting the responses that they need, first, sure, try to elevate within the supervisory structure, call the on-call number, try to figure out who the supervisor is if you can't figure out who the individual case manager is or the individual community support worker. But sometimes there are systemic failures. Sometimes the entire organization is falling down on the job. And so I think there also does need to be a reporting structure for people to say, like, look, we persistently try to get this specific DBH provider to send their CSWs out, and we can't even get an answer from the person who's listed as the program director. I don't think that's acceptable, and so I think that we have to address that. And it does go both directions. We also need the case management staff for DHS folks to be involved in treatment planning when there are behavioral health concerns so that we can make sure that the care is delivered in an integrated way. Sometimes we do see people kind of pick their favorite case manager or their favorite person on their support team, and then the interventions start drifting in the direction of who they want to work with instead of who they need to work with. And maybe also start drifting in terms of we're actually coaching people to do things that are a little contradictory or not fully aligned. And so reinforcing the opportunities for teaming is really important, and then doing the monitoring work to say, if you're not going to be part of the team, then we need to hold you accountable for not being part of the team.
And in that sense, you're talking about the providers, if they're not being part of
either the case management providers or the DBH providers, yes.
Okay. Well, and that is a theme that we have heard. Better coordination in this space is absolutely a theme that's jumped off the page today. I want to thank Ms. Agava and Ms. Gully also for your testimony. I think really helpful to hear about the kind of big picture ways in which we can improve this system. I don't know, Ms. Agava, if you want to speak to what Mr. Lavota just spoke to, but I thought I saw you nodding your head in a couple of different places.
Yes, individual agency capacity is a major issue. The supervision of what we do with an agency when multiple partners are saying this agency is not responsive to us is not a question that other agencies should be able to answer. That is a question that the oversight agency has to control, right? And so DHS, DBH, they need to be able to determine what that process looks like. And while we love collaboration and coordination, there is something to be said for system partners coming together and defining what their system, their coordinated, integrated system is going to look like, so that when these situations arise, there is a clear institutionalized process of, hey, we've received this many complaints because we have a system where you can complain to DHS about this agency. And once we reach this threshold, this is the action we will take, because it's not agency XYZ's job to determine that nobody should work with agency ABC. Because then you can have personality issues, people disproportionately, again, some of that bias coming into play, in the capacity of the agency. Maybe they're just not doing as well with their funding. And so there has been issues in outreach or coordination, but DHS or DBH should be the ones responsible for engaging in that conversation, not other agencies.
Well, really good job setting the table for our government witnesses who will be coming shortly. I will say you started by admiring the people who were here 4.5 hours in. It's now 5 hours in. I will say those people have to be here. But thank you for that, and end by saying I love the glasses. Councilmember Henderson.
Thank you. I'm going to be very brief because it is 4 o'clock and we still have 3 more people to go. I do want to ask just a question to Ms. Wolf and Ms. White. When you do have a situation of a young person who is transitioning, maybe qualifying now for PSH, does the onboarding for that young person look different, considering the idea that it's, someone who is 45 who's entering PSH might need a very different level of support than somebody who is 19, who's now and you have an apartment and you need to pay bills and you need to do the X thing. What does that look like?
It's hard to tell because when young people are eligible for PSH and they receive the vacancies, the organizations receiving the vacancies on what beds are available, at what programs, there are rarely any programs that are available for 18 to 24-year-olds. So they have to stay in there where they are in extended transitional housing. There's a barrier. They don't have access to permanent supportive housing, even when there's a clinical need.
That's interesting. Okay. All right. Thank you all for your testimony. And if you haven't provided it for the record, please upload it. Thank you.
Thank you.
All right, thank you to this panel. We do have 3 more witnesses. I think we're going to do it where, Ms. Silla, if you would come up, and I understand what we'll be doing here is just getting a report from you on the conversation that the ICH had on this topic, and then my expectation is this will be relatively brief, and then we will turn to our 2 other government witnesses. It's the practice of this committee to place our government witnesses under oath. Would you please raise your right hand? Do you swear or affirm under penalty of law that the testimony you are about to provide to the Committee on Human Services is the truth, the whole truth, and nothing but the truth?
I do.
Wonderful. So I actually have one question for you, which is, my understanding is that you had a conversation in the ICH about these topics, and I wonder if you can report on what it was that you were hearing from the folks on the ICH about these topics.
So one of the things that was really fascinating to me as I looked at the witness list and I also listened to the testimonies today is that I think you have pretty much all of the witnesses have synthesized the very feedback that I am receiving on the council at our behavioral health work group. And so I think you actually have a really good understanding of the sorts of challenges that people are coming to the ICH and describing to the ICH. I think you have heard it in a level of detail that, that I would not want to repeat because I am not a provider. I am not a client receiving services. I cannot do it nearly as eloquently or as robustly as the folks that have done it. So as I listened to the testimonies, if that is okay with you, I started to think about how do we level up and how do we think about this from a system level approach? How do we partner with you to think about what everything we have heard might mean and how we approach this work especially at the ICH. And, the DC Council is a partner of the ICH. You are embedded in the leadership infrastructure across all of the committees and the work groups. And so I would love to think that through, maybe in partnership with you and maybe even right now, just kind of what's resonating.
Well, absolutely. We want to be a thought partner with you as we go forward. The question is, what do we do with all of the information that we have heard and will hear when we speak with our government witnesses, our other government witnesses? Particularly since Councilmember Henderson has stepped away for a moment, I will invite you to offer your thoughts up until the moment that she comes back, and then we'll move on and pick up that conversation after the hearing. But if you'd like to offer the thoughts that you have about what next steps you think we should be taking.
Yeah, I mean, so from a system level perspective, it felt to me we need to make sure people have access to the appropriate level of behavioral health services and supports. And then it also sounds to me like we need to be thinking about what does effective crisis intervention and prevention look like. And it feels, especially when I was listening to, starting from the very first witness, right, Dr. Sam, he was talking about making sure that we are, it felt to me like he was saying we need to integrate and embed behavioral health services and support so that the people that are helping you get your keys, the people that are helping you move into housing, the people that are supporting you meet your needs, have that behavioral health perspective, expertise, knowledge embedded in how they are delivering the services. So it felt like in one way, people are asking, how are we working together to make sure we are connecting people, maybe even actually embedding that behavioral health expertise and supports within homeless services. So I want to start thinking about what does that look like at our facilities, because this has to start from when people are on the streets. That's what I was hearing, that we can't start at the site of the housing voucher programs. We have to start earlier than that. I understand we have a problem with people that are in units right now. We also have to solve for that. But I also want to take seriously that we are examining how are we partnering all the way from the streets, from our homeless shelter, and walking together side by side as both Department of Human Services and Department of Behavioral Health towards the end of addressing people's behavioral health challenges and also meeting their housing needs, also meeting their employment service needs, also meeting their food-related needs, right? Because I heard food, I heard income and employment as another thing that people need supports and services with. And it is deeply gratifying to know the kind of work that DBH is already doing on that front. The sorts of innovations that we have seen at DBH that we need to be uplifting and promoting, whether it's the intensive care coordination team and the ways in which they are showing up at the front door, at our day drop-in centers, at our homeless shelters. Those are the sorts of things that I think we really need to uplift, amplify, think through how are those successful, how can we improve and better support our district partners.
Okay, thank you very much. One thing that came up in a number of places, and you're right that a lot of this focus has been on where we have folks who are in units and there are real challenges that are confronted. And Dr. Sambaris started by saying that it's sort of not surprising that that would happen, and that what would be a typical path is a person might be moved from one unit to another, didn't work here, try here, and then didn't work there. Maybe we should be focused on a setting with a higher level of care. I wonder what your reaction to that potential path to deal with situations where we have real challenges on the ground where it may not be working for the person or their neighbors in a particular unit.
Especially because of the vulnerability of our clients and the vulnerability of our relationship with our clients, I'm always hesitant to force people into that choice, right? And I always want to be asking, did we exhaust all possible means? Did we do everything that we should have done, that we ought to do before really advancing something like that? And so I think that there is an opportunity for us, especially, for example, if the traditional PSH model isn't working, is there a way that we can consider and escalate so that a team with more expertise, with the appropriate behavioral health expertise, is that maybe when we should be connecting folks to act? Should that be a part of, if this program's not working, then we are diligently and deliberately making that connection to a team that has the additional supports and services before we say, hey, it's got to be site-based. Hey, it's got to be at this particular location and at this higher level. Can we afford them the flexibility and deliver those higher levels of services without constraining their choice? I think is what I would prefer to default to first.
Well, I definitely hear you, and I think the way in which I described it is, it's not the first answer, it may not be the second answer, but very useful to hear your perspective on it. I do think we're going to turn to the other witnesses at this point. Okay. I am told that Councilmember Henderson doesn't have any questions right now, but we'll follow up. I think we should have an ongoing conversation about this. We're taking this all in and need to figure out what it is that we'll do. And absolutely want to be working with you as we go forward.
Thank you so much. I definitely appreciate an ongoing conversation because it's not one roundtable that's going to solve this problem. I think we need a sustainable approach, and working in partnership, I would love to be a part of that solution. Absolutely.
100%. Thank you very much.
Thank you.
So we move now to our okay, I think we want to take a 5-minute break, and then we will call up our two government witnesses, Dr. Bazaran and Director Pierre.
I went like 10 times. Why did you wait? For great. Waiting there too to try to. She's really good. I had to swear. Yeah.
All right, thank you, everyone. Let's get back on track. It was good to have a little bit of a break. It's been a long day. But the end is in sight. Acting Director Pierre, Dr. Bazaran have joined us at the table. As you know, it's the practice of the committee to place our government witnesses under oath. If you would please raise your right hand. Do you swear or affirm under penalty of law that the testimony you are about to provide to the Committee on Human Services and the Committee on Health is the truth, the whole truth, and nothing but the truth?
I do.
Wonderful. Thank you. I think, who wants to go first?
Thank you. Well, good afternoon, Chairperson Fruman, Chairperson Henderson, members of staff of the committee. I am Rachel Pierre, Acting Director of the DC Department of Human Services. Thank you for the opportunity to participate in this public joint roundtable discussion on behavioral health supports in our local housing voucher programs. The District Permanent Supportive Housing Program, administered by DHS, provides long-term rental assistance paired with individualized intensive case management services. This program has helped thousands of district residents exit homelessness, overcome housing crises, and maintain stable housing in neighborhoods throughout the city. Through this participant-driven model, DHS supports residents in improving their health, wellness, and community integration. Our goal is for everyone impacted by this program to experience its benefits and live in communities that support the well-being of all residents. When our clients thrive, their neighbors and communities thrive too. Today, I will provide an overview of the PSH program with a focus on how the district supports residents, particularly those living with serious mental illness or substance use disorders. I will share updates on DHS's collaboration with our partner agency, the Department of Behavioral Health, as well as key stakeholders as we work to strengthen our service delivery for district residents. When Mayor Bowser took office more than a decade ago, she committed to making homelessness in the district rare, brief, and non-recurring. Since then, district agencies, council members, nonprofit organizations, businesses, and community partners have coalesced around that shared vision, working collaboratively to drive meaningful progress through innovative, evidence-based, and person-centered best practices. Our successes are both visible and measurable. The modernization of facilities that support individuals and families experiencing a housing crisis reflects our DC values of dignity and respect. The 2025 point-in-time count further demonstrates the impact of these efforts, showing reductions in homelessness across both the family and individual systems. These outcomes underscore the effectiveness of our investments and the strength of our coordinated response in the district. In alignment with this commitment, DHS has significantly expanded its permanent housing programs for individuals and families, more than doubling their reach in fiscal years 22 and 23. These historic investments have been sustained through continued funding in each subsequent years, reinforcing the district's unwavering commitment to housing stability. DHS employs a progressive engagement model to ensure that individuals and families receive the least intensive and least costly intervention necessarily to resolve their housing crisis. At the highest end of this continuum is PSH, our most intensive and resource-rich intervention. Through PSH, we currently serve 8,000 households. PSH combines long-term rental assistance with supportive services to help those who have demonstrated chronicity and have disabling conditions exit homelessness and maintain stable housing. In alignment with evidence-based practices, DHS operates PSH as a housing-first model, which prioritizes immediate access to permanent housing without preconditions such as sobriety, treatment, or engagement in case management services. We consistently find that housing serves as the foundation for overall well-being. Once individuals have a stable place to live, they are better positioned to address other challenges, including behavioral health, substance use, and employment. Studies show that 9 out of 10 remain housed 1 year after receiving housing first assistance, and that housing can be 3 times less costly than criminalization. Originally launched in 2008, PSH has evolved over the last 17 years. One of the most transformative development has been the integration of Medicaid as a funding source for supportive services, marking a major step towards sustainability and system alignment. Today, approximately 80% of PSH case management services are funded through Medicaid, significantly reducing reliance on local dollars and enabling the district to serve more residents. Case management within PSH is organized into 3 distinct phases: assessment, housing navigation, and housing stabilization. I would like to take a moment to focus on the housing stabilization phase and highlight how intensive case management plays a critical role in supporting participants maintain stable housing, adapt to life in a new community, and improve their overall well-being through consistent guidance and personalized support. To deliver intensive and person-centered case management services, DHS partners with 23 community-based organizations. These services follow the Housing First model and are tailored to meet the unique needs of each household. While some participants benefit from weekly and home visits, most require less frequent support. Case managers providing HSS work collaboratively with participants to determine the appropriate level and type of assistance. During the housing stabilization phase, providers are contractually required to maintain at least 2 contacts per month, one of which must be an in-person visit to the participant's home. Each participant develops an individualized service plan with their case manager, which is reviewed and updated at least once per quarter to reflect evolving needs, accomplishments, and goals. Participants also review their overall service plan goals, revise existing goals, or set new ones during the annual assessment. Individualized support often includes the case manager connecting clients to resources, services, and support that aligns with their priorities and needs. Those could include things like a referral to DBH's core service agencies for behavioral health services or connections to a home health aide, or facilitating a meeting with a neighborhood school to ensure kids are enrolled. At intake, all participants are assigned a case manager, though after the initial 1-year period, they may choose to waive case management if they feel stable and no longer require ongoing support while continuing to receive their housing subsidy. Recognizing that circumstances can change, DHS continues to conduct quarterly wellness checks for participants who opt out of case management. With that overview of PSH case management, I would like to spend the next few minutes discussing how DHS conducts oversight and accountability of case management services.
Director Pierre, really appreciate we got the testimony, both Councilmember Henderson and I reviewed it. I wonder, if you can, in 2 minutes, just summarize what's there, because I'm sure we're going to cover that this territory. And again, really appreciate the fact that you got it to us in advance, that you got us the pre-hearing questions in advance. But we are diligent students and we've read it all.
Sure. So maybe I can just read the closing remarks and then we can wrap it up. And I'm happy to answer questions. In closing, permanent supportive housing is a powerful foundation, but not a one-size-fits-all solution. For many, it marks the turning point from crisis to stability and from stability to growth. DHS remains committed to engaging households with empathy and persistence and encouraging voluntary participation in services that reflect each individual's unique journey. This work is only possible through deep partnerships with community providers, sister agencies, and the residents we serve. Together, we ensure that when someone is ready to engage, we are ready to support them, and we expand housing programs, strengthen oversight, and refine service models. We remain guided by the belief that housing first works, and coupled with consistency and compassion, we create the conditions for long-term stability and well-being. Thank you again, Chairperson Fruman, Chairperson Henderson, for the opportunity to testify. I welcome your questions and look forward to continued collaboration.
Thank you very much, and I am sure we will cover the passages that we skipped over in Q&A. Director Basron.
Yes, and I will be quick in my remarks. First of all, thank you very much for having me. I'm Barbara Basron, the Director, Department of Behavioral Health, and I'd like to say good afternoon to Councilwoman Henderson, Council Chairperson Henderson, as well as Chairperson Fruman and council members and staff. I'd like to spend a moment talking specifically about the collaboration with the Department of Human Services to provide behavioral health care services and supports. Residents who receive rental supports through DBH are a fraction of the residents with housing vouchers. As Director Pierre testified, DBH works closely with the Department of Human Services to support non-DBH housing voucher recipients. We also have our own, and you saw that described in my testimony. Though the majority of tenants are able to manage with existing supports, a small percentage of the tenants require additional supports to maintain independent living. One of the efforts that we have just put in place is a new activity that is our $1.3 million that is being used to support housing voucher recipients. To focus supports on these residents and to enable better monitoring of outcomes, DBH, through the Office of Contracting and Procurement, awarded a $1.3 million contract to community-based provider organizations in May. Community Connections is the provider of choice. Community Connections supplements the work done by DBH by providing direct and ongoing contact with residents whose behaviors lead to complaints and requests for assistance from their neighbors and landlords. Community Connections is responsible for coordinating support or re-engaging individuals with their mental health provider. When a connection does not exist, Community Connection works to encourage them to agree to services. With this consistent, ongoing engagement, we expect to reduce reliance on the community response team or law enforcement by preventing or reducing the severity of a psychiatric crisis, which disrupts the tranquility that residents expect in their own home. Also, a resident or landlord can call a dedicated number managed by Community Connections to report any concerns that they may have about the behavior of a resident before it escalates to a crisis. The number is 202-281-2911. Calls to the hotline are returned within 2 hours during the business day on the same day, and the next day if it's after hours. In the 5 months since the program has started, Community Connection reports encouraging results. It has engaged 535 referred residents and connected 31 of them to behavioral health services. It has provided landlord mediation services for 12 residents to stabilize their housing. It has received 84 calls on the tenant landlord support hotline. That hotline is very important because it is an immediate connection to care. The program, which supports individuals in all 8 wards, has a capacity to serve 500 individuals at any one time. About 2/3 of the current participants have DHS housing vouchers, and nearly all of the remainder have vouchers with the DC Housing Authority. I also want to just take a moment, if I might, to talk about our work to address concerns about housing voucher recipients who live in a number of apartments along the Connecticut Avenue corridor, and you heard about that earlier today. To better support residents and property managers, Community Connections has assigned a case manager in 8 buildings identified by the Tenant Association, property managers, and community members with high numbers of reported incidents involving individuals whose behavior suggests behavioral health concerns. These case managers are responsible for on-site presence Monday through Friday. While on-site, the case manager engages with residents known to them, conducts wellness checks for residents based on referrals, and coordinates with property managers. They check in with the property managers or the concierge to hear updates and to address any concerns. They coordinate care for residents, including crisis support if needed. The case manager also will assess whether a different level of support is required and connect them to that level of care. Because treatment for mental health disorders is voluntary, except in limited, legally defined circumstances, we know that consistent, respectful engagement that builds trust is the way to get people to accept the help they need. At the same time, we know every person has the right to enjoy peace and tranquility in their home environment. This concludes my testimony. I'm ready for any questions along with my team, and I'm happy to talk about other innovations that we have put in place in partnership with DHS.
Wonderful. Thank you very much to both of you. I'm just going to ask a few questions in the first round and then turn over to Councilmember Henderson. But Dr. Bazaran, very exciting development that you're talking about. Help me understand the mechanics of the program on Connecticut Avenue. And so is it 8 individual people who each will be assigned a building, or is it one caseworker who's assigned to 8 buildings?
No, it's one caseworker that's assigned to one building.
Okay.
And they are responsible for being there on a routine basis because we want to really begin to build those relationships. And also we want to build relationships not simply with the resident, but also with building management, so that they know who they can call quickly and they know when to expect somebody on site. And so I think that this is a model that we are tracking very closely to see if this on-site presence is the way we need to move in order to work more quickly with people.
Very, very helpful. How do you see the interplay between these people and Community Connections? It was Mr. Cabeza who.
Community Connections is both a certified behavioral health provider offering both mental health services and substance use services and housing supports, and also is the contractor.
No, I hear you. And Mr. Cabeza from Community Connections testified earlier, but how do you see the interplay between those caseworkers and the individual caseworkers for the folks in the building already? How's that going to work?
They are responsible for making those connections, and we expect them to be in communication with other caseworkers that are involved with the individuals of concern that they are working with.
And this is a new thing. When we saw your testimony, we were very pleased and excited to see it. Are these people in place yet, or are these people who will be coming into place in the near future?
They're in place now, yes.
How long have they been in?
How long has it? Launched in May. In May, since May. Mm-hmm. The designated people have been in place for the past 2 months. We launched actually the whole contract in May.
And you may have said it already, but will these people be in contact with the tenant associations as well?
Absolutely, and as a matter of fact, I did speak with with Miss Lance just to find out whether or not she knew anything about them, and she said, absolutely. I know about them. My building manager knows about them. They are working, and we're happy that that's happening.
Okay. Thank you very much. A different model, and I want to be grateful to the model that we're using, but a different model that we sometimes talk about is a hub where there would be a number of different service providers in one location close to where there were people with high needs. What do you think of that model? Something like what's happened at Gallery Place, Chinatown?
Mm-hmm. Well, I think that certainly it's worth exploring. I will tell you that one of the things that we're looking at doing, which is slightly different, and that is finding, for example, launching sites for services. So one of the issues we have, and particularly in terms of response time, is that if somebody calls and the team member is way across town, by the time they get there, the matter could have been resolved, the person could be someplace else. And so we're looking at how we can have these kind of launching sites in different places. And so that's also something that I want to explore. The other thing is, I think that the Department of Human Services and the Department of Behavioral Health have really worked very closely together, linking our various case managers. And I think that's another way of providing that continuity of care and ensuring that people get what they need.
Well, I appreciate that. I'm gonna stop here and turn to Councilmember Henderson. I will say that coordination function, we heard from a lot of folks.
Right.
And I think everybody here is humble about how things have been going and that there's room for improvement, but that is a space that pretty consistently during the course of the day, we heard, how do we strengthen that cooperation? With that, I'll turn to Councilmember Henderson.
Thank you, Councilmember Freeman, and thank you all for your testimony and for being here. I just want to do a quick follow-up on this around landlord supports and otherwise. The case managers or the caseworkers who are part of this Community Connections pilot, are they considered clinicians or are they just case management?
They're just
purely?
case managers.
Okay.
Yeah. Mm-hmm.
And I guess I'm trying to understand how Community Connections sort of got picked. Damien and his team are great, but I'm wondering, for the 8 buildings, I don't think as far as I know, Community Connections is not a housing provider and providing housing.
They are a housing provider.
Do they do the housing casework as well?
Yes.
Through the program? So were these already not their buildings, but did they already have the majority of the cases for the individuals who are in these buildings?
I mean, it's hard to say the majority, but they probably have some. We have 23 providers, so they probably have some case managers already in those. I mean, some clients assigned to some of their case managers in the building.
Okay, but then, I'll go back to my original question of how did you guys select Community Connections as the one for this type of work?
We put out a solicitation, and
Oh.
actually we put it out several times. And then that is the one, you remember? Yeah, okay. And then we finally got a provider because we wanted to launch this. We felt it was very important. And so it was that competitive process.
The intensive case manager money that kept sitting, and I was wondering why you haven't spent it and you wouldn't let me take it. Got it. Okay. Glad we got all of those pieces together. Great. I will give you an opportunity in terms of like the feedback from the landlord panel in terms of their desire to have more upfront training or guidance around the program and maybe working with their property managers, obviously not to do the case management piece, but to provide some additional context. What were your thoughts on that request?
Well, I actually did an event with a number of the property managers and board members in that Connecticut area, and it was. They said it was very helpful because we talked very specifically about how services could be accessed quickly, how support could be accessed, and then the nature of some of the problems that they were facing. One of the things that I have spoken to them about is, we're certainly willing to go out and provide other supports. And also, certainly our provider can provide that kind of support.
So you've offered that for their properties along Connecticut Avenue, but I think to their point, this isn't something that's isolated in that area. I feel like in some ways, for better or worse, it's been elevated because of some of the issues that have happened in that part of town. But even Mr. Sheffield was sort of talking about for smaller providers who don't necessarily, right, they're not Bazzuto, they're not Borger, they're not these other larger companies. How are we connecting with them in a sort of systematic way? Not when there's a problem, but like at the very beginning and just sort of providing regular updates.
I can speak briefly and then I'll turn it over to Director Pierre. And that is that any building can call the hotline. It is not just focused on that area.
I would just say their request wasn't around the hotline when there was an issue. They want to know on the front end.
And Community Connections, a part of their mandate was to actually go out and meet with the other property managers so that they know about the service, because they do have a responsibility for telling people that the service is available.
Okay, Director Pierre.
I'm sorry, go ahead.
That's quite all right. So I think a few things. What I also heard from the landlords is that at Connection, usually they know who the case manager is, but oftentimes with turnover and so forth, that communication is kind of, there's a breakdown in communication. Just hearing the testimonies today, I do think there's an opportunity to re-engage our landlord partners, because we used to have a landlord partnership advisory council that we used to meet with landlords on a regular basis, and I think that helped in terms of them providing support to each other and so forth, because we have a landing page on the DHS's website for landlord and community resources where they can go and actually go and type and see what resources are available to them, how they can get access to the landlord partnership fund, how they can figure out who is the case manager or the provider assigned to their the resident in their housing unit. So based on just the testimony today, I do think that there is an opportunity for us to kind of revive that group and really make sure that we communicate. So, we'll continue to send the information about the landlord and community resource. We just also heard that there was a balance in the landlord partnership fund, meaning that landlords, housing providers are not taking advantage of the resources that we have set up for them. And I do think that we probably can do a better job with strengthening those resources, these connections.
What about in terms of updating record keeping? So one of the things that was mentioned was that, when there is a particular issue that might arise, the first thing that they're looking to do is call the case manager on file, and then they'll find either the case manager is no longer with the organization or they're no longer with this particular client. What is the process for updating those files when there has been a change in who has been assigned or just personnel in general?
Yeah, so my understanding of how it's supposed to work is that at the first, home visit, that when you have a new case manager, they also make contact with the landlord. It's not always possible because of depending on the, housing units. Sometimes it's a 4-building unit where you may not have a property manager on site, and so forth. So it needs to be individualized based on the housing intervention. But I think, if anything, the resource is there. This is on the landing page, on the landlord and community resource page and DHS. There is a place for a landlord who does not know who to contact to go there and get information on who to contact so that we make sure that there's a connection. So that even on a micro level, if a case manager does not do that connection themselves with the landlord, a landlord has a way to figure out how to make a connection with either a case manager, but at least the housing provider who's attached to this resident.
It's like 26 seconds. It's not really enough time for a question, so.
All right, thank you very much, Councilmember Henderson. On this, the communication, so often, like, people will come to me and say, nobody told me, and I know, I told them 4 times. And I don't know whether that's the case, but I'm a little surprised that I learned about these programs through your testimony. So I wonder what proactive things you've done in terms of communication around this, both of these things, the hotline and the program on Connecticut Avenue. And Director Pierre, you spoke to, well, maybe it's time to reconvene this landlord group. That might be a positive thing going forward. But maybe we fell down, that we didn't know about it, but we didn't know about it until yesterday. So what have you been doing?
Well, I feel that more communication is necessary. And we have charged our provider with communicating with all of the building managers and other supports like tenant associations, but we need to do more. I am very clear about that. And I think that there's some ways of doing more by, pulling people together, as well as we did meet with a group and we gave them information at a meeting, but we need a more individualized approach.
All right, well, I appreciate that.
Yes.
Thank you very much. So I want to go back to some of the themes that came across in all the different testimonies. So on case management, and case management loads and case management performance. In the answer to pre-hearing questions, it looks like case management loads vary, but also I don't think there's been like a corrective action plan for case managers for anybody, maybe since 2020. And I'm wondering, how do you monitor the case management load, including the acuity component to it? Because we heard from different people, well, you know what, 12 might be right in this setting with this level of need, but at a higher level of need, it might be a lower number. So how do you deal with that? And how are you overseeing the performance of your case managers to make sure there are some great players, and we heard from them, but we also hear about gaps in performance, and we don't see it in the oversight that the agency has provided?
So it's a question of a few things. We may not have seen some corrective actions for providers, but we have issued some performance improvement plans for various reasons through the audits. So we continue to monitor and audit cases monthly. So we do 10% of audits of cases monthly. We go into the case notes, we review, and then based on the results of the audits, we then put providers on performance improvement plans. I think you heard from not just Dr. Sims-Barris, the providers, and even the clients in terms of the need for just a ratio and a range for case management services, for the caseload, I mean. So if someone has a caseload, a very of very stable clients who've been in the program for multiple years, they may not need more than one visit. And even that one visit a month may seem even like overbearing because they've been stable for quite a while. You and I spoke earlier this week about the opportunity to step down to a quarterly visit, and that's exactly what we do to assess the caseload, to have the option of stepping up people when they may have been on a step down, like a TH program, or stepping down people when they no longer need that that level of services. Someone with a caseload of who are all still in the housing navigation phase. What we call housing navigation phase is when somebody's matched to a voucher, but they are still in the lease up process. That is definitely more intensive caseload because you require more visits actually contractually. And we know that in order to help somebody move from homelessness to housing, you need to be working with them more than just once a month in order to speed up that process. So while in the contract, we have it as 1 to 17 for families and up to 1 to 25. It's a maximum, not a minimum. And then we expect the providers to kind of use their judgment in terms of assessing the caseload based on acuity and so forth.
So,
Oh,
go ahead.
did you want me to respond?
Sure, please do.
Okay, certainly. We hold our certified providers responsible for the performance of those who are doing care coordination or their community support workers are working directly with the individuals who may have vouchers or may have a mental health problem. And we have provider relations that provides ongoing technical assistance and ongoing site visits to see and visit the providers to find out how things are going. We also do provide a public provider performance report that looks at the degree to which our providers are functioning effectively. So that's just some of the things that we do. We don't have the same kind of case management system that.
All right, well, thank you very much. I'm curious.
So our community support workers are mandated to follow up.
Dr. Sambaris, one of the things he said was the caseworker who hands over the keys should be the caseworker who works with the client going forward. And I'm curious your reaction on that.
So I 100% agree. And there are two models of how that happens. In our current model, that's exactly what happens. Just so you know, so we have outreach teams who are not PSH case managers. They work with totally unhoused clients. When someone is then matched to a housing voucher, they are more likely still experiencing homelessness. They're either unhoused, so they may not have if they're unhoused, they probably have been working with an outreach worker. If they are experiencing sheltered homelessness, meaning they are living in shelter, they don't have a outreach case manager, but they have the PSH case manager assigned to them when they are still experiencing homelessness. So that same case manager actually helps move that person from homelessness to housing, and that's the case manager that continues to work with them. The relationship breakdown happens when somebody has been unsheltered for a long time, and these are usually the hardest folks to engage because they even refuse to come into shelter and so forth. And then it's not just a warm handoff, it's a collaboration until they are moved to the housing. When they move to housing, they no longer obviously has the outreach worker because that outreach worker is by definition working with people who are considered to be unsheltered. But it is still the same case manager, the same PSH case manager who is assigned to someone when they're still experiencing homelessness, who continues to move them into housing and will continue to be their long-term case manager.
Okay,
From a behavioral health perspective, I totally agree. I've worked with Sam Simperas for some years, and I do support that position. It's all about relationships, and it's all about engagement and the degree to which you have that relationship right at the beginning before that person moves in. You're handing them the key, and they are then agreeing to enter into that relationship. I think that will have more positive outcomes.
All right, well, my time is up. Councilmember Henderson.
Thanks. Let's talk coordination. Does DBH have a formal MOU or data sharing agreement with DHS to track real-time PSH participants?
No, we don't have a formal MOU. However, We do bump our systems, the HMIS system, to determine whether or not there are individuals in that system who have behavioral health needs and are in our system of care. And then we do coordinate our services around those individuals. This is particularly important for the by name lists that DHS has so that we can follow up. And our intensive care coordination team, as well as our PATH team, work very closely with the DHS team around those individuals.
Should you have something a bit more coordinated in terms of your databases of systems?
I would welcome that opportunity. I mean, I think oftentimes this is actually,
Yeah.
and that's not just from a behavioral health and housing coordination, but the lack of visibility across program
Yeah.
because it does create a barrier and what we could see a better coordination between services.
I mean, even Marie's talked about
Sure.
like in her own organization,
Yeah.
right, that they're off divisions not talking to each other, although we're dealing with the same,
Absolutely.
person
Right.
and client. So how does DHS verify that an individual referred for a PSH through the coordinated entry are actively connected to the mental health provider or core service agency? Is this the bumping up that Dr. Bazaran was talking about?
So we have through it's a part of it. We have through we do have I think Mr. King can go. We do have a person within DHS, within DBH that we can make a referral when we think that the person is not connected to a CSA. So just say we know that we've made a referral and that we don't know whether or not the person is connected because we are not seeing the services. We can reach out and ask for a reconnection. So there is a way for us to request reconnection when we see that there's a lack of coordination. There's always opportunity for improvement to really be able to have real-time access and be able to maybe potentially bump our system, but there is an avenue for us to request reconnection when we've made a referral and it appears that the client may not have necessarily made a complete connection with a core service provider.
Okay. I mean, so I think this is like when folks in the community who aren't necessarily a provider or have the background pieces, they sort of think, okay, I hear the program, permanent supportive housing. And then you have to, they're like, that's DBH, and we have to align them. Nope, you start over at DHS. I guess you could technically start with DBH, but for the purposes,
with DHS,
it's usually with DHS. And then there are assumptions made that people in PSH, you could be in PSH for a variety of different reasons. For some people, it is you need that just additional pieces of support as you're transitioning from perhaps being unhoused, and you need some support to help you sort of transition in that period. Then for some people, they might have some sort of behavioral health need. They might have co-occurring disorders and all of those different things. But then when we say, yes, you have a PSH voucher, but the only thing that you have to do technically to be a part of the program is agree to case management at least twice a month?
Yes.
Is that?
Yeah, so that's from the client's perspective, right? Because that is what housing first. There's no precondition. We don't say that if you have to do these things. That's from the client perspective. That's not from a service provider perspective. Housing first is housing first, not housing only. And we don't implement it as housing only. We provide case management to everybody who moves into housing. And we have a very, very small percentage of people who actually opt out or waive out of case management is less than 2%. And there's still an extensive process on somebody to officially be approved to be opt out of case management. I mean, I think you also heard from testimonies from Rochelle Ellison, for example. She's somebody you could say, well, she's still in the program, but she chooses not to engage in case management. And what this means is that she doesn't have to open her door in order to stay in the program. But that doesn't mean that we're not going to come to the door every week, right? So that's what we mean by saying that services are voluntary, because we're not going to kick her out of the program because we know that she needs the trust, she needs the consistency. And for someone, it may take 2 weeks. For someone, it may take 2 years, but we know that she's a person like her, and I'm not using her, I'm just giving an example that she's used, someone who may have experienced trauma and distrust and so forth, that it may take longer and maybe different case managers until you find the right person before you start trusting again.
Yes, I understand that. But then I also feel like in those situations where Ms. Ellison's situation is different. So let's just take a random Sam. Random Sam has extreme night terrors and is disruptive to the neighbors and might, and Miss Lance sort of talked about it, right? Might leave the apartment and walk out naked through the halls and bang on his, the doors of the neighbors and sort of do all of these different things. Sam also isn't connected with a DBH provider and is actually choosing, like, I don't actually want to do that. I'm not saying that Sam can't stay in his housing, but at some point, I think for folks, it's like, okay, you're part of this permanent supportive housing program, which is how you got here in the first place. We are recognizing that you have a need here and that not addressing your health need is actually now impacting the community around you. How long do we allow for Sam to just spiral without intervention?
But we would never allow Sam to not go without intervention. Whether or not now we get to a point that Sam is compliant with what we're suggesting that he does is a different story. Right? So because there's this perception that because someone is not, the night terrors haven't stopped, that they're not receiving services, but we know that severe and persistent mental illness, there's no cure for that. There's only treatment, and that most people who are even managed, they will relapse. It's just the part of the disease, like anything else, right? You could be treated like for cancer and then you relapse. So when we talk about severe and persistent mental illness, that's exactly what we're talking about. So then somebody like him could then CRTs comes in or CPAP and they go into a crisis bed, and then it looks like for 1 or 2 days they're stable, they go back to the community, and a week later it kind of comes back up.
Yeah.
So we will continue to work with this person probably every day, but if every night the neighbors hear the terror, they will assume that we are doing nothing, and we never not do anything. It is the perception that because it's not fixed, then that means that the services are absent. Right. So what we're talking about, it is the hardest, and I don't think there's anybody who's doing it like in the world who has cracked the code on how you really treat the hardest people who are experiencing severe and persistent mental illness outside of committing them to a psychiatric hospital. Right. So that's what we're talking about here. So it's not a poverty, it's not a voucher. It's really like the issue is really an extreme behavioral health and mental illness.
And I think that's one of the reasons why many of the voucher holders are in ACT, assertive community treatment. And that was what Dr. Simbaris was talking about as service and support, because that is 24/7. And the ACT teams are on call 24/7 to help that individual. And so I think that's important. The other thing to note is that if that person is receiving care and we're doing that care coordination between DHS and DBH, we can share information so that on behalf of that person, so that we can make sure that they're getting the treatment that they need. And so I don't want us to think that there's nothing that happens. We can and do provide intensive services for those individuals.
Okay. This has been a great hearing. I do have a round of questions that I'm going to do. I do think that one path forward is to meet after this to go over things that we're not able to go through in this setting. I hope you feel like it has been a very constructive day where we've heard a lot of different perspectives.
Very instructive.
Going to try to touch on a couple of different things, and I'll give Councilmember Henderson the last word. One of the things that we've talked about is home visits, and the need for home visits might vary, but there are settings where it feels to us that home visits could make more sense, greater frequency could make more sense, and requiring it could make more sense. One is where there have been persistent lease violations. So we have a situation where somebody is being disruptive to their neighbors and exhibiting behaviors that speak to a need on their part. And another is where there are young children. And that's highlighted for me by some of the experiences that we've seen where we've lost some children. So I'm curious your reaction to the idea of requiring weekly home visits in a context of lease violations and where there are young children, and whether in the home visit context where there are young children, how important it would be to lay eyes on those children.
So our human care agreements have 2 visits or 2 contacts as a minimum, not as a maximum. And it's clear, it's laid out very clearly. And when there's case manager and does an assessment, then they are expected to increase the visit frequency based on the needs of the family or the needs of the household. And I think that also speaks to what Dr. Simbaris mentioned, that you need to be able to vary the services intensity based on the needs of the family. The reason that we have a minimum and not a maximum, because most in a contract, because once you put a maximum, then someone may have to prioritize, well, Sam needs 4 visits, but I have to give everybody 3 visits. So I'm going to give Alicia 3 visits so that I can be compliant with the 3 visits when Alicia may only need 1 visit, right? So it allows for the clinicians to really focus their energy on who needs it the most. So that management of how many visits needs to happen in supervision. I think you also heard the provider testify on the fact that we are require clinical social workers to be supervisors so that they can themselves supervise the case managers who may or may not be social workers in terms of assessing the service needs. It's never going to be a perfect assessment on how many, who needs more visits, but it's the requirement is very subjective. It's really just based on the needs of the family, of the household. And that's something that can only happen based on a clinical evaluation, a clinical assessment of the person.
And that was what I was going to say, is that a risk assessment that is a part of a clinical evaluation also informs that process in terms of how often do I need to see this person? What kind of home visit do we need to do, and so forth?
I hear you on that. I don't think it's a choice between a minimum and a maximum. I think that we have certain circumstances that have become hot buttons. And the question is whether or not the minimum in specific contexts should be higher. And
And I actually stand corrected, Councilmember, because we do have in some cases, there's a requirement of 6 visits in the contract based on identified additional needs, so that we can require case managers to do more visits based on identify that the client, has a higher level of needs.
okay, so that's a thing I'm going to look to build on. Then there was some discussion, and Dr. Simbaris sort of was negative on this, and I think it was really helpful to have Dr. Simbaris. But to what extent, when you're evaluating people, do you think this person would be better off starting with a transitional housing program as opposed to moving immediately into a permanent supportive housing voucher? When you are evaluating a person's needs going in, if you had the bandwidth of transitional housing, are there more people who you might have directed first to transitional housing as opposed to a PSH voucher?
I think Dr. Simbaris answered the question much more than I ever could. That there's just no tool to really evaluate based on what the presented needs of someone. What we do know is that some people will not come in even to shelter. They will not come into transitional housing. So even if we were to make a recommendation for them to come in, they will not. Some people will only come into their own housing because oftentimes these other facilities do come with more regulations, like a curfew and this and that you don't get in your own apartment. So, Councilmember, there are folks who are on the street that for whom we have, intervention. They could come into shelter, they could come into bridge housing who continue to say no. And in those cases, the only tool is really connection to services in housing. Right? And so a case like this, we would really try to make a connection to an ACT team prior to the person moving, but it's hard to tell who's going to be successful. And the good doctor said it much more than I ever say, that we don't have a tool that really actually assesses this.
I would like to just add that the Department of Behavioral Health does provide housing for individuals who have serious and persistent mental illness who need more. And that's in we have a whole series of mental health community residential facilities where people actually have on-site support 24/7. And we are currently providing housing to 544 people in that type of environment.
So I hear you on that, and thank you for that. I do think, so there's one question about going in, and there are limitations going in of identifying the people for whom that's appropriate, but then there is in a sense, coming out. And one of the things also that Dr. Tsimberis talked about was where you have people who it's not working for them or their neighbors, it may be appropriate to move them. It might be appropriate to move them twice. And if it still isn't working, it may be appropriate to move them or to a higher level of care. And I'm curious what your reaction to that is.
That's exactly our model. So we don't have the enforcement to force somebody to leave their apartment unless it's a criminal issue. Then it becomes, they get arrested, or they've assessed to be a danger to themselves and others, and they go to CPAP, or they get committed to St. Elizabeth. When somebody has a lease on their name, even if there are lease violations, we continue to work with the person for them to voluntarily agree to be moved to another, placement. For us, for CHS, what that looks like is with the few buildings where we have site-based PSH with, services on site. If we have an opening, then we will make that recommendation. We bring pictures and we show. We will do tours of the building so that the person knows what they're saying yes to, and we'll continue to encourage somebody to say yes. And I also think you heard from Mary's Kitchen. In some cases, waiting for the person to be evicted is the only tool that we have, because we if the person continues to say no, if they get evicted, then they have no choice but to work with us to get them rehoused. That's never something that we want, but we're not a law enforcement. We can't physically pick up people and force them to move when they have a lease in their name.
No, I hear you. I do think I want to look for ways to give you more leverage in those settings, because they arise they arise with some frequency. And so that's a thing let's continue to explore. Last thing, and it was a little foreshadowed, is you try to connect folks with an ACT team. Do we have sufficient capacity with our ACT teams in order to serve the need that is out there?
We have not turned away one person from ACT who's needed it. And so we have 9 ACT teams that are serving almost 1,000 people. And so we haven't seen that to be an issue.
But is 9 teams serving 1,000 people, so each team serves 100 people or 110
It's
people?
100, yeah. Each ACT team can serve up to 100 people, yes.
And
the way the team, because remember, it's a team of people who all have responsibility for that panel of individuals. And that's the evidence-based practice.
And you feel that you have the capacity that you need?
Yeah, at this point, yes.
Okay, with that, I'll turn it over to Councilmember Henderson.
Dr. Bazar, how do you guys evaluate the quality of the ACT, of the ACT teams?
We do it we do on-site visits. We have a provider relations person that is responsible for providers. And if the provider has ACT services, then they are responsible for making sure that those are offered to fidelity. The other thing is here again in our provider, I'm calling it provider scorecard. That's not the official name of it. We also get data that way. And we also get feedback
from participants
in terms of whether or not the service is working or not working. And Dr. Moise's team of clinicians will provide support in that instance.
So in the instance, so to kind of back up a little, Director Pierre, you were saying like, we don't have that much information at the beginning in order for us to make a determination about whether or not, but there could be a situation where the person is known to DBH.
That's correct.
And so at the very beginning, if they are already connected in services and a DBH clinician who knows the individual who's like, I don't know, I don't think we're there. What happens in those situations? And is there space for that in suggestion to be made if a person had already been working with a clinician and the clinician is determining based on the work with that individual that perhaps independent living at this particular stage is not going to be a good fit?
We in the district apply a housing first model. By definition, there's nobody who's not ready for housing. Housing first.
No, not ready for housing, ready to be at a scatter site using of a voucher as opposed to something a bit more structured.
So, and Dr. Bowser may speak to, what that looks like in terms of, because then it becomes a behavioral health intervention versus a housing intervention. So I know Dr. Bowser and DBH has SROs and so forth, and maybe they would say yes to a situation like that. But for us, when the only tools that we have when somebody's experiencing chronic homelessness, is helping them move into housing and making sure that they continue to be connected to behavioral services. I have to say, I do think that even from a system, there could be, and I'm looking forward to working with Dr. Bowser on this, an opportunity to better connect people to ACT teams or folks who we have identified probably needs a higher level of care to an ACT team prior to them moving. I do think that there's a gap to a certain extent in terms of a higher level of services prior to the person moving into to housing, because sometimes that referral can be made and a connection is not made.
That's true. That intervening time.
Right. So as a system, these are the things that we're talking about. How do we better sort of kind of like map out where the gaps are? And I think it's important to hear from the gaps that the community and the providers have identified. I do believe there's a gap. And I think that this is something we need to look at. How do we make sure that there's better connection before people move into housing? Because it is true. It is, from a DHS perspective, it is the same case manager who helps people. They're assigned to them when they're still experiencing homelessness to move into housing. So we continue that process. But if there's a identified higher level of care need, we may need to really focus on these individuals, making sure that they're already connected to an ACT provider, making sure that the ACT team is part, if you're already engaged in moving this person in, because we've identified that the ACT team is probably going to be what is most important to keep the person stable. So
I'm sorry. My apology. And so I think that we actually are moving in the direction of closer coordination through some of the things that we're doing right now, where we are really embedding our teams together. And they are actually going out and working with the unhoused population together. And through that, they are learning about the needs of those individuals, who many of whom may have a voucher, may not have moved, and may be eligible for a voucher, and so forth. And so I think that that kind of coordination will make a big difference. And Director Pierre and I have really talked about that and how we begin to utilize the learnings from that process.
I think I would be more interested, not more interested, but I am very interested in sort of what that coordination piece looks like going forward. And I do want to be clear, I don't feel like our housing first approach is incorrect, but I do feel like in some cases, and while I hear experts saying like, oh, the first location might not be good and the second and the third and the otherwise, I feel like every time we're moving, like there's a negative experience and we have to move someone, it's almost like we're stepping backwards, and that could also be doing some harm, right? Director Pierre, when you said like our sometimes we have to wait until the eviction happens because that's the only reason. Well, eviction is a freaking traumatic event for anybody. And so if there's anything that we can do to avoid that from the front end to set someone up for success, that's really what I'm trying to say is like, what does the coordination look like to set someone up for success? Hold on one second. The one thing that I also want to suggest though, in the coordination of this is a great little duo that you have here, but I feel like it should be a trio, and that CFSA should also be part of the conversation, particularly when we're thinking about the number of kids who are also impacted by this program.
Two things. So we do through the CAP process, so our coordinated entry process, where our case managers present cases when it is flagged when somebody is experiencing or really has very high needs, and we do try to make sure that if there is an opening in a DBH, supportive housing program, that we move them there. So that happens in a coordinated housing process. Just resources are limited, but that does happen through our CAP process. That's one. I'm going to go to 3 because I forgot the 2.
I do have 2.
Okay.
And the two that I have is that our core service agency staff are required to assist individuals who are unhoused to get housing. We have a PATH team that does that. We have our integrated care team, and we have our core service agencies. And so they are responsible for everything from helping them get ID to helping them through the VI SPLDAT, the assessment instrument, and then working with them to get into housing.
And as it relates to child welfare, when a family comes even through Virginia Williams, we are able to already see if the family is connected to CFSA. So the coordination happens in that case. But I think I just want to make sure, like today I've heard many, many times testify that all of these children died and all of these children died in our housing. They were connected to our housing. So this is data that we have. And I've asked my team from fiscal year 24 and 26, 24 and 25, we've had 6 juveniles died in our who were connected to a permanent supported housing program. None of them died as a result of child neglect. So 4 of them died as a result of gunshot wounds, which is traumatic, but it's more based on the crimes that's happening in the city. And 2 of them died of like not natural causes, but like death of cancer and other, so we have to just be careful sometimes to assume that because, a child passes away in a very traumatic situation. And the one case that they've mentioned many, many times, actually, I cannot share those details if that's the case, but we're making assumptions but we look into those cases. We look into those cases and oftentimes it's the assumption that folks are attached to a voucher program and they are passing away because we're not providing the services. It's just an assumption. And because we can't share what we know about cases, we let people have that assumption. But I can tell you about the young people who died in our program, it was not neglect related.
Yeah. No, I know that this is probably one of the hard parts in that there's so much information that we have that we can't necessarily share publicly. To your point, it allows for rumor and innuendo to sort of happen. And then sort of what we talked about before, because I know this is the same situation and it's happening in a building in Ward 4 and other places, right? Like there's assumptions that we're not acting because the person is still there, even though there might be work that is happening. But the process for removing someone from an apartment, from a unit, et cetera, you have an extraordinary bar that you have to reach there. And in many cases, it is like if you're involving law enforcement in those things. And I know that is deeply unsatisfying to folks.
Absolutely.
But I think there's also this other feeling too, that because but for the government support and intervention, that person might not have been there, that we, the government, are taking on some responsibility, some additional responsibility by what is happening in sort of that moment. The numbers that you spoke to are obviously any death is tragic. But when I'm looking at some of the other reasons or the other things, right? Abandoned units. So it was, they just left or other things. But I mentioned earlier the number of deceased, and I was like, okay, well, that could be for a number of different reasons. It could be for natural causes X, Y, Z, but also probably, and maybe given our opioid situation, probably some SUD related pieces in there, incarceration and otherwise. And so, I don't know. I feel like sometimes unfairly, not sometimes, often, and I think we hear it now, even in sort of the national conversation. We're talking about individuals who rely on SNAP benefits or Medicaid or LIHEAP or otherwise. People have this perception already in their heads. And anytime you have one particular incident that occurs, it only amplifies what was already your bias from the very beginning, your already viewpoint from the very beginning. And this feeling as though if you're part of a government program, you have a higher level of standard of how you should be acting in community as opposed to anyone else who might just be living their lives. And it's always unfortunate when there's one incident that happens and now you have labeled everyone else, because we spent a lot of time today talking about our very persistent problem cases, when in fact, the vast majority of people who are part of this program
Do well.
are doing just fine.
Absolutely. Absolutely.
And I think,
And we need to find a solution for the ones who are not doing so well.
yes.
And we believe that too.
So I know that Councilmember Fruman is trying to land this plane.
You take your time.
And this is the fun part, because I engage with Dr. Bazaran often, so we talk about some of these things, but we don't often have an opportunity to bring multiple agencies together to have these conversations. I do feel like there was testimony brought today by some of the providers and otherwise that point to some of the communication gaps and places of opportunity for further coordination amongst the two agencies in terms of sharing information and sharing data and coordination there. I hope we can work on that. The other thing was around the data piece around how we better define who opt out. And I don't know if you caught that in terms of opt out with success versus opt out
Right. Right.
with another sort of asterisk, if you will. Dr. Bazaran will follow up in the I guess that's technically winter, but during performance oversight, let's talk about how the community connections work is going.
Sure.
And hopefully by then, some more people in the with more time, we will have more understanding of whether or not this is actually a successful intervention or not. But thank you so much for your time today.
All right. Thank you very much, Councilmember Henderson. Thank you very much for your partnership in this. I do think I want to underscore also the success of the program in many, many settings, but I don't want to brush off where there are serious issues. And I think we need to be careful not to jump to conclusions and make assumptions, but I think we also need to be careful not to characterize the folks who have raised issues as not being genuine, because I think these are people who really care about their neighbors and who are living it on the front lines. And a challenge becomes what happens, even if it worked 95% of the time and 5% of the time there was a real issue, how do we deal with that? And it gets hard in a system of choice where the levers are limited. But that's part of the challenge that we're grappling with. And I want us all to respect the good faith that we're bringing to this conversation to try to come up with answers. I do think that this has been an incredibly valuable hearing, roundtable. I want to thank Marcia Huff from Councilmember Henderson's staff and Dan Pesson from my staff. I think they've done a great job in putting something together that's really, really constructive. To close it out, to those watching, if you plan on submitting written testimony for the record, please do so by uploading it to the council's online hearing management system before the record closes at 5 p.m. on Thursday, November 20th. The time is now 5:30 p.m.